Hello, Abby, can you hear me? Hello, Abby, you there? Hello, anybody there? Abby, you there? Any technician there?
Good morning and congratulations on hosting the 6th Innovation.
Hello, is anybody there? Hello, can we do a sound check, please? Sound check and video check. Okay, pulling it up now, okay.
Good morning and congratulations on
Okay.
hosting the 6th Innovations in Cerebrovascular meeting. Amazing.
Mic check 1 2. Mic check. 1, 2. Check, check,
Yeah, I can hear that.
check, check. Mic. We can hear. Is okay. I should be back here in this. Not in stream yet. No, not yet.
Okay, you're not televising yet, right?
Knock, knock.
Okay,
Good morning, everybody. Good morning, everybody. We had the pleasure of being here yesterday on our nursing symposium, but a lot of different faces today. So let's pretend that yesterday didn't happen. It's phenomenal to be back. Wendy was quicker than me to calculate how many years we've been trying to do this present session of this meeting. And it still feels weird, right? And I cannot start mentioning the pause COVID without taking a moment to pause to a guy that we lost, a dear guy from Brazil, Dr. Lucas Augusto, a resident from São Paulo that was supposed to come and join us as a research fellow with a brilliant career ahead of him, and COVID took his life at age 32, left his 2 kids and wife and mom behind. We know COVID has changed the way we behave as a society, as a world, but it's so nice to be back and see faces, no masks, that we can congregate and exchange information face to face and see old friends and make new friends. And the goal for the meeting is discussion, guys. So please don't be shy, throw a tomato. I want to talk. The guys that are sitting more on this side, they don't have eyes on the back. So if don't stop talking, we want interaction. We go to bigger meetings. There's no time for discussion. The key, the heart of the meeting is conversations. To be at this nice place with subsidized CME, any other place you would go, you know how much you'd be paying for this, is only possible because of support of a lot of people. And I'm not gonna say names because I'm gonna miss somebody. I'm gonna be unfair to somebody, but this is heavily sponsored by our partners in industry and heavily sponsored by our hospital Baptist health system. So a big thank you to that for everybody that is represented here in the room, for all the team that did all the work behind the scenes with Abby, team, Wendy, and everybody that worked really hard to make this happen. People that are volunteering here. Thank you very much for that. And with that, I will stop and I'm going to introduce you our first speaker. There's our own Dr. Johnson Foy. I don't remember exactly how we got her started on this, but she did a phenomenal job raising awareness for brain aneurysm. September is Aneurysm Awareness Month. So we have here Dr. Johnson Foy that's going to tell us about what every single primary care physician should know about a brain aneurysm. Yeah. Thank you.
Good morning. Again, I'm Dr. Trishella Johnson Foy, family medicine at Baptist Primary Care, and I thank you guys for allowing me the opportunity to be here with you today. I know that many of you are beyond primary care, but hopefully this talk will allow you an opportunity to kind of know how to go back and engage with your other colleagues and those who you're trying to teach or train on this topic. So I have no disclosures other than that today is a day of engagement during Aneurysm Awareness Month. And so hopefully this talk will be engaging for you. The objectives are for us to kind of really define the condition and identify those different types of aneurysms, discuss the epidemiology, and then clarify risk factors, helping your primary care doctors really define signs and symptoms and determine what are the best diagnostic tests so that they may be able to understand management options and then help facilitate providing reassurance to patients who may be dealing with this. Now, this beautiful woman here, many of you may know, some may know her better though, as Daenerys Stormborn of House Targaryen, our great Khaleesi and mother of the dragons and the breaker of chains. However, she faced a different fight not long ago, where she actually at the age of 24 suffered from a subarachnoid hemorrhage during the first season of Game of Thrones. She had 2 aneurysms and 2 brain surgeries, which ultimately were 2 near death experiences for her. Now, this great, beautiful beast is one that many have unfortunately tackled. Some, though, have not made it through. Some have fallen. Many faces that you've seen that you may not have known were actually affected by aneurysms. But that doesn't have to be the story of all. Now, here locally, right around the corner, there's the park named after this woman, Miss Tilly Fowler, who was a up-and-coming politician who based here in Florida, but had made it to Washington. And in 2005, she died from a brain hemorrhage from an aneurysm. So there are many lives that are cut short. So this makes this an extremely important topic. About 1 in 50 Americans have a brain aneurysm that's unruptured. But 4 out of 10 of those people who will rupture will die as a result of it. So this makes this conversation extremely important. When you look at those numbers, that's really about 1 to 3% of our population. And breaking that down further, about 80 to 85% of these result in these non-traumatic subarachnoid hemorrhages. Autopsy studies show that the prevalence in the adult population may really be between about 1 to 5%. And there are some studies that actually show that this goes up to about 7%. And so it can be a little bit underestimated. The good news is 50 to 80% of aneurysms do not rupture during the course of a person's lifetime. So there is this great opportunity to live with this. And that is what primary care physicians need to convey to patients, that this does not mean that they have been given a death sentence. We need to help them understand that this is something that they can live with. Very specifically, though, this is one of those conditions that are more common in women, about 3:1 to 2 ratio of women to men. The problem with aneurysms and why today is important, why this day of engagement, this month of awareness is important, is because although you have 16 to 15 million people in the US having a brain aneurysm, 90% of them know little or nothing about it. So what are the facts? The risk of an aneurysm bursting is less than 1%, less than 0.5% throughout a person's lifetime. But if it does rupture, they cause the most debilitating strokes. But only 13% of strokes are caused by ruptured aneurysms. So what do we need to do then? We need to be able to understand what the risks are, what is the proper radiology to evaluate these aneurysms, when to refer, and more importantly, how to reassure. So before we get into that, I do like to take a step back for a moment and remind some of our generalists what the anatomy is. That blood flow to the brain is supplied by 4 major blood vessels that join together, forming the circle of Willis. You have the anterior and posterior cerebral artery, the internal carotid arteries, and your basilar artery. Now, what is an aneurysm, though? The aneurysm is this weak area of the wall of the blood vessel that causes the blood vessel to either bulge or balloon out. It usually occurs in those areas of bifurcation or where there's a change in the vessel structures, things like AV malformations. Major structural changes in the arteries and hemodynamic mechanisms are what are believed to really be the major factors and forces in what leads to the development of aneurysms. Most people having them, though, will not have any symptoms throughout an aneurysm until it ruptures. And there are symptoms at that time that we want to make sure we pay attention to. And then the repair. What do we do about them when we find them? There are several different types of aneurysms, though. You have saccular, or those berry aneurysms that are quite often known. You'll hear people talking about berry aneurysms. You have fusiform and then dissecting. These are when the actual wall of the vessel are involved and you have a true outpouching or a true bulge of the wall. But there are also what we call pseudoaneurysms or false aneurysms, where there's no true bulging of the actual wall or adventitia of the vascular wall. Saccular aneurysms or berry aneurysms are the most common and are thought to be either degenerative or developmental. There are other potential sources or reasons for it that I will talk about a little bit later. But it's important to have the conversation about these because they're the most frequent cause of these clinically significant bleeds are ruptures. When we look at the circle of Willis and where they most often occur, it's about 40% in that anterior communicating artery, about 34 to 35% in the middle cerebral artery, and about 20% in that posterior communicating artery. But right there in that circle is where you're going to see most of these aneurysms be present and cause most of the problem. Right there in that central portion of our brain is where we have to worry the most about these saccular aneurysms. Now, there was a time when it was thought that these were mostly congenital in origin, but studies after studies have shown that there is really no great evidence that it's congenital or developmental or an inherited weakness in the arterial wall, although there are some genetic conditions that are associated with an increased risk of developing these aneurysms. But when we look at what is truly leading to the development of these aneurysms, it's thought to be most likely related to the hemodynamic changes that cause vascular injury. So the occurrence, growth, thrombosis, and even rupture of these are usually explained more so by these abnormal hemodynamic shear stresses on the walls of these large arteries that are at these weak bifurcation points that are what put people at greatest risk for developing and rupturing aneurysms. Other causes would include trauma or infection or tumors. And then in this time of this epidemic that we live in, drug abuse. So looking at these patients who are currently increasing the use of opioids and heroin, this is when you have to also consider all of these as these great risk factors for the development and rupture of aneurysms and these other high flow states associated with AVMs and fistulas. Now, when we break it down, you have either inherited risk factors or acquired risk factors. Those inherited risk factors, a lot of times we think immediately of just one or two genetic conditions, but there are actually several that are associated with it that I'll get into the more important ones a little bit later. But if you want to refer back to this and really see what conditions put people at risk for the development of aneurysms, this list can be a bit helpful. Outside of the genetic conditions, you have just being born a woman. I've told you that there is an increased female to male ratio, and then family history of aneurysms that are an inherited risk. And I'm gonna go back for you real quick. I saw some other people. And the second screen, we're going to really talk more about those other inherited risks that we got to pay a little bit more attention to. Now, acquired risks are things like advancing age, alcohol consumption, cigarette smoking, that illicit drug use, hypertension, and trauma and infection. Those are things that we have a little bit more control of. But it's important to help people understand that even though they have risk factors, this does not mean that they're absolutely going to develop an aneurysm. There are some people who have multiple risk factors and never develop an aneurysm. And most people who develop aneurysms actually don't show a lot of these risk factors at all. So knowing your risk can be helpful and important. So as their clinician, you need to make sure that you are risk stratifying them. But this is where the reassurance comes in, and this is where being diligent as doctors come in, is that we make sure that looking at the risk, but putting it not in a prescriptive matter where we just are saying this is what's going to happen to you, but helping people really kind of understand, just like you would do with any other disease or condition, what their risks are. Now, there have been some genetic testing that has been available to look at what people are going to be most likely to rupture. So there's one thing to have an aneurysm, but then what is your true risk of rupturing if you have it? And so there are some studies that look at the genetic makeup of some of these patients to clarify, is there something that is going to make a certain group of people more likely to rupture? So there has been some chromosomal associations that have been noted and found. But it's still not something that we can definitively put our fingers on. There are many studies that have been done on looking at what the natural history is, but we still don't know. So how do we stratify? How do we provide reassurance when we don't know? There is a way to look at a patient and give them a score, and this is called the phases risk score. where we look at a group of potential risk factors and determine the likelihood of rupture. Now, this you can see is a long list that I won't go into in detail, but what is more important is when you create a score, when they develop a score, the higher that score is, the more likely they are to rupture. So if you have someone who you know has an aneurysm, this is your way of walking them through what their potential risks are. So this phases risk score, and allowing this to guide your management with them and allowing them to be able to understand how diligent they should be with follow-up, what types of things should be done, when to refer. These are the things that allow us to kind of move forward. Now, there are going to be a certain subset of your population, certain patients that you really need to pay particular interest to, and those are people with polycystic kidney disease, AV malformations, and fibromuscular dysplasia. It hasn't been that long that we really begin to understand the risk of fibromuscular dysplasia, but we know now that there is definitely an increased risk of these patients being more likely to develop these aneurysms and have potential ruptures. Family history, however, studies show that it only predicts the likelihood of developing an aneurysm, but not necessarily the risk of rupture, which is again why we need to look at all of this information together to decide how we want to proceed. So then who needs to be screened? Who are the people that we really should be sending for scans? If there's a person who has 2 immediate relatives with intracranial aneurysms, then those are the patients that we need to send for scanning. There's a 4% risk if there is 1 family member, but then that increases to an 8 to 10% risk if a person has 2 or more family members. All patients who have polycystic kidney disease that are of autosomal dominant variant should be sent for screening and should be sent for evaluation because they are at a higher risk of development. But we live in a world now where regardless of what the doctor says, patients have the ability to go and have genetic testing. And they go and they get these screenings. And the question is, what do we do with it? How do we help them through this? How do we help them understand what these genetic information means? So we have to, again, provide that reassurance and that confidence that although these tests are available, although these tests can be done, it does not really allow us to understand what your risk of rupture is going to be or your true risk of development. So just like with the rest of the conditions we're dealing with, people having this information available can sometimes complicate our lives as physicians, but we can use it to help them through what they may need for helping them understand their risk overall. There are some studies actually that show aspirin being something that when we think about subarachnoid hemorrhages and bleeds that we should stand down from. But for those of you who are neurovascular and in this conference likely have an understanding that there are some studies that show that the rupture risk is actually reduced in patients who take aspirin. And so there was a large meta-analysis done about 2 years ago that also spoke to this. And so what we don't completely understand is why that risk, and it's thought that it may be due to the anti-inflammatory properties of aspirin, but we're not sure. It's still something that you want to individualize when you talk to patients and really get clarity on what might be right for them instead of just blanketly putting everyone on it. So as primary care providers move through taking care of these patients, they want to be clear that they're making the right decision for that patient and not just what is new to do at this point. Looking at your patients is not just about what is internally going on inside them. We know that genetically there are going to be some groups, the same way we know women are more likely to have aneurysms, Black women are more likely to actually have ruptured aneurysms. So you want to make sure that you are being diligent and expressing to your women who are of African-American descent or African descent that they may have a higher likelihood of rupturing, so that follow-up is going to be one of those things that are important. Because if you remember, most people don't have symptoms. But when they do have symptoms and warning signs, we need to pay attention. We need to make sure that we are following the signs. So what are some of those things that you have to look out for? Well, if they're presenting with severe headaches, this would be something that you want to make sure you're doing your due diligence, looking for aneurysms. Seizures, light sensitivity, double vision or blurry vision, face pain that may be an unusual presentation, or if they're having small embolic strokes, you can have those coming from a thrombus in an aneurysm. Visual field defects that you don't necessarily have an explanation for is a reason for us to make sure we're looking for aneurysms. And then TIAs, a dilated pupil that is has all of a sudden developed that may be unexplained, maybe is a reason to go ahead and investigate. There are many misdiagnoses when it comes to ruptured aneurysms. People present to the emergency room, and unfortunately, oftentimes they are not scanned appropriately. So we want to make sure that as we're training our physicians and training our ER docs to know what things to pay attention to so that they scan the right people so that these patients don't end up dying from something that is presenting. We know that it's very important to diagnose these things as early as we can. So what studies should we be ordering? Well, CT angiogram, MRAs are the scans of choice when it comes to monitoring and evaluating for unruptured aneurysms. And I'm sorry, what is the gold standard is actually going to be angiography. But what is often easier and quicker to do in those moments are going to be your MRA or your CTA. So with the CT angiogram, it's very accurate, it's high resolution, and it has a sensitivity of about 97% or 77 to 97%, and a specificity of 87 to 100%. That sensitivity does drop when you have those smaller aneurysms, and smaller being less than 3 millimeters. You are limited in patients who have impaired renal function, so then you have to consider alternative ways of looking. The MRA also has great sensitivity of 70 to 99% and a specificity of 100% for aneurysms that are 3 millimeters or greater. But again, that sensitivity diminishes for those smaller aneurysms. Oftentimes, though, we don't have time to get the MRA right away, so it becomes important to do the test that is available so that you can do your monitoring. Now, a catheter angiography, whether it is with or without advanced 3D capability, is the gold standard. It's more expensive and a little more invasive. However, this is what is going to give you the greatest bang for your buck. This is where we make sure that we get into our great neurosurgeons who can really guide these patients and take care of these patients. And then this is handoff time. This is when the management is done. Initially, depending on the patient, conservative management, just like with most things, is oftentimes first and foremost. Those people who are in dire need will move beyond that, but patients who are usually over the age of 60 and have small aneurysms, except for those with a strong family history, are usually managed conservatively. But patients with aneurysms 7 to 12 millimeters diameter, that management again needs to be individualized. So looking at a patient and stratifying their risk, the likelihood of rupture, using those phases score, that will help you decide how to manage these patients. Now, this goes beyond primary care. So the most important part was 3 slides earlier, where we get them referred to the right people who will decide how to manage them. They will consider the proper interventions, and those interventions being either coiling or stenting with coiling or clipping these aneurysms. This is something that my neurosurgeons will decide for me. I don't have to make those big decisions. Primary care doctors don't have to, but what will happen is the patients will come back and ask their primary care doctor. My patients are very particular, and even though there are bigger brains in the rooms that talk to them and tell them this is what they're gonna do, they're gonna come back and say, well, Dr. Johnson, what do you think? And so you have to be prepared to make sure that you are adept with answering the questions and reassuring them that you put them in good hands and that the right management plan and the right strategy is being developed for them. But the biggest thing that we can do as doctors for our patients is provide this reassurance for them. We've talked about the overall potential risk of rupture being less than that 0.5%. So how do we allow people who might have heard of someone or who know someone that they died immediately from a ruptured aneurysm? How do you help them feel comfortable with there's this aneurysm in their head? So it's about how you, one, provide them the reassurance with the delivery that you give. How do you explain it? How do you tell them that this is what's going on? But although we don't know the potential, the likelihood of risk, here's where you stand. Here's where you are. That reassurance, putting them at ease, encouraging them about living their life so they're not walking around with this doom and gloom sensation. That is what your responsibility as a doctor is. Making sure that you say it in a way that they're able to just live their life. Also plugging them into the proper resources, helping them to connect with people and resources that can walk them through this. If they have had family members who have been, who've had aneurysms, or friends, if they don't know anybody, this is an opportunity to make sure that they're in the right support groups and have the right awareness. Letting them know that they can live their best life no matter what. Showing them examples of people who we know are strong people who are living and doing and being prosperous. These are the examples that we want to allow them to see, that survivorship is real, that living with this condition is something that does not have to be the end of them, unless they go crazy and burn a whole city, and then they have to be killed by Jon Snow, and it's over. So, any questions? Thank you. Oh, go ahead.
First of all, Dr. Johnson, Faye.
Boy, like
Foy,
joy.
sorry, I said John. First of all, thank you very much for the excellent overview and presentation. I
Thank
really enjoyed it. You mentioned one of the scoring system that our colleagues use, the phases. There's another that recently was published, it's called UIA. And some of the colleagues who are sitting here, they're authors on the paper. So it's really a famous paper that the FDA uses. Now, the problem is with the demographic shift that we are getting older and older. And you mentioned 70. I feel a little bit worried, but anyway. So the point I wanted to make is, since our life expectancy moving towards 100, and there was paper coming out of China that show the older you get, the likelihood of rupture, it goes up. That's
Yes.
one thing, even if the aneurysms are small. The second thing is, once you rupture and you are older than 80 or 90, the outcomes are bad. And they found also out when you do endovascular therapy, this minimal invasive that Ricardo and his colleagues do here, that the outcomes are better. So when you see today a patient who is 70, has a 3 millimeter aneurysm, what do you tell to the patient? If the patient is not nervous, or a patient who is super nervous, and every time he has a headache, he thinks something is going to blow in his head.
What do I tell him? One, I make sure that I keep close touch on him. It's one of those things. The fortunate thing about primary care is I can see them every week if I need to. I can see them as often as I need to. I make sure that they're connected with the great neurosurgeons who I trust to take care of my mom or take care of any other patients. But I let them know to live their life, to make sure, because if they've made it to 80s and 90s already, then they've been living a pretty good and prosperous life. So I tell them to keep living, and that there are things that are available that may ultimately decrease their risk, or that things we can do, but I tell them to keep living, and so that they can have the best life that they can. Go ahead.
One of the comments I wanted to make is actually tomorrow we'll talk about some tools that allow us to check using artificial intelligence if the aneurysm is changing over time. So like, it's interesting that you mentioned the follow-up, how to do those images. Obviously, I think what we're trying to talk about today is like, how do you counsel somebody that has an aneurysm? But part of giving peace of mind may be that we do have ways to treat minimally invasive, but at the same time, we also have better ways to monitor the aneurysms too, and have the ability to detect if there's a change in aneurysm shape or size. And I think that is really also a really important part of it. Smoking, high blood pressure, and emphasizing those things, it's something we do quite often too. And I think that this is, I think tomorrow we'll be able to go over and show exactly how we're doing this in practice today too.
Good. I'm looking forward to that. And as any modifiable risk factors, I'm always going to encourage that we talk to them about, and that we make sure that they are able to focus in on those things, and that we keep the blood pressure controlled, that we definitely make sure that they're not smoking if they're smokers. But again, more importantly, getting in and making sure that we're staying on top of it. The imaging is done, the follow-up is done. Those are the things. So I'm glad that we have this availability of mechanisms to make sure we're following appropriately. Dr. Hanna.
Thank you. Always very educational and inspiring. Not every single, with all the respect to the others, not every single primary care physician has the same knowledge and into brain aneurysms like you do, Traquela. My question to you is, I go to my primary care physician, I'm going to be asked prostate cancer in the family, colon cancer in the family. You talk about guidelines that is very generic. If you read the guidelines from American Heart for screening, is very soft, so soft that if any new patient come to a Baptist or any other hospital, there's no there in screening, do you have any brain aneurysms in the family? So trying to raise awareness, we got funded by the state of Florida, and we're screening anybody that has first-degree relatives, just to show what is the scoop of that picture on Florida, South Georgia. But why we don't ask our patients that go see a primary care physician, fibromuscular dysplasia, if this lady has fibromuscular dysplasia, it's 4X, and these people are not getting screened. If you have 2 family members with brain aneurysms, these people are not get screened. Why at Baptist we don't put a little task force and change our screening on new lovely Epic? Why we don't have brain aneurysms in the family, yes or no? That would spark a conversation with the primary care physician to ask, who had an aneurysm? Oh, my great grandpa. Okay, you don't have to worry about that. My mom died and my sister had one. So what would take is that American Heart guidelines, is stronger endorsement. From your perspective, what it would take to get this screening question on every single primary care provider in the country?
So for every single provider in the country, I think one of the things that we just have to do better in general is take a good family history in general about it all. It is literally the biggest fight that I have with my staff. They leave it blank for everything, whether it's diabetes, high blood pressure, cancers, or definitely aneurysms. So really starting with retraining from the basics of asking real family history questions is going to be one of those things. If we just do that part right, that's the start. Now, when you talk about guidelines, it has to be something that usually is going to be passed down. The United States Preventative Service Task Force has to say, hey, this is important, so do it. The CDC has to say it's important. Some body, the American Neurological, we need to make this a more generalized screening. And if that is the case, then I think you'll see a broader representation of it. For me, as a primary care doctor, I just want a good family history no matter what. And so I do ask them those questions, and I pounded my staff, ask the questions, ask the questions, ask the questions. So if we can have generalized at Baptist, what we could do, I'm looking at Mr. Zuino, what we can do is make sure that we're training MAs in a way, because they're doing a triage, they're doing an uptake, making sure that they're trained in a way to understand the importance of family history. They do not completely get it. And it's because there are so many things that they're thinking about and worrying about and making sure they're checking every box in Epic. But family history is extremely important. And when I say this is a daily fight with my staff, it is something that I have worked really hard to make sure they do better. And so we have Liz Collins in place who can say, train these people this way so that they're doing the right screenings, so that we may catch these people for our great our neurosurgery department, so they'll have some more people to take care of.
Thank you.
You're welcome.
Any more questions?
Any other
guys?
questions? I was trying to be brief, so.
No, it was perfect. Thank you very
All
much,
right,
as
thank
usual.
you.
Thank you. A big plus from the COVID crisis is this situation that you can be in places that you are not. And Professor Ansar Rai is a dear friend from West Virginia University. Unfortunately, last minute could not be with us physically, but he was kind enough to be on a Zoom link with us. So I don't know, Ansar, if you can hear me. Thank you, brother, for being with us and in the spiritual and on Zoom. We're gonna watch what he recorded for us, and then we're gonna discuss intracellular devices, myth or reality. Can we play Dr. Rai, please?
Invitation from Doctors Anel and Savajo and the organizing committee to speak on the topic of intracellular devices. These are my relevant disclosures. Briefly going over the terminology of cerebral aneurysms for any in the audience who may not be familiar with it. Morphologically, the aneurysms can be divided into sidewall aneurysms or bifurcation aneurysms based on where they occur. The aneurysms can be further divided into a narrow neck or a wide neck based on the ratio of the widest portion of the aneurysm to the neck of the aneurysm. So this, for example, is a narrow neck aneurysm, sidewall, wide neck sidewall, wide neck bifurcation, narrow neck bifurcation aneurysm. And this may have implication on cerebral aneurysm treatment. The most common and widely used treatment, and certainly the first to be adopted, was primary coiling, where coils are placed inside the sac of the aneurysm. And this works well for narrow neck aneurysm. But for wide neck aneurysm, we use adjunctive devices such as permanently implantable stents or temporary balloons to keep the coils inside the aneurysm and prevent them from prolapsing in the parent vessel. More recently, we use intraluminal flow diversion, which is essentially a stent with a very thick mesh or a dense mesh that diverts flow away from the aneurysm, so we don't have to place anything inside the aneurysm. And even more recently, we have been using intracellular devices that disrupt the flow and prevent the blood flow from coming in the aneurysm. That's the topic of the current presentation. If we look at trends in endovascular treatment over the next, say, 8 to 9 years, we see a fairly flat growth curve for primary coiling. This is based on industry data. Slight growth in coil-assisted devices, flow diversion, but relatively more growth in intracellular devices, which indicates an interest not only on the part of the physicians, but also the industry. When we look at our own data at our own center at WVU, Rockefeller Neuroscience Institute, over the last 12 years, just over 1,200 aneurysms divided into pre or post 2019. And this year was chosen because that was the first time an intracellular device such as the web became commercially available. Pre-2019, the majority of the aneurysms we treated were internal carotid artery sidewall aneurysms and basilar apex aneurysms, which reflected the early adoption of endovascular techniques. Post-2019, we see significant growth in MCA bifurcation aneurysms, and the most common aneurysm we treat is an ACOM aneurysm, endovascular technique. This constitutes 40% of the aneurysms that we currently treat are ACOM or MCA bifurcation, which were previously getting clipped, but now because we have more intracellular devices available, such as the web, these aneurysms can be treated. And this reflects the disease incidence in terms of what aneurysms are more common, Certainly, ACOM is the commonest aneurysm and the most common aneurysm that ruptures. So now at least our endovascular techniques are matching the disease incidence. In terms of the types of treatment used, we can see that the most common treatment that we used pre-2019 was primary coiling, which is now 33%. And we see a significant growth in this area, which is intrasaccular web device and flow diversion, which accounts for 40 to 40% of the techniques that we use post-2019. So not only we're treating the more common aneurysms, we're treating flow diversion and flow disruption. Overall, intrasaccular devices have led to increase of volume growth of 25%. Majority of these aneurysms are bifurcation. Certainly, we are treating more MC and ACOM aneurysms. And this has also had a positive impact on our procedure variables. So for similarly sized wide neck bifurcation aneurysms treated with stent-assisted coiling or web, we see that our procedure operating room time has significantly decreased from 4 hours to 2.5 hours from stent coiling to web. The anesthesia time has decreased from 3.5 hours to 2 hours. The procedure time defined as arterial sheath access to removal has decreased from 2.5 hours to just over 1 hour because the procedure times are shorter. The radiation time and duration and the radiation dose has also significantly decreased with the use of web versus stent-assisted coiling. We compared the cost of treatment between web, stent coiling, and coiling or bifurcation aneurysms. And these were similarly sized aneurysms in terms of height, width, and volume. And the cost of stent coiling is certainly more than coiling because we are using not only coils, but also stent, which adds to the cost. The web device comes in just at comparable to stent-assisted coiling. It's certainly more than primary coiling, but it's important to note that with the size of the aneurysm, as more coils are deployed, this cost can increase, whereas the cost for the web remains fairly consistent for aneurysms up to 11 millimeters. With that, we come to our first case, which is that of a ruptured right MC, a bifurcation aneurysm in a 50-year-old lady, which was treated with primary coiling. She also had a complex MC bifurcation aneurysm on the left side, which was offered surgical clipping, but she did not show up for the surgery, and then COVID happened, and this is the angiogram 18 months after the aneurysm was first discovered. This shows a significant growth in the aneurysm with a very irregular morphology, with a very wide neck incorporating the branches of the middle cerebral artery. So our plan was to stage the endovascular procedure. We again went over the surgical option, which she didn't want. At the same time, web became commercially available. And our plan was to stage the procedure with treatment of the dome of the aneurysm with the web, and then retreat the neck of the aneurysm, reconstructing with stents and coils. So here is the first stage of the procedure. Microcatheters is inside the aneurysm, and you can see the web device coming, which is sheathed inside the aneurysm. And when it comes out of the aneurysm, it takes this expanded shape. So here we are delivering the web in the aneurysm. I'm obviously going at a faster pace than we actually deployed the device. After the device is deployed, we do an angiogram which shows stasis within the aneurysm. And after the device is detached, the final control angiogram shows that there is stasis within the aneurysm, but more importantly, the parent vessels are patent. At 3-month follow-up, we can see that the part of the aneurysm where the web was placed is completely occluded. We can see the residual aneurysm with the MCA branches. Again, unfortunately, because of COVID, we went on diversion. Patient could not be treated for another year, at which time we saw that the aneurysm had actually grown in the untreated component. This shows the complex morphology of the residual aneurysm incorporating both middle cerebral artery branches. So our plan was to do stent-assisted coiling and with a Y stent technique to cross the neck And anytime we do Y-stent, we always catheterize the difficult branch first. Here you can see the web is acting as a backstop, allowing us to catheterize the more complex inferior division. And once both microcatheters are placed, we remove the wire and we're deploying the first stent in the inferior division, covering the neck to the middle cerebral artery. So as the stent is, in this case, an atlas stent is unsheathed from the inferior division to the mid M1 segment. Then the same catheter is used to access the aneurysm. And the second microcatheter and wire is used to access the inferior division. And a second atlas stent is deployed. So now we have a stent in each branch, and you can see the overlapping stent in the M1 segment. We do a DynaCT to confirm the position of these stents. So you can see both stents protecting the bifurcation branches and crisscrossing across the neck of the aneurysm. Now that we have both stents in place and the web previously placed, we can coil in a fairly standard fashion. So here you can see the web, the coils, and the stents. And after the aneurysm is coiled, you can see the underlying middle cerebral artery and the M2 branches with a fairly decent protection of the aneurysm. This is the control angiogram. This is the 3-month follow-up angiogram showing complete occlusion of the aneurysm, and the 6-month MRA confirming the occluded aneurysm and the patent vessel, and you can see the other treated aneurysm on the left side. So this is an example of using these techniques together because these are not mutually exclusive. This is an interesting case of a 60-year-old gentleman with diffuse subarachnoid hemorrhage, and the patient had 4 cerebral aneurysms, 3 on the right side, right MCA bifurcation, and the right internal carotid artery terminus, and an anterior communicating artery aneurysm. The patient had another aneurysm on the left side involving the proximal M1 segment. So the plan was to treat all 4 aneurysms in the same setting. This is the treatment of the first aneurysm, which is the ACOM aneurysm at the right A1-A2 junction, with deployment of a small web using a 17 microcatheter. The web is deployed and detached, and the same microcatheter is then utilized to access the internal carotid artery terminus aneurysms, with deployment of a second web through the same microcatheter. This required a little bit of manipulation, but intrasaccular device was placed with good coverage of the aneurysm, confirmed with rotational angiography. Here you can see the device and the paired vessel. This is the web, this is the ICA terminus. This microcatheter was removed and a larger microcatheter was utilized to access the right middle cerebral artery bifurcation aneurysm, and an SL8x3 web device was implanted. So now 3 aneurysms are treated. On the right side, you can see the middle cerebral artery bifurcation aneurysm, the internal carotid artery terminus aneurysm, and the ACOM aneurysm. After detachment of that device, then the 4th aneurysm in the same setting is treated with a 4th small web device. And so this allowed treatment of all 4 aneurysms in about 45 to 50 minutes. You can see the occlusion of the aneurysm on the angiogram almost immediately, and also occlusion of the right middle cerebral artery bifurcation aneurysm, ICA terminus, and ACOM aneurysm in the same setting. I will skip over the next case. This is an example of a similar complex bilobe aneurysm that was treated utilizing web. Traditionally, we treat them with stent-assisted coiling or primary coiling, perhaps. But in this case, we deployed a web in the first lobe use that web to deflect the microcatheter into the second lobe of the aneurysm. So here's the first web deployed. We utilize the same microcatheter to access the second lobe and deploy a second web braced against the first one, as seen here, and do the angiogram, and we can see that the both the lobes of the aneurysm are occluded with significant stasis in the cerebral aneurysms. Despite web being a great device, and it has certainly transformed our practice, it still has a 5-year retreatment rate of 18%. And for this reason, we think that there is obviously room for improvement and possibly room for other devices. One such device is the Trenza device, which is a braid created with nitinol and platinum. It's not a single implant, but rather acts as an intracerebral scaffold for wide neck aneurysms, both side wall and bifurcation. This is what it looks like when looking from the blood vessel into the aneurysm. This acts as a frame, followed by placement of these platinum coils. This goes through a microcatheter, which is similar sized as VS17, but has a larger inner diameter. These are the types of aneurysms that have currently been treated with this device in a clinical trial setting. The European trial is called the TREAT, and the US study is called Citadel, and the Baptist is a site for this study, and Dr. Hanel has treated several patients. So this is an example of a case where the device was used. Because this is still under clinical trial, I cannot show the actual results of the treatment. I can show a replicated flow model, and just to give you an idea of how the device behaves, basically the device can be deployed and redeployed as many times as needed to create an intrasaccular frame, after which traditional coiling can be performed. And so here this has maintained a frame inside the aneurysm, following which the coils can be placed. Traditionally, we treat an aneurysm like this with stent coiling, but having the frame inside the aneurysm allows us to avoid placing a stent inside the blood vessel, which may need antiplatelet therapy. This is a case that has been treated in Europe, and because the device is approved there, I can show the follow-up data. This is a wide neck bifurcation aneurysm at the anterior communicating artery. The Trenza frame has been placed, which results in significant stasis, followed by placement of multiple coils to complete the aneurysm. This is where the procedure was stopped. There is still some filling in the aneurysm, but on the 6-month angiogram follow-up, there is complete occlusion of inflow into the aneurysm. This is another example of a wide neck left ICA terminus aneurysm. This shows the deployment of the first Trenza frame. And you can see it comes out just like a coil, so it's fairly easy to use. Once the regular frame has been placed, then this can be followed by placement of standard coils to complete the aneurysm occlusion. This is what it looked like on the final angiogram. Another example of a wide neck right ICA terminus aneurysm. The first Trenza frame has been placed with stasis inside the aneurysm, followed by traditional coiling. So the hope is that with the ease of use and durability of treatment, this can add another technique, another tool in our inventory to treat these aneurysms. The last device that is currently undergoing clinical trial is available in Europe, is called the Contour by Sears Endovascular. And again, Baptist is a part of the trial, and Dr. Hanel has done some of the cases. This is similar to a web in terms of its makeup, in that it has a braid that acts as a flow disruptor, preventing flow from coming inside the aneurysm. It's designed to treat a wide range of aneurysms. This is a case courtesy of Dr. Tufel Patanka from Europe, treatment of a wide neck right MCA bifurcation aneurysm. and another left MCA bifurcation aneurysm with the contour device. So in summary, intrasaccular devices certainly can expand the scope of endovascular aneurysm treatment, as I showed from our own practice, that this has allowed us to not only increase the volume of endovascular treatment, but also actually follow the incidence of the disease in terms of aneurysm location. Ease of use and durable aneurysm occlusion are key factors in adoption of new intrasaccular devices. There are several new intrasaccular devices in the pipeline and will likely emerge in the next few years, given the interest in this technique as shown by the projected future trends for this therapy. I will stop here and take any questions. And again, I appreciate the invitation and congratulate you on a phenomenal meeting. Thank you.
Do we have Ansar on Zoom?
Yes, I can see the screen. I don't know if you can see me.
Is there any way we can put Dr. Ansar beautiful face on the screen? You like that, brother?
Yes.
Thank you very much. Any questions here on the audience? Here, AJ.
Ansar, thanks for the beautiful presentation. A question. You have neurosurgeons who still clip aneurysms. With all the newer technologies, especially for bifurcation aneurysms, like the web, like the Ceros, the contour device, and Trenza, where is the role of an open surgeon who does clipping? Where do you see, why would you hire a surgeon who does only clipping nowadays? Just provocative.
Yes, so I hope you can hear me.
We hear you.
Okay, that's a good question, and I was asked that previously by an endovascular neurosurgeon. I think Ricardo may be better suited to answer that. I don't think there is role for just an open vascular neurosurgeon. I think these days, in the current environment, a neurosurgeon who does vascular neurosurgery has to do endovascular. And, you know, there's dual trained neurosurgeons, but I think the bulk of their practice as it pertains to neurovascular procedures is shifting towards endovascular. Our practice changed considerably. We have very good open vascular neurosurgeons, and they were clipping a lot. And we were a conservative place, but the shift happened we were part of the WebIT, and I think the shift started to happen after that. They're heavily involved in the care. They saw the result. We are probably now a little bit more skewed towards endovascular, and we have endovascular neurosurgeon now, starting next few months, trained here, but we do endovascular in probably 95% of our cases at this point. And I don't see that trend reversing. I'll probably let Ricardo and Demetrius and other endovascular neurosurgeons speak more to that, but that's my assessment.
I think the tricky part here is, and we see this all over, a lot of the young generation of people being trained in endovascular, they're called dual trained or endovascular neurosurgeons. They're not proficient in clipping an aneurysm. Like the MCA aneurysm, that was my question to you. The MCA that you web, and definitely we saw the shift in our practice. I think you can discuss durability of web, but if you look at WebIT and others, the safety profile for the treatment is phenomenal, very low risk. But if you put that plus the Y stent assisted coiling, and you put both together, you saw 18% retreatment rate. So 1 in 5, you're treating this patient again. And the retreatment is going to be Y stenting or flow diverter. So this is something that would be great to discuss. But there's no prospective data on MCA, but it's a pretty darn good procedure. Clipping works really well. The question is when to indicate that. I think that becomes the tricky question. And the proficiency of people doing that, I think, is decreasing. because the number of endovascular, you just said that at your shop with the web, the shift of MCA happened there. I think it's great to have people dual trained, but a lot of the dual trained are actually endovascular. They're not microsurgeons. And that's a problem because then if you're not comfortable with the technique, naturally you're not going to do the technique. So it's a problem.
And sir, I think on the same token, it's interesting. We have so many new technologies, and there's a learning curve, of course, for each one of them, and how you incorporate that without. We all want to have, let's say, a best assessment of what is the best modality to use for an aneurysm treatment, and maybe perhaps another way to look at this is post-treatment. While you can still change, can you assess the likelihood of occlusion long-term? So we're about to give a talk on intrasaccular or intravascular imaging. So using tools during the procedure that can allow you to have a predictive value if that treatment is going to have a durability we expect, and if not, to change that based on how much you cover the neck and so forth. So I think we're going that direction because it looks like we may have different solutions to the same problem. And then we just need to figure out if the most effective one.
Yeah, I agree. I mean, I think these are tools at our disposal. I'm not dogmatic about one being solution for everything. I think there's opportunity to be creative and to use all available tools. I certainly don't think that endovascular alone is a solution for everything. And here we have had cases where patient has been referred, we've seen the patient in the clinic, we do the angiogram, and I don't even attempt to treat it after I look at it in detail and the patient gets clipped so I think these are complementary treatments. And to Ricardo's point, he's absolutely right. The dual trained endovascular neurosurgeons are predominantly endovascular practitioners, and I hope that in some way or shape we can retain the skill set for microsurgery, and maybe that will evolve in the coming years. But the trends are shifting. Thank you. I wish I was there. Two of my colleagues are out with COVID, so I'm stuck covering.
Thank you, Ansar. I really appreciate your time, and we'll have you back in the afternoon. I didn't have the chance to say thank you naturally to all the faculty that took time of their busy schedules to be with us physically or over Zoom. Really appreciate your time. And for everybody, Dr. John Bennett and Neurosurgical TV, that are doing live streaming of this for whoever wants to be with us. Upsides of COVID, everything in life, right? Two sides. Thank you, Ansar. We're gonna move to our next speaker. Is my dear brother from a different mother. If you don't like anything that you do, blame him, because he brought me to the United States. So he's right here. You can talk to him about that. Dimitris Lopez is the head of the cerebrovascular program at Advocate Aurora Health in Chicago. I don't even know how many hospitals he coordinates on that system. He's going to talk to us on his first talk on the present and future of intravascular imaging. Thank you, Dimitris, for being here.
Well, thank you. Regarding bringing Ricardo, that's probably one of the best investments we made. It was, it's a long story how we met, but maybe tonight we'll talk about that. But the topic today, I really appreciate the opportunity to share with you an update on this. Overall, intravascular imaging is something that I would say is a new frontier in the neuro field. If you think about today angiography and all the image that we get, the CTA, non-invasive CTA, MRA, and then now we talked earlier in the talk of the gold standard being angiography. But I imagine that this has been the limiting point perhaps for us for many years, because we reached a certain level of information we can get with this type of imaging. And I would say that we need to explore a little bit extra. Can we get more information if you go and start obtaining image from inside of the blood vessel? So there are different modalities to do that. You may have heard about IVUS, which is using ultrasound inside of the blood vessel. And there is another one that these are the collaborators of this group for development of the new light-based intravascular imaging. So you're not using ultrasound. Now you have a catheter inside of the blood vessel, and using a light source, you can actually develop images that are at almost like a histological view of the blood vessel wall and the structures inside of the blood vessel, and perhaps even outside of the blood vessel. So why this type of modality, optical coherence tomography, which is a light-based intravascular imaging, is important? Well, circulatory diseases are really important have a huge impact in our health. So if you look at ischemic disease of the heart as well as the brain, these are incredible numbers of patients that get affected on this. And perhaps we don't have the knowledge needed to have a bigger impact on this, even though all the technologies you saw earlier are creating impact on aneurysm, on stroke, and this is undeniable. But we need to go further. And I think here is what this new concept of developing optical coherence tomography beyond or what we had already. This technology is not necessarily new, but what I'm going to talk about today is very new. It's called high frequency OCT. So this is now the ability to develop a technology that can go into smaller vessels. Can actually, one of the main issues about this concept is that you have to eliminate the blood from the blood vessel to obtain the image. So the only way to do that is by injecting contrast or saline and removing the blood from the blood vessel. So the fastest you can acquire the image, less time you have to eliminate the blood from the blood vessel. So that was in the neuro field. Because of Circo-Willis, we have a lot of collaterals and blood coming from different directions. So imagine that if you're trying to obtain an image inside of a blood vessel, inside of a Circo-Willis, you have to account for eliminating the blood coming from different locations. And to do that, it's important to have good catheters. So we have seen that over the years. The intermediate catheters that we have today are incredible to be able to do this. The other thing is the speed of the pullback became, with this technology, much faster. So this is why it's almost like all the stars are aligning. It's not only about developing a good OCT catheter technology, but it's also everything that's coming around to where we are today, intermediate catheters, and the ability to have certainly new concepts. And one of the concepts that was important was not to develop only an imaging catheter, but there is something called physioanatomy, which is the concept of having not only an image of the blood vessel, but also the physiology, looking into different pressures, for example, pressure gradients with the same catheter. So I think this is really something that will revolutionize the way we see, bringing us to more information, not only anatomic, but also physiologic. And this is kind of the evolution. If you look at the two lines of imaging, physiology and anatomy, or two lines of information we receive. So something called FFR is also incorporated in the scatter. So in blue, you see these two families or these two lineages of physiology and anatomy finally now all together in one catheter. In one system, you can get the imaging as well as the physiology of that vessel, and this adds value. So today, this project of high frequency OCT, it has basically 3 catheters. We have the clearance already for cardiology. It's called the VIS-RX. So this catheter is available in Japan and the United States today. And we have the FFR coming, and VIS-M is going to be something we'll talk about. That's the neuro OCT. That's the first time we're talking about OCT having actually an FDA approved product for this type of imaging. Now, why this is a big deal, let me try to be very clear that some of the limitations, the commercially available OCT is on the left side, is the Abbott product today, and that's in the right side by Gentuity is this HF OCT. And this is the coronary catheter, but it gives you an idea of the differences that they come now in a smaller profile. So you're going from 2.7 French to 1.8 French. What that allows you to do with that, plus the pullback and the quality of the image being better, allows you to cross lesions that were impossible to cross before. And you can obtain imaging pre-lesion, during the lesion, and post-lesion. So imagine looking in plaques that you couldn't cross before. Now you can because of the profile of this device. There's another interesting point talking to the initial experience with this system. The cardiologists that have used, they tell me that they're using much less contrast to be able to clear the field. So with a few cc's of contrast, you're able to obtain an image that in the past, first of all, you couldn't even do it. So there may be even savings on the amount of contrast you need to clear the blood. This is the indication that has been approved for. So now you're going from 1.3 to 6 millimeter vessels. This is an image that we were limited before. We couldn't image to that width as well as to the size or the tightness of the lesion. In this case, including the ability to go into the left main is a big deal for coronaries. So this experience is happening, and a lot of the things that have also been incredibly positive is how easy it is to use. So this is actually in your Angel Suite. You can see the console is attached to your table. You literally just hand off the cable and connect to that console, and you're able then to get your images, and you can actually have side by side with your angiography a co-registration, which is really powerful. So we have published some of the initial experience with the neuro system and some of the concepts of how this can be used. And now I think probably the most interesting part of this is what happens with this imaging. Look at the right side, the ability to see, this is actually a cadaver basilar artery. The little light source that goes from PCA to the basilar is actually showing you how that light is traveling inside of the blood vessel, and that's how the image is being acquired in the catheter. I'll give you more details on that, but look at on the images of the blood vessel, you can see the different layers of the blood vessel. This is impossible to see with current angiography. You are only seeing the shape of the lumen, but you're not seeing the wall of the artery. So this is information that would be incredibly helpful to us to understand some disease processes. This is what it takes. You have the console and the catheter, and this is the size. If you are familiar, some of the procedures you just saw us going into a blood vessel to place the web or the stent, this is exactly the wire there. You can see the synchro wire 14. This is the familiarity is very important. So to be able to develop a device that feels very similar to what we do today is key for the success of neuro OCT. So imagine that not only you're using a device that are very familiar with the size and can go into locations like MCA, anterior cerebral artery, and by placing this device there, you have a ability not only to obtain imaging, but perhaps down the line, physiological information of the vessel flow. Now, the other thing that is being developed is the ability to, is the concept of how to use this best. Do you deliver this directly? Do you go with a microcatheter and put inside of the microcatheter? We'll talk a little bit more about this, but the key part of this is that the materials that this is being made are very familiar to us, and it shouldn't be a tremendous change on how we do this type of procedures. One of the issues that we had before was, if you're familiar with Dragonfly, which is the Abbott product, many times when we catheterize through the skull base, by the time you got to your position, the catheter was not functional because the fiber optics inside it, they would break. Nowadays, with this type of system, is more like a little bit different. It's not a catheter, it's more like a wire, how it works. So you can actually go inside of a microcatheter, commercially available microcatheter, and then you deliver this, and it's been extremely consistent in not having so many failures. The part of the issue is that the Dragonfly concept, you had to place the catheter, the light source would travel inside of the catheter. And this one is actually a true pullback. The wire moves position from distal to proximal. So once you're done with the imaging, your wire is not in position anymore. It has moved down. But what that allows, it allows you to develop a lower profile device to obtain this imaging, which was really essential for neuro. Here, I just want to highlight a few things that are extremely important, is that 7 millimeters of width. So when you are inside of a blood vessel, to be able to see beyond that 7 millimeters in a radius would be almost like 14 millimeters around that. It's very important because it allows you to see beyond the blood vessel. Or if you have an aneurysm, you can see a certain aneurysm's wall from the lumen of the vessel. And this is really a key part of how this is much better than what we could do. This is approaching what IVUS could do, for example. Now, 10 microns of resolution, that's incredible. So to be able to see on that resolution is nothing like that. And of course, 250 images a second, it's good and bad. The good thing is that it's a lot of images in a short period of time. The bad part is that you have to analyze all this information. So look on the right side, you see the catheter. This is this guide wire going inside of the or pulling back through the system. So you can see here how, as this wire comes down, it generates the image. And on the right side is the type of image you can see at 250 images per second. It's a lot of information, but you can see here that you have this intermediate catheter. You're injecting the contrast as you're obtaining the image. And so by that clearance, that time that you obtain, it will give you a sharper image. And that's how you get this type of resolution. But the other key part is how long of a segment you're able to image. So these constructs, to image 10 centimeters in a vessel, it's a lot of images in there. And it provides us a lot of information in different constructs we can make. So I think that this is, we have a lot of information from animal data, some cadaver data, and we have tested not only the ability to consistently get the catheter into position, so the going to tortuous anatomy, as well as the ability to understand what is the best delivery system to this. But the over and over, we're so excited about the ability to now obtain not only luminal information, but also microscopic information of the vessel wall. Now, we feel that the future of this field will involve better understanding pathology. So we also will have a benefit to size the devices better. This is when you measure the vessel size, the OCT gives you probably a more realistic view over the vessel size of how to fit the stent better to that. So this is really important because when you're picking for outcomes to be good, you have to have a correct sizing of your devices. And many times the reason for failure is because we have not achieved a good position of our stent, or perhaps even when you place a web or the coils in the aneurysm, you're not seeing completely the view because this metal, any type of material you put inside of a blood vessel will create an artifact to X-ray. And the OCT does not have the same type of artifact that you see in the angio. So by using both together, you have a more true view of what has happened. And I'll show you a little bit of how that's going to play a role. Now, the other thing is, I think is really valuable is the ability to monitor the healing response of any implants. So you imagine if you could know when to stop the Astra and Plavix after placing implants in a vessel. So by knowing the endothelialization, how that happens, if the device is completely covered, it's extremely helpful to be able to make that decision with some kind of a true image of the vessel. And I think that maybe will allow us to give a more peace of mind. You saw recently a lot of publications on plaque characteristics, when to do a carotid stent, when to do an intracranial stenting for atherosclerosis. Is the plaque unstable, stable? Are there risk factors on the plaque? All those things I think will be helpful for this type of imaging. So we talked about the tortuosity. These are animal models that can show that we can still acquire the image despite of going very tortuous anatomy. And here is a comparison between what you see in angiography and on OCT. And on the left side is the angiogram. So you can see that looks pretty much like there's a stent in place, but you can see on the right side of the picture that the stent seems to be well opposed on the angiogram. But when you look at the OCT, the little dots is the stent, and you can see outside there's a gray circle. That gray circle is the blood vessel, and there are areas that is not well opposed there. And that's an opportunity for clot to form and potentially failure of that device. And that many times is not visualized on the angiogram. Of course, this is a dynamic picture many times, so the ability to reproduce and take this image before and after to do in different time points, all this is an advantage. This is another image modality we have is cone beam CT, which is a CT scan in the angio suite. So you can see here a comparison. The top row and the bottom row is the quality of the image is very different, of course. The resolution is much better, but also you probably have more of a ground truth on the OCT imaging than you have with angio or cone beam CT. Now, the ability to see, and this is very interesting because what this picture is showing is not looking at down the lumen, but now looking at an aneurysm on the sidewall or a branch vessel. When you place a flow diverter across a branch, what happens over time, how the endothelial grows over that, and how blood clot can form also in that location. So I think it's extremely helpful for us to actually start seeing. Now, the question everybody asks is that, what are you going to do if you see something, you know? And I think that I would say the answer to that is always, it's better to know more and then start learning from that data than just not know anything about it. And I think that's where this is heading to. This is an example of how blood clot tends to go into the flow diverter after deployment. The little debris you can see here are basically in the lumen. I don't know the best way to point here because I know if I choose one, then you're going to be upset with me. If I choose there, then you're going to be upset with me, but I'll do both. So these are the blood clots. You see the little clots inside of the device and right there. And then you can see that if you do a reconstruction of the vessel, this is a post-processing. You will actually see maybe if new devices with surface modification, if there's a difference on those devices and how much they acquire, they get clot, or even technique, how you deploy a device, and then you can evaluate how much clot you generate by the deployment. And I think this may be a smarter way to evaluate this. But this is a trip now inside of the blood vessel. This is a post-processing that can be done, but it's an amazing, like, let's say, crude reality of what really is happening on that vessel. If there is clinical significance or not, is definitely something that we need to learn, but I think it's very helpful to have this. This is the discussion that this work was done at UMass. I think Matt will be joining us later on. He may be listening to us now. But this is just what we're alluding to. This is a web placed inside of the aneurysm. Is it possible that you can get some information after deployment that allows you to predict if the aneurysm is going to occlude or not? And I think this is where this is going, is that if you have a good coverage of the neck, you probably have a cured aneurysm. But if you don't cover that well, it may not, it may fail. So you can reposition the device or place a flow diverter, do something else during that day. Now, the analysis for different types of plaques, this is an area that we can grow a lot. As you know, today for intracranial stenosis, we have a lot of limitations in how to indicate treatment. And I think by understanding what type of plaque we're dealing with, it will help us in this field and will help also to make the best treatments possible. This is us doing some of the first getting ready to the first in man study. This is about to start so we have a lot of collaboration with international sites, and this group is being very much getting ready. Here are the different techniques. So I just want to give you an update because we talk about this concept, but it's actually happening right now. The pullback device is the one you see on the right side, and there are different ways to connect these, either the microcatheter or your intermediate catheter to it, and how you do this pullback is being sorted out. It may depend a little bit on the anatomy, the ability to do the clearance, but this is a technical detail. But I just want to show you that this is as deep as this, as we're going down to the technique. This is another area that I find really interesting. This is the work done by Ankiras. And if you look at the ground truth today, when you do simulation of devices, so if you want to do device-specific simulation, you actually don't know where, when you deploy a flow diverter or deploy an intrasaccular device, where each strut is located. It's all, by doing an OCT, you actually can map and get a real idea which each strut is positioned in relation to the structure, to the vessels. What that allows you to do is actually to provide the ground truth for that simulation. So you can actually see how accurate was your simulation up front. So I think OCT will have an ability to provide us some real feedback on what we predicted, if that really happened in the end after we place a device. This is a recent work also from the UMass group on the ability to see beyond the blood vessel into the subarachnoid space using the OCT. So then imagine that you're looking at the structures in the trabeculae or the subarachnoid space, the structures that's navigating in that space. This is definitely uncharted water right now, but beautiful pictures trying to get to the meaning of all this. But it's definitely a possibility as we start looking to beyond, the 2 to 3 millimeters close to the tip of the catheter. Now we're going 6 millimeters or 7 beyond the wire. Now, next steps also, and this is just starting, every image that you obtain, imagine you obtain 250 images per second. AI is going to be crucial to analyze this data. So the ability to quickly receive a feedback from what the AI is screening on that imaging and let you focus in the areas of importance, it's going to be very, very key. And I think that the most important part of this for me is going to help us to do a better training and shorten our learning curve in a field that we're just starting now. So I think that this ability to interpret this in a real time will be key for us to start to getting the real information we need and focus on that, on this ocean of different kinds of images that we'll receive each time we do a study. So this is kind of the platform that the vision is first going to prove the safety of doing the navigation in the neuro space, but also moving to adding physio information. And so we have the anatomy and the physiology, and then the AI to analyze all this data that we receive. So all this, I think, will be key. A question that many of us may ask is, what is the reimbursement for this? So in the coronaries, finally, there is now an IVAS OCT code as well as for FFR. So this may be added to make this a success in the Neuro 2 as we move into potential reimbursement for this image. Thank you.
Any questions for Demetrius?
Oh, no.
I'm gonna leave the microphone with him.
I don't want to be pain in the neck, but let me be devil's advocate.
Yeah.
Demetrius, I see first of all, thank you for the
Yeah.
beautiful presentation. I think for the research, I think this tool is very good currently. Now, when you go up, it's optical based technology. You have to put fluid in the space to create the images because you have blood products that would reflect otherwise. So when you have an immature endothelium, let us say, in a patient, and you want to confirm whether there is a complete endothelialization. So you go with a microcatheter. There may be some risk that you may get some debris or some immature cells washed out distally, creating some TIAs or hits. The second thing is when you inject dye or water to get those clear pictures in that segment that you scan, isn't there an added risk in a patient that is undergoing healing response? Are you worried about?
Yeah, I mean, I do think that it's an invasive method to obtain a diagnostic or to obtain information. So I guess in the end of the day is how much the value of that information outweighs the risk of the intervention. I think that's going to be the bottom line, you know. And so clearly in high risk procedures today, intracranial stenosis, for example, there are a lot of barriers to, because there is a morbidity to the procedure versus the medical management. But if we, with something like this, could make the procedure then better than the outcomes we have today, then I would say it's worth the risk, you know. But I agree, this is definitely to get this level of imaging. If we could do that non-invasively, that would be ideal. You know, I think that's definitely, but I think what's inspiring about this project is that it shows that there's a world out there that we cannot see today. And if we can do that in a non-invasive way, then we should go in that direction, if that makes a difference. But I think it's the first step, first generation for us to see how much impact it will have in our field. You know?
I think it's going to be very interesting to tie this with Adel's talk later today. Again, you're trying to poke a vein through the subarachnoid space. It would be phenomenal. It would be interesting to hear Adel's thought about doing an OCT or an IVUS to go with the e-shunt.
Well, great job. I mean, this is obviously phenomenal technology. And I think the images that you showed at the end, showing the imaging of the subarachnoid space is really revolutionary. The fact that it can be done through a microcatheter, 1.4 is impressive, and even today. And so I think, it really opens up the possibility of navigating inside the subarachnoid space for the future.
Yeah, and I think for that, the physiology part, as much as we can maybe assess if the shunt is patent or not, or different things like that, and may be interesting to look at this. But certainly for me, it's been exciting to be on this because of how many times we have a failure of a device, we do angiogram, and because of the artifacts, we cannot see exactly what the problem is. We all guess that, oh, it didn't heal well, but why, what happened, and I think that we all been there, especially giant aneurysms and things that, all the questions we have today with dylactic disease, you will be talking about posterior circulation aneurysm. So I think there are so many unanswered things that maybe help with this.
Thank you, Demetrius.
Thank you.
Our next guest is a frequent flyer here, true pioneer of interventional neuroradiology / interventional neurology / endovascular neurosurgery. Professor A.J. Kumar Wakalu is a dear friend, is going to share his thoughts, some of the most complex aneurysms that we have, posterior circulation aneurysm treatment. Thank you, Kumar.
Oh, first of all, Ricardo and the committee, thanks for the invitation. It's always a pleasure being here. I love this part of the country. You won't believe it. I shaved my last time he called me mid of the summer Santa Claus. So I wanted to avoid that association. I'm coming closer as a senior to that group. But first of all, I want to thank Dr. Johnson Foy for the presentation. She mentioned a stepchild of aneurysm, and she had a cartoon of fusiform aneurysm. So Ricardo asked me, Dr. Hanel asked me to talk about fusiform aneurysms. They are rare. I don't even believe that they're aneurysms. I think it's the vasculopathy. It's a disease that currently we can control, I think, with our technologies, but we still don't have a proper understanding. So there are certain features to those aneurysms that needs to be discussed. Now, I'm not technical, but how do I advance with the green one? Yeah, there's some financial disclosure and interest here, but no conflict associated with the current context of the subject. So few facts over fusiform aneurysm of the basilar trunk. It's very rare, and it's interesting that unlike what you heard from Dr. Johnson, unlike in female kind of a higher incident of aneurysm, this is a male disease. So over 80% of the patients we see are male of different ages, starting from 50 all the way to 70, 80, and some of them are associated with aortic disease. Now, the mortality of this patient population, if we don't treat them, is over the next 5 years, 80%. And it's a bad disease. So it's basically a death sentence if you diagnose that. Most of the work was done in Japan, and they have a large group that they have been studying and publishing. And the mortality of endovascular treatment has been in this population very high, and I will walk you through the brief history and then where we are standing today. And surgery, I just spoke to a gentleman who's world-renowned in surgery of this kind of aneurysm. He's a Finnish guy, Harneshima, well known to my colleagues here. And they have done over 100 of those cases. And he tells now the patient when they are discovered with this aneurysm, please go home and enjoy your life. I have a different attitude. I think it's a little bit too fatalistic in the era of endovascular treatment. We have to give some of the patient chances. So early experience started when we were back in Buffalo. And you have heard Nick Hopkins also, who was running the program at that time. And we had our experience with stent-assisted coil embolization, which we then later published in Stroke. And we removed basically all other data set and focused on only in the basilar trunk. And it was interesting. This is one of the patient with a fusiform aneurysm of the basilar trunk. At that time, we had only coronary stents, which were very difficult to navigate to the brain. And we coiled around it, and the data looked very promising. I have to say, we had a lot of patients that we saved lives, and there were follow-ups 5, 6 years. Some of the patients had nearly 10 years follow-up, and they did very well. That encouraged us with the introduction of the flow diverter. We thought, well, if stents and coils worked in this area, why don't we embark the journey using flow diverters? You have heard about flow diverters a while. And then we put a prospective study in Europe, mostly enrolled patient. And the initial experience with the flow diverter was we placed the flow diverter, and like the cardiologist did, we placed the patient on dual antiplatelet. So we gave them Plavix or clopidogrel at that time and aspirin. And we said, okay, let us look at what happens. This is one of the aneurysms. You see the flow diverter, that's the white mesh-like graft across one of these patient, and the patient was at the time of the treatment already wheelchair bound. You see, we were basically treating only patients that had no other options. Either they had already stroke-like symptoms or they were wheelchair bound. So they were at the, and the results were very good. We got here on DWI some mini strokes, nothing to our surprise, because there's a lot of clot burden in these aneurysms. And this is how it looks at 6 months and at 12 months, fairly gone, completely gone, some filling of the aneurysm, but the patient died a year later of pulmonary complications, most likely due to perforator occlusion. So brainstem injury that led to death of this patient, unfortunately. And the other aspect was, how do we deal with these patients when they develop after treatment or at the time of treatment a hydrocephalus? And I think there you will see from Dr. Malik also very good work, because they are on dual antiplatelet treatment, you have to stop. Some of our surgeons don't like to put a shunt for good reason, because of the risk of the bleed. We have to stop basically these patients giving antiplatelet, and there is a risk that the whole construct thrombosis, like in the heart, we need to treat it. So we analyzed then these subpopulation for basal, and the results were fairly promising, but the peri-procedure morbidity and mortality was very high. So we thought, let us start a prospective study and expanding and focusing only on this subpopulation. And as you know, in the anterior circulation, flow diverter has worked. This is a pediatric case here. You see here the 3D or the supraclinoid aneurysm treated. So the results were very promising over the last more than 10 years in treating this giant fusiform aneurysm in the anterior circulation. What is the challenge of the posterior circulation? The challenge is that we have a high distribution or high number of perforators that come out of the basilar trunk that make the treatment very difficult. This is a patient that did very well here from Dr. Lilik's group in Buenos Aires, treated for a fusiform aneurysm with a flow diverter. The contralateral vertebral artery was closed to avoid an endo leak, similarly what you do in the aorta. And this is 3 months follow-up, 14 months follow-up, and the entire artery has basically remodeled around this. Another young patient with a dissecting form, completely different disease entity than the previous cases, with a dissecting aneurysm, had a severe headache, impending rupture possibly in this person. So we treated him, we coiled him, placed the flow diverter, and you see the result is fabulous. 24 hours later, aneurysm is completely gone. However, the perforators, the tiny branches that supply the brainstem, went down. So you cured the aneurysm, but you gave the patient a massive stroke from which he won't recover at the age of 20. So this is a dilemma that we were facing. So when we then put together our data in this over 50 patients, what we found out was 27% of the patients, so these 52 patients, 27%, so nearly 1/3 of the patient had a morbidity and a mortality, and the all-cause of mortality in 17%. That's a big number in a patient population that obviously are not treatable, but to lose almost 1/5 of the patient from the procedure was unacceptable. However, when you do the subgroup analysis, what we found out was very interesting, that the reason for all these deaths were associated with infarctions. Less rupture risk after the treatment, but we were losing the branches that supply the brainstem, upper pons, mid pons, lower pons, craniocervical junction, etc. Now, what we did is, okay, let us split now the group of patients that present at an early stage of the disease. So patients where the aneurysms are still asymptomatic. So you see here the category of the patients that presented with a modified ranking scale 0 or 1, and there was only one patient we lost. So overall improvement of the condition was obvious when we treated the patient who didn't present with symptoms. Now that's not easy because these patients have such a bad disease that most of the referring physicians say, let us not treat it. The patient is asymptomatic, and wait until they become symptomatic. Now, what happens if we do the analysis of those patients that present already with the symptoms? Either they have stroke of the posterior circulation, or the aneurysm has grown to the size that it creates a mass effect of the brainstem. And here you see that many of the patients that presented with modified rankings 3 or 4 died or had a major morbidity associated with the treatment. So you see, the problem is that we waited very long. What about the occlusion rates and angiographic outcomes? The angiographic outcomes and occlusion rates were very high, almost comparable to anterior circulation, with nearly 70% of the patient complete aneurysm occlusion. So the summary of our early experience with flow diverter in the posterior circulation was that patients with symptomatic vertebrobasilar fusiform aneurysm had too unacceptable high morbidity and mortality rate. It's safer to treat these patients earlier and single implants. So instead of telescoping different implants, which increases the risk of perforator occlusion, was probably the way to go. And I remember Demetrius, who is sitting here, was promoting that a long time ago, and I concur with him after going through this journey. I think from our early experience, lifelong or long-term dual antiplatelet treatment was the way to go. Now, there were other people, other group members that have embarked the same journey, and they found the same thing, that if you treat these patients with the flow diverter and put them on dual antiplatelet, we have here a situation of high peri-procedure morbidity and mortality, which is unacceptable low. So what has changed? What have we changed? We have not changed the device. We have changed some ways, techniques that have improved, but we have done something different. We learned from subgroups that probably to put the patient on anticoagulation on top of antiplatelet may make sense. And we did some early, this is Bilbao, Frank Gehry, some of you know that. What we did is in a multi-center setting, we compared our data of patients, and Ricardo is one of the investigators in 8 different US centers, and this paper is just being published. I think it's online. What we did is we said, let us look at 2 patient population. One patient population that has dual antiplatelet treatment and the other population that had triple therapy, we call it. So we added to aspirin Plavix or Brilinta aspirin, we added Eliquis. So rivaroxaban or I think there were some other anticoagulants that were added. And let us compare the data. Obviously, there's a lot of shortcomings with data. It's a retrospective, it's a case series, it's centers that have a lot of experience. So we did the analysis. You see on the left side, the triple therapy in 14, it's a rare disease, like I said, in 14 patients, and dual antiplatelet, classical treatment like in anterior circulation of 13 patients. And there were some surprises that popped up. First of all, surprise, there were more patients that were sicker in the triple therapy. The reason is that people still are waiting because the old data was not present. So they were waiting to enroll them in the triple therapy. So where we had Eliquis on board or one of the anticoagulation. The other surprise was, and that has to do with all these newer instruments that we have developed, there were more radial access. And I have to say, radial access to the posterior circulation is so easy as compared to femoral access. It makes the procedure easy because of the configuration and relationship between the vertebral artery and subclavian. And it's very comforting for the patient. It's really a very straightforward procedure. Then what about numbers of devices used? You see there's a behavioral change. Initially in the dual antiplatelet treatment, 23 devices in many patients versus 3 devices. I said 1 device in a small number of the patients, 3, versus in 64% of the patient with triple therapy, single devices. So that means our learning and habit have changed over time. And that goes back, like again, I said, Demetrius said it a long time ago, we should have less and wait before we, telescope the devices. So that was one thing. The other observation was the outcome. And the outcome was very, very interesting. The decline in modified ranking scale was seen in the triple therapy only in 1 patient versus in 9 patients that had dual antiplatelet treatment. And that has to do with perforator strokes. Perforator strokes was the key leading cause for this patient population to get a damage to the pons and subsequently shift in the modified ranking scale. The complete occlusion, of course, dropped in the triple therapy because anticoagulation, we know that from patients who have AFib and get aneurysm treatment, that the healing response gets delayed. And that's to be expected. Now you're blocking all the mechanisms of thrombosis of an aneurysm. And we see that with coiling. And you see that's reflected in the study that you had only in 25% in this observation period, a complete occlusion of the aneurysm versus in the dual antiplatelet group. Some cases from our shop, here a patient with a basilar truncatum, you see this is an ugly disease, 6 months follow-up, some occlusion of the aneurysm. Another patient with a large clot burden, and he's 70. He has now lived for a few years. Here, one single flow diverter. We had to close the other vertebral artery. You can imagine there's an endo leak. When you look at that, there could be an endo leak from the back, and that's what we faced. So we closed the vertebral artery carefully, put the patients on anticoagulation to avoid perforator occlusion as well as occlusion of the pica, because suddenly you have dropped the blood pressure and the flow. This is how it looks after the treatment. And when you look in vaso-CT, you see nicely how the device covers the aneurysm. But you see also the problem. There's a distance between a major perforator and the device itself, creating the propensity for a stroke. So what you do is you want a remodeling of the device, of the aneurysm around the device without occlusion of these little perforators. And that's exactly what we do by keeping the patients on anticoagulation. Another patient with a Turnoff, younger patient in his early 60s, where we had a technicality issues because it's just too big arteries. We don't have the flow diverter. So what we decided is to expand the flow diverter with 2 stents. We call it the double barrel technology, and place a stent here. So the concept now is getting more and more just to focus the flow diverter on the segment that's diseased rather than placing the device in areas where we have a healthy normal perforators and a higher density. So we are reducing the implants, the length of the implants. So this is the cartoon that shows how we expand it further. And you see already at 3 months follow-up, the belly of the aneurysm is shrinking. So you are unloading the pressure on the aneurysm. And this is 1.5 years later on Eliquis and Brilinta, and you see most of the aneurysm has thrombosed and the patient is doing fine, he's stable. And how is that possible? People ask me, how is that possible that you keep the perforators open? And the interesting thing, the perforator don't keep open. They close off, but they are what we call longitudinal new branches that sprout. It's the angiogenesis that sprout through the clotted segment. And you see that on the video clip on the left side, there are little branches that sprout between the device and the clotted area and reperfuse the brainstem. And that's the beauty about this progressive slow occlusion. Another patient, I will go quickly, 55-year-old with ataxia. Many people say, why are you treating that? The patient has the early symptoms. It's very easy to treat, and it's a very easy treatment. Maybe we can see the videotape here. Can you forward it? It's really the simplest way of deploying a flow diverter is the posterior circulation. It opens up always. You can titrate it exactly. Just go fast forward. So you place your device right there. You don't want to cover the perforators of midbrain up at the top. You place the device, you glow with your balloon or with your stent. Here we are anchoring the distal part with a stent. Here the device has been placed. We go, you can move a little bit faster. Yeah, keep going. Ooh, that's very fast. So you have your the device placed, then you go with the balloon, you open up the device with the balloon, and you anchor distally and proximally the stent. This is the ballooning. Very easy procedure for interventionalists who are used to do that. The problem is not the treatment with the device. The problem is what we are talking about is management of this patient with antiplatelet and anticoagulation. And that's the major shift, as you see. We can move forward now. Next slide. Yeah, this is how now the construct looks. Like I said, we want to reduce the flow diverter, which has higher mesh and more metal than stents. You see the stent anchoring here and down the device extended into healthy segment, and this is the final result. And the patient is alive few years later, and the aneurysm is stable. Another subject, same technology, most of it is thrombosed, ugly here, ugly kind of a web kind of a plaque here, elderly patient. We treated him. The patient is now 5 years alive. The aneurysm is gone. There's a stability. Has the aneurysm disappeared? No. In some patients, we see the aneurysm still there. It doesn't go away completely. Another more complex case, completely different disease than the one of the senior person, which is atherosclerosis. This is a media necrosis, so we call it disease of the media muscularis with this fusiform aneurysm where we treated this guy. Again, we put it on triple therapy. So what is important is, and Ricardo, Dr. Henel has contributed a lot into this, that we differentiate. Whatever looks angiographically an aneurysm doesn't need to be an aneurysm. It could be an aneurysm, but it could be a completely different underlying disease, and the outcomes will be different. But these vasculopathies of the posterior circulation are a challenge. I think that we have to reclassify them. I think the fusiform aneurysms still remain a challenge for us, but I think we should really seriously consider treating these patients before they become symptomatic. So instead of doing every annually MRI or MRA follow-up on them and wait until the patient is wheelchair bound, I think we should intervene earlier. And the critical problem is the high perforator density. And I think less is better. Single flow diverter probably better. And infrequently, we have to sacrifice the other vertebral artery. We consent the patient for that to avoid endo leaks. I think blood pressure management is important. Anticoagulation management is, and dual antiplatelet management is very important. These are patients that stay with you lifelong. Now, what will make a big difference, I think, is this newer technologies. I hope that Matthew Gunis will talk about that later. Who has been heavily involved in this. This is a new flow diverter that's heparin encoded. So the heparin stays there for a very long time. And I think this is an innovation that could be beneficial for the posterior circulation. Here's some research study from UMass, from Matthew's lab here, showing with OCT technology. And Dimitris, there I believe really this is critical for understanding in early stages what these implants do. Absolutely. Here, MRI showing nominal hits placed in the basilar trunk of the canine model, and very, very interesting results. And we think maybe there will be less endothelialization, but that couldn't be shown in this study. So you get the same endothelialization. It doesn't inhibit the healing response of the vessel and the aneurysm, but it inhibits basically clot formation in the perforator. So I think in the posterior circulation, this may make a huge difference. With that said, I thank you for your attention.
Question? Or you can answer here. Any questions for Professor Wakalu, guys? So we discussed this before, AJ. We struggle with this indication. Early treatment for a quote-unquote fusiform vasculopathy, a 65-year-old guy with a dolichoectatic, ataxic. When do you indicate treatment? Any dilation you're indicating? And if you don't indicate treatment, how often do you follow these people? And I know it's a tricky question, but we struggle with indication, right? Because again, to put somebody through a heavy metal treatment, it's not risk-free, and despite all the things that I think we learned in the last decade or so.
So we were in Japan together, and we debated that on the panel. And we have in our group now patients that are annually followed up by MR, by our neurology team. They come every year, and then there is an inflection point, and that's very interesting, where suddenly the aneurysm starts growing. And with the growth of the aneurysm, it takes down the perforators. So the symptoms are, like you said, dysarthria, numbness, all these very mild symptoms. And the neurologist said, let us wait further. And what we have seen is that suddenly the aneurysm starts growing. So it doubles, triples, quadruples within a year and becomes unstable. So from our past experience, when we treated these aneurysms, we used to tell them 30–40% morbidity mortality. Today, when I see a fusiform aneurysm and the patient comes to me and say, doctor, I had this weird feeling in my hand. And you do MRI, sometimes you don't see anything, but sometimes you see a mini stroke. That's when I am proposing to intervene. The horrible thing would happen at our place is that one of the chair's brother has an aneurysm like that. He was 52. I told her, bring the brother, we will treat it. He's asymptomatic. A year later, they are doing the MR scan on this 53-year by now, and he coded in the MR scanner. And the whole thing blew, and he died. Now, the person is very open to the concept in a jointly fashion. These patients are more a clinical problem. They're not only our problem, it is management. And I think if you do at your institution in a standardized approach, this patient, where you involve everybody in the team, neuro IC, neurocritical care, I think it is valid to treat the patient at a very early stage before they get symptomatic. That's my approach now. And what do you cite on complications now? I think it's less than 10%. It's like in anterior circulation. But I think anticoagulation, like our paper shows, may be very critical in managing.
AJ, so one question on the when to use coils or not on this, not for vertebral artery sacrifice, but if there is a saccular component or if it's just an ectatic vessel, I can see the situation that you would favor to use coils on a situation that you have a belly, a very big belly. But between multiple flow diverters versus using coils and one flow diverter, it's a big question, right? We don't know. Sometimes to control the thrombosis in the sac of the aneurysm, is it better to control that now with the anticoagulation and use anticoagulation and less flow diverter, or you still use coils in some cases?
I think that's a very important point. And there, I truly believe that OCT, what you presented, will be very helpful. I think it's critical to know from which segment of the aneurysm perforators originate. If you place coils across a perforator, you will kill the perforator. You don't want to do that. But sometimes we see this outpouching that look very paper thin. They look altered in their probably histomorphology. So there, I would say, place and cover those areas with coils. It's not always technically easy. But the other thing is that some people, you yourself promoted that, why not place a stand, wait, place another stand? So basically, you gradual approach. We have not tried that. We are still leaning towards a single device whenever possible and anticoagulation.
Yeah, but when we talked about that, I think the problem was that I think the concept of using anticoagulation helps on the stage. The reason to do stage was because we wanted to control the thrombosis of the end. But now if we could control that pharmacologically, that may be a way to get around that. So I think the concept of trying to do the best construct the first time, because we were just reviewing now what happens with cases that were treated before with stenting coil when the technology was available. Now they fail, they're coming and you need to do flow diverter. It's a different beast, right? So the healing may be altered. And so I do think sometimes we have to use our first device with the best chance to help the problem. And the staging, I think, is valid, but with the medication, it now adds another component to that stage, how you control the thrombosis.
I think Kifon had a question.
Yeah, thanks. That was great. Thank you so much. And I'm not going to ask technical questions because I leave that to Demetrius, but My question is about triple therapy, and as somebody who's managing that, is triple therapy something that we should anticipate for 100% of this population? Or is this something that is offered only to a select group? Is that something that you guys are starting to see and would recommend? And then, as you guys were just discussing, those that were in a staged fashion that have not been on triple therapy and are representing, you're going to place flow diverters. Is that a population that we should be considering then might be on duals right now that we start anticoagulation? And then my final question is, are we doing full dose? Is anticoagulation being recommended in full dose fashion, or should we be, doing a half dose anticoagulant?
Thank you very much for bringing up the question. I didn't go into the details. One quick note, I'm moving away from triple therapy to two therapies, Brilinta, and I know Ricardo is nodding because he's doing it also. So our next paper will be on that. Because from cardiologists, we learned something very interesting. They send us patients with AFib, and many of them are Eliquis 5 milligrams BID. And they asked me, why are you placing flow diverter and putting them on dual antiplatelet? We don't do that when we do our coronary stents. So we switched now. When patients are on AFib treatment, we give only ticagrelor, or you use, I think, you use something else as antiplatelet. You do ticagrelor. So that means for this fusiform aneurysm, we can do the same thing. And we switched now. I start with heparin for 2-3 days, controlled in the neurocritical care with my colleagues from neurology, and then blood pressure maintains for the perforators. And then we keep them for 6 months on 5 milligrams of Eliquis and Brilinta, generally 60 milligrams BID. We started with 90, now we are down to 60 milligram BID. And then what we do is we try to taper off the Eliquis from 5 milligrams to 2.5 BID. And some patients don't tolerate it. They immediately start having this weird microinfarction kind of symptoms. We go back. The one patient who was 1.5, he's down now 2.5 milligrams BID. Our goal is then to slowly, gradually see how can they tolerate it, and then wean off the anticoagulation. It could be that some of the patients you cannot get off the anticoagulation at all. Same thing with the antiplatelet agent. Try it slowly. I think it has to do with the perforator density. It has to do whether they are healing, and the neogenesis allows you this collateral. It's like when I think Sherwan Sekharji last year presented the MC aneurysm. Some patients tolerate that because they have the collateral. And I truly believe, unlike previously thought, that in the pons area, you have also, they are not end stream vasculature. I think there are potential for collateral. So taper it down and tailor it to the patients as needed. That's our approach currently. You want to comment?
I don't rush to stop anticoagulation. I think we have our cardiologists that do this for much lower risk disease. Exactly what AJ, he stole my comment. Tons of data coming from cardiology. They're dropping the aspirin, keeping the Brilinta or whatever second antiplatelet agent they're using because of the safety profile. Seems that aspirin adds hemorrhage risk, does not prevent thromboembolic risk. So I think there's a signal there that for this. But if you look at these aneurysms that AJ present, again, those are the toughest aneurysms that we have, and we are rushing to stop a medication. Again, I think if the team is winning, the patient is doing well. I pause before I'm going to stop an anticoagulation because the patient is doing well. There's a question from Zoom. What about if the aneurysm rupture? Again, that's the other side of the coin, right? Again, the world is not perfect. We got to pick an enemy. It's a big deal if the aneurysm bleeds, and not uncommon. That's a fatal consequence with all these blood thinners on board. But our problem, as AJ said, is thromboembolism more than rupture. Nima will present, or we'll present a case here for the audience later that is 180 from that. But again, I think thromboembolic, once you treat it, is the enemy. Abby, do you have more questions on Zoom? Okay, well, there's been time here, Dr. Lowe.
I mean, the other problem is that most of these patients have fall risk. So they are very, the whole point of doing the posterior circulation case because they're very unsteady. And this is an issue. So I think that's the whole point of do early treatment to avoid because the treatment anticoagulation under patients that are falling all the time, that is a problem. So education and preparation for that is a big deal, actually. This is very different than the cardiac patient that doesn't have the fall risk that our patients have, so.
I forgot that to your interesting question. One more comment. In the anterior circulation, in the carotid area, what we have found is that when we place the flow diverter or stents also across the ophthalmic artery, that often patients present with photopsia, so micro hits. And I learned that from Dr. Kuhn. We put now the patients rule out with cone beam CT, there's no bleed. We give them half cardiac dose, adjusted dose of integrin, eptifibatide as a bolus, and half a dose as a drip overnight. And in the last 1 year, we have been doing that. We have not seen any ophthalmology finding. And I think what happens is, despite PRU values being in therapeutic range, that there's this schmutz, there are these endothelial progenitor cells. And the first slide was that we are looking into that. This little bit of debris, they are cellular elements that attach to the implants, and they, through the shear forces, are flown distally into the ophthalmic central artery. And patients feel that. And it's interesting, when you avoid that early stage emboli and you get over it, patients do very well. That's what we are learning, the hard way.
So you're putting every anterior circulation on integral for 24 hours? Ophthalmic, gotcha. Interesting. We got a break, guys. We're gonna give you 15 minutes of break because we're gonna have a full hour of lunch for good food and camaraderie. So we're gonna come back at 10:35 sharp for Lucy Giselle Thibault talk. Thank you.
Hey, everybody. Hey, everybody. I just wanted to let you know, too, we do have tables outside. If you'd like to eat lunch, you're able to eat in the room here, but then you can also go right outside to the back patio to eat your lunch also.
Knock, knock. Okay, guys, it's 5 past the break. As a good Brazilian like Dr. Lopez, we're great in keeping time. Our next speaker is a dear friend, Canadian, Lucy Thibault, aka Giselle, is going to talk to us about antiplatelet management for neurointervention. We had a little brief in how important that is for what we do. Lucy, thank you very much from taking time from Japan, France to come to Small Ponta Vedra and join us.
Thank you so much. Thanks for the invitation. I'm very honored and happy to be here. I'm a little bit jet lagged, it's true. And I was just counting last night. It's my 17th segment coming here last night, flying in this month. So it's been a long month, let's see that way, but great meeting and a lot of good information. So I was asked to talk about the antiplatelet management in a neurointervention procedure. So I'm not going to focus on anticoagulation. I know that there was a hot topic just before the break. That'll probably be another topic of discussion in one of my future presentation. I'm just trying to advance it. Whoops. Okay. So the way I talk, I will divide it. It's talk about the antiplatelet agents, talking briefly about the platelet function testing and the value of it, talking about the regimen for elective case and also for those emergency cases, the role of IV cangrelor, which is a P2Y12, but I'll discuss it a little bit more in length at the end because it's new, and the future direction for antiplatelets. So my disclosure, I'm a full-time employee of the medical industry, but there's nothing related to this talk about devices. I'm a PharmD by profession, and it's basically based on pharmacology. So first, the indication for antiplatelet, we know that the main goal to use it is to reduce the rate of thromboembolic event. And at the same time, we try to limit the risk of hemorrhage. And this is where in neuro, contrary to cardio, the balance sometimes it's very small. So the antiplatelet normally used for routine and elective cases are used for unruptured aneurysm when stent assist coiling, flow diverter procedure. And in intrasaccular device, we saw it from Dr. Rees' presentation this morning. Since the device is inside the aneurysm, I think more and more in the future, we may see people using antiplatelet for a little bit less time at the end, or eventually maybe not using antiplatelet with those devices, mainly for rupture cases. For carotid artery stenting, for when those intracranial atherosclerotic disease need to be stent for high CAD, and the venous sinus stenting plus minus with the anticoagulation on that side. And for emergent procedure, of course, rupture aneurysm. In stroke, it's mainly when a stent need to be deployed, like in those stendum lesion, when a carotid need to be done, and also when a stent need to be put for high CAD as well. I don't know where I need to point, but oops. Okay, so the main challenge, even today in 2022, we don't have guidelines, no consensus of the use of antiplatelet for no procedure. If we look at this timeline slides over there, it started in 2002 when the first stent, the Norform stent, was put in the brain. We have aspirin, we have Plavix, we have the G2B3A that were there, and there was at the time ticlopidine, which is not on the market in US anymore. And then as the evolution go, the second one that came after that is the Prasugrel, which I'll talk briefly about. And then the ticagrelor, the Brilinta in 2011. And then what we have is P2Y2 since 2015, it's the IV cangrelor. So there's been an evolution mainly for the P2Y12 drug. The G2B3A pretty much are the same, except that the Repro is not available in the market anymore. And moving forward, we hear about those surface modification and coating on those devices that may eventually prevent us to use antiplatelet or maybe single antiplatelet regimen, but we're not there yet. So this is just a sketch to go over where those drugs work, which I think it's important to understand before we start talking about which one to choose. What you see on the right-hand side over there is a platelet that is spherical. Basically, there's no action, it's hemostasis. And when the platelet become activated, they basically have those little spikes that form at the surface of the platelet and they become gluey. And this is when they're going to start accumulating to each other. And like you see on the slide over here, they become activated, and then eventually they're going to aggregate to each other. And the final pathway to bring two platelets together is the activation of the G2B3A receptor that you see over there, and that will link two platelets together by the bridge called the fibrinogen, which eventually will become fibrin. And this is why you have a case where clot form in front of your eyes, you inject a G2B3 as a rescue drug. Basically, the platelets are not together yet totally because fibrin is not formed, it's still fibrinogen. This is why the G2B3A, who are antiplatelets, are acting very well as rescue drug to dislodge a clot in a case of an acute thromboembolic event. So we'll talk first about aspirin. I think everybody is very familiar with that drugs. It's normally combined with the P2Y12 orally. It is suggested to use the lower dose because you have a good antiplatelet effect with baby aspirin. There's no need to increase the dose of aspirin to 325 or 650. In fact, you may increase the side effect, GI bleed, irritation, everything by increasing the drug. The drug worked very quickly. So you normally see the peak serum in 15, 20 minutes. In some country like Europe, they have the IV formulation, which act almost immediately. And you'll see platelet inhibition with the baby aspirin in less than an hour. And again, the mechanism of action over there, it's to block the coenzyme cyclooxygenase. So that way you don't do the activation of the platelet. And again, it works at lower dose. If you increase the dose of aspirin, you get the COX-2 involved. And at this point, you have prostaglandin also involved that may have an indirect effect on platelets. So the main pitfall, again, it's dose related. It's those GI bleed that could happen, allergy. There's protocol out there to desensitize a patient using small alicot. The enteric coating is not recommended when you're reaching for an antiplatelet effect because again, the peak serum may be delayed by the time the drug got absorbed. One thing to keep in mind, if you're combining aspirin with ticagrelor, you are decreasing the effect of ticagrelor if you're giving more than 100 milligrams of aspirin. So whenever a patient discharged from the hospital, always try to recommend not to take over-the-counter medication that may contain aspirin during their treatment on aspirin and ticagrelor, for example, post-stent. There's also an interaction with the COX-2 inhibitor, which are the non-steroidal anti-inflammatory. And we know that there's some patients who are not responding. That's why you can measure sometime the RU, I'll talk in a few minutes. In function of P2Y12, we have basically 3 oral drugs, clopidogrel, Plavix, that I think everybody is very familiar with the limitation of that drugs. It has some drug interaction, mainly due to the metabolism of the drug. The onset of action, depending of the dose, go from 2 to 6 hours. And the usual bolus is not 300 milligram or 450, but it's 600 milligram, followed by 75 milligram orally per jour. The ticagrelor, which is the Brilinta, has a completely different mechanism of action, which I'll cover in a few minutes. It's not affected by the cytochrome. So that's pretty much why we see less patient variability when we use the ticagrelor. And the bolus, as you all know, is 180, followed by either 60 or 90 BD. And the onset of action is very quick. Normally, if you try to load a patient for an emergent case and you decide to do it orally, you can combine baby aspirin with a bolus of ticagrelor, and you'll probably be able to do your procedure in less than an hour. Same thing for prasugrel, who also work very quickly, in fact, a little bit quicker onset of action than the ticagrelor, but the bad side of the prasugrel, there's report in the literature, even the neuro, reporting a higher rate of bleeding that is reported, and I'll cover that in the next few minutes. So the main difference between those 3 drugs and what make the clopidogrel, the Plavix, so challenging, it's basically because of the metabolism of the drug. So what you can see over there on the far left, it's how the Plavix is digested by those different cytochrome, who basically it's a family of enzyme who's just going to try to metabolize the drug to make it active. So basically, when you're taking 75 milligrams of clopidogrel, you have 15%, which is the active drugs. So if you have a lot of cytochrome in the meantime that take a piece of it, you don't know at the end if your patient is really therapeutics because he's not getting the 15% that he needs to achieve a good antiplatelet effect. The advantage of the new molecule like the prasugrel, it's also a prodrug, but the metabolism is much more simple. It's not a 2-process oxidation like the clopidogrel. And for the ticagrelor, what makes it even more attractive, because sometimes you say, well, I'm not going to even test my patient because there's basically no report of a patient not responding. It doesn't require any hepatic bioactivity. So it's just basically what you give to the patient, except if there's some drug-drug interaction, the patient should get the dose he needs when you bolus him. And this is a heavy slide, but it just to show you the complexity of the clopidogrel and the reason why it's such a challenging molecule. Even clopidogrel is used a lot still today in US, and a lot of the labs, they have their drug of choice with aspirin. Not everybody reach out to ticagrelor, unfortunately. But there's all those gene polymorphisms and mainly the cytochrome C219, and there's a lot of stuff that can interact with that. We know that the Asian population, they don't metabolize the clopidogrel as easy as Caucasian. You also have the increased body mass, the BMI, the patients that are diabetic, acute coronary syndrome. These have tendency to decrease the absorption of the clopidogrel, and we know that the smoker may have a higher response to clopidogrel. So there's a lot of little door that can open an interaction that is possible, and for that reason, we see a high variability in patient response. In function of dosage, if you're using clopidogrel to load your patient, use 600 milligram, you'll see an effect in 2 hours, but by combining with aspirin, your bolus will kick out in 1.5 hours. And again, that can be baby aspirin. If you decide I'm going to bolus my patient with 200 milligram, it's a rupture aneurysm. Well, by the time you get ready, if it's in an hour, by the time you give the drug to the patient, your patient is not therapeutics yet. So it will take 300 milligrams, 6 hours to pop out to be therapeutics, to have a good protective effect as an antiplatelet. So that's something that sometimes people forget, or don't give enough of clopidogrel as the bolus dose. In function of the other molecule, again, another complex slide, but it's just to show you the difference. Clopidogrel and prasugrel are basically acting the same way, and the ticagrelor and the cangrelor are basically have a completely different mechanism of action on the P2Y12 receptor, but they all P2Y12 receptor inhibitor. This is just a sketch to show you the difference between the two. The paper clip that you see over there is the P2Y12 at the surface of the platelet, and the little yellow ball that you see over there is the ADP. So normally when the ADP is put on the P2Y12, it does stimulate platelet aggregation and motivate the G2B3 receptor. So what the prasugrel and the clopidogrel are doing, they are competing with the ADP. So by doing that, they are blocking the receptor at the level. When the ticagrelor and the cangrelor, what they do, they bind irreversibly. So this is a little purple ball that you see over there. They bind, they go free, they bind, they go free. This is why ticagrelor is reversible as a molecule. But when you try to reverse ticagrelor in a patient that is bleeding coming to you, it's not an easy drug to reverse, contrary to prasugrel and clopidogrel, where you can give desmopressin or some platelet. It's very, very difficult to reverse a patient on ticagrelor. And I'll talk about the advantage that cangrelor can have, because cangrelor has such a short half-life. You stop the drug and 30 minutes later, 50% of the platelets are back. Or if an hour later, all the platelets are back to normal. So there is no antidote necessary or anything for cangrelor, but there's an antidote coming for ticagrelor. So that's the different mechanism of action. The main pitfall for the ticagrelor, it's mainly the drug-drug interaction. I explained to you that the metabolism is much more simple than the clopidogrel, but there's one interaction with the cytochrome 3AC4, and there's a type of drugs that will decrease the effect of the ticagrelor, and there's some drug that may increase the effect and put the patient more at risk of bleeding. We also know that the Asian population has a bioavailability that it's superior to the Caucasian population. So meaning that you may need to give a smaller bolus or smaller maintenance dose in those patients. They definitely are acting more to ticagrelor. The drugs that have tendency to increase the effect of ticagrelor to watch for are basically antifungus drugs, some antibiotic, and some antidepressant drug. And these are strong cytochrome 3A4 inhibitor. And the one that may decrease the effect of your ticagrelor is an anti-tuberculosic drug and some epileptic drug that again are strong inducer of this cytochrome 3A4. So something to watch for. Another thing that it's interesting, it's a study done in cardiology, and they did something very similar with the prasugrel as well. Is like you have an emergency case, you don't want to use IV or IA drugs, you don't have access to cangrelor, you can crush the pills of ticagrelor, and you can see over there, you'll have basically a much more rapid onset of effect with the drugs versus giving it just PO. So you will have about 30 minutes will become about 20, 25 minutes. And then after that, you can continue procedure. So your patient will be low basically much more quicker. So it's not a prodrug like clopidogrel and a prasugrel that has those drug-drug interaction that I mentioned. It's a molecule that is reversible, but keep in mind it's not easy to reverse if you have a patient bleeding on it. The onset of action is about 30 minutes. So you can load your patient, start your procedure, and the offset of action about 3 to 5 days. There's some side effect we have not seen with the other drug, and it's mainly due to the mechanism of action, which is dyspnea and bradycardia. And again, be a little bit more precautious in the Asian population because they have tendency to react more. And again, it's to be taken twice a day, and it's not reimbursed by all the insurance companies still today. But the FDA just recently approved a generic for ticagrelor. It's not available yet, but it is approved by the FDA. So this is something moving forward that may decrease the price of this drug because a monthly supply is about $580 US dollar right now. The prasugrel I mentioned is a prodrug. We know that it's about 10 times more potent than clopidogrel and have a reputation to cause more bleeding. It has a faster onset than the ticagrelor, just a little bit. And the offset of action is more similar to the clopidogrel because it binds irreversibly to the platelet. So it will live with the platelet to the lifespan of the platelet. The FDA has emitted a black box precaution. So the patient with an history of stroke or TIA, the prasugrel is contraindicated on those patients because in the sub-analysis of one of the big cardiology study, they show that the patient population who have this kind of history were more at risk of bleeding. Same thing for the patient who are 75 years or older, to be cautious, maybe decreasing the bolus and decreasing the maintenance dose. And same thing for the patient who has a low frame. So again, this is on the labeling of the FDA for precautions. In function of the hemorrhagic complication, what does the literature say? There's two papers that basically report that. One in 2013 for Barry, it's a group from the Kentucky who talk about the hemorrhagic complication. Another one from the French group at Montpellier who decide to decrease the bolus and the dose based on that. This is the first paper there talking about the hemorrhagic complications. So this is the group from St. Louis, Missouri. So they saw in that study that there was definitely more hemorrhagic complication that was statistically significant in the prasugrel versus the clopidogrel. And in a study that was done in Europe, looking at the hemorrhagic complication, this was a meta-analysis of close to 1,400 patients on rupture aneurysm, looking at 7 studies. And again, here, the prasugrel was associated with a higher risk of hemorrhage than the clopidogrel. Again, this is clopidogrel versus prasugrel, not ticagrelor. As I mentioned, for the ticagrelor, you can crush the pills and it will bring you 3-fold faster absorption of the drugs if a patient needs to be low, then this is the drug that you decide to use, that it's your drug of choice. For the G2B3A, they are antiplatelet as well. They can be given IV or IA. The kinetic is the same for IV and IA, by the way. And we have now 2 drugs available. The ReoPro is not available anymore. And when those drugs do, in fact, is that they are, I'm going to go this side, I'll go to the other side. So they basically block the final pathway to bring to platelet together. So the platelet become gluey. They have tendency to be attracted to each other, and the fibrinogen is going to be the bridge here that's going to bring 2 platelets together. So what the G2B3A do, even if you're giving it to load the patient or when you have a clot formation in front of you, it's block this receptor over there. And if the fibrinogen start forming, it's just basically dissolving it. So this is how those drugs are working. So the Aggrastat, which is a tiraifibran, can be given as a bolus followed by an infusion. And those medications are very strong. They are very potent. In 10 to 40 minutes, it will inhibit about 90% of the platelet. And the platelet function normally return to normal in 48 hours. The integralin, you need also to give a bolus followed by an infusion. And the majority of the platelet infusion will last for about 4 hours. So they can be used for rescue, or they can be used to load the patient in an emergency situation. This is just a table that shows the main difference. They are very similar in kinetics. There's not that much difference between the 2 drugs. The main pitfall that we have of those drugs, they are expensive. you need to bridge them to some oral antiplatelet, and there are some new drugs in development that may be going to be an oral G2B4 that is in a phase 2 trial right now, and they are reversible and they can be used for rescue. The cangrelor, which is the new IV P2Y12, is a very short half-life, 3-6 minutes. So basically, when you give that drug, your platelet got inhibited almost right away. So an emergency situation where your patient was not low coming, you decide to put a stent or fluid diverter, this could be the drug of choice combined with aspirin to give to your patient. The nice thing about it, I think, in neuro, is that if a patient bleeds or there's a situation that you need to reverse it, you just stop the drugs. And in 30 minutes, 50% of the platelet will be back. And in an hour, all the platelets are back to normal. So it's really a true reversible molecule. The offset of action is super rare, and you don't have this rebound platelet inhibition when you stop the drug. Another new drug that has appeared on the market is Voxapamar, but there's a lot of hemorrhagic complication related to this drug. So I'm not so sure that's going to be a drug of choice in the neuro field moving forward. What about the testing? In absence of proof, there's no proof of absence. This is a very controversial topic. The gold standard is to do the light transmission aggregometry, but most of the lab don't do it today because it's cumbersome to do, has limited clinical use. The one that we see most often used is a point of care assay called the Verify Now. And it has a CPT code, so it can be reimbursed. It's reliable from what literature is showing us. This is something that Dr. Philippe Albuquerque from the BNI presented at the ESMINT last week, and their threshold to look at platelet activity is 194. I'll go over another slide, tell you what most of the other lab is using, but the PRU is basically the reaction unit for the P2Y12. You can also test aspirin by using a different cartridge on the same machine. It's called the RRU, and the magic number over there is 550. So mainly that you want to look for a number that is less than 550 if you decide to measure aspirin to see if your patient is responding or not. And there's also a cartridge that exists for the final for the G2B3A, where you can calculate the percentage of inhibition, but we know that those drugs are so potent and there's no resistance to those drugs. So that's basically in its use. And what I put over there is a study, Dr. Hanel was the main author for the Premier study. And in the Premier study, flow diverter, in the past, we used to look at 240 for the PRU threshold. They've been looking at the PRU less than 200 with a range of 60 to 200. So as more studies are coming, it sounds like the PRU is moving from 240 now to 200 based on the study. This is a study from Dr. Fraser from Kentucky. They look at the meta-analysis of close to 1,500 patients over 12 studies. And they consider that those patients that were qualified as hyporesponder, meaning a PRU more than 200 to 240, have 15 greater risk of having a thromboembolic event. So that's kind of clinical evidence, kind of try to justify if testing is really something we want to do. And the hyperresponder, which were judged as a PRU less than 60, 70, they were 12% of them were greater risk of hemorrhagic events. So their comment was like PRU, as assessed by Verify Now, can be useful in predicting complication rate for both thrombotic and hemorrhagic. This is an algorithm that I put together. On the right-hand side, you have the aspirin 550, but for the PRU, in the past, based on cardiology literature, not too long ago, it was 60 to 240. But now we're looking at what the neuro literature is publishing, and people looking at minus 40 to 60, most of the time 60, and up to 195 will be considered a hyporesponder. Again, for flow diverter, based on the result of the Premier study, they used 200 as the threshold for the ROS. But one thing I think it's important when we measure PRU, and I'm hearing it all the time, well, I give a dose, then I measure, it was subtherapeutic, I give more drugs. It's important to consider when to test the patient after you rebolus a patient. I put it in red over there. So you need to test 6 hours post-bolus for clopidogrel, and you need to test 45 minutes post-bolus for prasugrel, and test 2 hours post-dose for the ticagrelor. And this is something that it's part of the IFU of the Verify Now. And the patient should not be tested within 48 hours after you give a G2B3A to your patient. So if you're switching a patient to an oral dose after giving an IV G2B3A, keep in mind that all your platelets have been inhibited by the G2B3A. So whatever result you're going to see on the PRU won't be what the patient has or where the patient is. So that's an important factor that sometimes people basically forget. And for bolus of Plavix, for example, it takes at least 6 hours post-bolus where you'll have a therapeutic level telling you exactly what the patient has, which is not always practical. So for the PRU, again, 120 PRU in this study that was just recently published last week in INR, they look at LTA, they look at the whole blood testing, and they look at the Verify Now. And what this study basically proves that there's not a huge difference in the result and the compliance of those 3 devices. So basically the patient who has a result of 120 PRU, but less than 1, they were considered drug responsive. And that was a study looking at 96 patients. So basically confirming that Verify Now, when we test with Verify Now, there may be a logistic that match with the LTA. Antiplatelet for elective cases now, most of the centers are using today in the US aspirin and ticagrelor, but a lot also still using clopidogrel, and they switched to another P2Y12 when it's not sufficient. And this is an article that was published by a French team that I think report well the selection of drugs that can be used. So aspirin in small dose, like you can see, and the ticagrelor was the drug that was mostly used, a little bit of prasugrel, probably from Turkey, and then clopidogrel. In case of thromboembolic event, they have also looked at which drug was mostly used. I put cangrelor in red over there because they report that cangrelor was used in case of rescue, but keep in mind that cangrelor is a P2Y12. It won't disrupt the clot in front of your eyes, even it's an IV drugs. So I don't know why it was used over there, but you should not consider cangrelor being a rescue drug. You should stick with the G2B3A. Another article that was published by the group over there, it's the group from Canada in Calgary, was to look at those 3 drugs. So there was a systematic review meta-analysis of aspirin plus Plavix, aspirin plus Brilinta, and aspirin plus Effient. And they look at the overall mortality of 2.14, an ischemic complication of 6.89, and hemorrhagic complication of 3.66. So basically 3 regimens were similar in terms of ischemic complication. And aspirin with ticagrelor, because often people say, well, ticagrelor, I'm afraid my patient will bleed more. But aspirin and ticagrelor in combination, low dose of aspirin, were not associated with a higher rate of hemorrhagic complication. In function of the length of treatment, we briefly talked about that this morning. It would be nice to be able to look and see when the utilization of the stent or the flow diverter is done so we can stop the treatment. This is an article, 2 articles, in fact, one from the French study when they look at the length of treatment for flow diverter and stent assist coiling. And what they realized, they have 23% of late complication after flow diverters within 30 days of stopping the dual antiplatelet. And there was a lot of heterogeneity in the length of antiplatelet following stent placement or flow diverter treatment. And in the other study from the group of Sarah Naranayan, they look at a higher rate of ischemic complication were found when Plavix was stopped less than 6 months versus continue more than 6 months. So I think there's a lot still need to be learned in function of the duration of treatment in order to prevent thromboembolic complication with those things. For emergent case, most of the time, aspirin and P2Y12 are used and load the patient, or G2B3A could be used. The role of testing in emergency situation is sometimes tricky. We don't have time to do that. The placement of a shunt also brings some complexity in the choice of the agent and when to do it. The main goal is to prevent the aneurysm for rebleeding in a setting of a subarachnoid hemorrhage. So also one recent article from CAROP, the group from Montpellier, report that dual antiplatelet seems to also be associated with a reduced risk of vasospasm in those patients presenting with subarachnoid hemorrhage. And we can see on the right-hand side what this study and authors reported in function of the drugs of choice chosen for emergency case. There was ticagrelor, clopidogrel, cangrelor taking a little bit more in the G2B3A for emergency case. These are 2 quick references for the neurointerventional field. Easy to read, talking about each drug the way I mentioned it earlier. This is paper I was able to co-author during the COVID pandemic period. So this is just quick reference to have. Quickly on the cangrelor, as you all know, this drug is very quick, act in 3 to 6 minutes, can be reversed very quickly, and it need to be followed by a bolus. So this is just a slide that shows how quick this drug can be reversed if you compare with the other one. And the way it works, it's a kinetics level 1, in fact. So what you see and what you get it's there. So you give the bolus to the patient, but you need to follow by the infusion, otherwise you'll become subtherapeutics. So by following with the infusion, you maintain the patient on a good level of inhibition of antiplatelet. So when those patients are finished, you finish the case, you want to switch the patient to oral. How do you switch to the oral P2Y12 and how to do it? So what's happening is that the drug is binding those platelets, and the drug of choice, which is the easier to use, is the ticagrelor because of the mechanism of action, very similar to cangrelor. If you're stopping the infusion, or as the infusion is going, you decide to give clopidogrel or prasugrel, you're going to have an antiplatelet effect when the second dose is going to do. It's because your platelet are all going to be bound by this reversible cangrelor over there. So the easiest one, it's to switch to ticagrelor. You bolus your patient as you finishing the infusion or during the infusion, and then you continue with the maintenance dose after that. That's the easiest one to use when you're transitioning from cangrelor to oral PA. And what the difference in how you can use it in neuro, in most of the cases, patient that you want to emergently load with antiplatelet because you have either a flow diverter or a stenosis clotting procedure, those patients who cannot take anything orally because of different reasons. These are the main case. The cost, of course, is a big issue, but there was a paper published in a cardiology paper recently that look at the cost of the cangrelor, because sometimes it's the challenge you have to bring it to your hospital. And what they realize is that it's more expensive, yes, but when you compare with the G2B3A, for example, if you're loading your patient, what they also realize is there was less time in the ICU, there was less thromboembolic complication related to the procedure. So the long run in the conclusion over there is that, yes, the drug costs more, but long-term, if you're making an analysis, it may be that you're saving money to your patient by less day in the ICU, switching them to orally much quicker than if a patient will be on the G2B3A, for example. And what this study also shows is that you can also decrease the price by using a smaller bolus than what the cardiology literature is reporting. And we've seen that more and more. These are just neuro paper, including one paper done by Dr. Hanel, where people now have tendency to use a definitely smaller bolus and small infusion, not even the half, but now a quarter of the bolus that is used in cardiology. And they have tested with the PRU, and they have a decent PRU. So it means that this is a potent drugs. In order to save some money, we may be very well that we can test the patient and we can go with 1/4 of the bolus dose and 1/4 of the infusion. And again, this is a P2Y12. So it can be measured with the verified now, like the ticagrelor can be, even it's an IV drugs. The main pitfall, as I mentioned, it's expensive. One thing to keep in mind, it's not a rescue drug. So you cannot use it if you have clot formation or thromboembolic event during a procedure. Stick with the G2B3A. And there's few publications in a row, not enough. But slowly and what the cardiology are proving us is that the drug is efficient, it's pretty safe. And that's what we're starting saying also in the neuro literature. So the future, I think some new drugs like PAR4, which focus more on the thrombin, may be something useful. Also, we have this G2B4 that's coming and maybe an oral drug to take. The device, I think it's where we focusing right now and where the direction may go. Mainly with the surface modification, hydrophilic coating, like the phosphorylcholine, PMA, HCP, heparin coating. And again, we're not there yet, but maybe with those medications, we'll need to use only one dural antiplatelet to eventually maybe will prove that those surface modification could prevent us to give antiplatelet to those patients. That will be great. And of course, more trial, at least prospective study, we need to accumulate more data in order to prove safety and efficacy. Because most of the time when we put a new drug on the market, something new, we extrapolate it from the cardiology literature. So one thing that is coming, the SNIS as Standard and Guidelines Committee that put publication in 2014 talking about testing, not testing the different drugs. The good news, and I'm part of a committee that's reviewing those standards right now, and publication will come pretty soon, where we're trying to build some clinical evidence mainly built on the cardiology literature, but also try to extrapolating to what has been published so far in the neuro literature. So there's something coming up hopefully in the next month. But that if we keep the platelet on the bench and we not get involved in the procedure, I think we're in good shape. Thank you so much.
Thank you, Lucy. I can definitely relate to those platelets. And we have time for two quick questions for Lucy. We want to preserve your lunchtime, and we have 3 great talks before the lunch break. So, any questions for Lucy? So another good one on ticagrelor is we are part of a clinical trial, just like Praxabind for Pradaxa. There is a reversal agent for ticagrelor currently being studied. So if somebody comes to the emergency room with a bleed, you can give a medication that will immediately reverse ticagrelor. So for those of us that are in emergency room and deal with brain bleeds and so forth, so on side effects of these medications when you're dealing with a bleed, I think it'd be great. For me, it's our choice when cost is not an issue. But the fact that you can reverse that, I think will increase the safety profile of the drug, and I think that would make even better for treatment of our patients with that. So the study is ongoing. We'll see when it's going to be done.
Yeah, I know you guys were part of a center, right? You were one of the center that was involved in the study.
To see on the testing, like if you do just verify now, do antiplatelet conventional setup, many people say doing clinic or do before the surgery start, but we all know that it kind of seems to vary quite a bit. Any thoughts on that, or what's the ideal timing prior to surgery to check, assuming you took 5 days of do antiplatelets, and what is your recommendation on that?
Normally what they say, take about 2 hours after the patient has taken his pill. So if he's taking it like 8 o'clock in the morning, try to do the test 10 hours later when he's on the maintenance dose. So you have the absorption and you can see what's under the curve over there. That's normally what is recommended.
Yeah, no, I guess the question for us, we tend to do this at the day of the procedure more and more as opposed to doing clinic, because we just learned that there is a fluctuation. You want to know almost the state at the day of the procedure as opposed to many days before. In trials, sometimes we're asked to do upfront, but that I think it doesn't apply to the patient the day of the procedure.
Yeah.
So.
Yeah.
Thank you, Lucy.
You're welcome.
Our next speaker is Professor Adam Malik, a dear friend from many different interactions throughout the years. He is working in many exciting things. We talked about this earlier today. His first talk is on the endovascular management of normal pressure hydrocephalus. It has been a disease typically treated with shunts. You guys will be wowed by the work that Dr. Malik and his team have been doing with that. And I think we're on the verge of something that is very important to our patients. Thank you, Adam, for being here.
Thank you very much for the invitation. It's an honor to come here and be among friends, but about some of the work we've been doing with the endovascular management of hydrocephalus. These are my disclosures. I'm co-founder of Ceravasc, which makes the eShunt, and I also consult for Cirrus. So hydrocephalus is buildup of fluid in the brain, and usually it results in dilated ventricles. As you can see in this patient that has dilated frontal horns, temporal horns, third ventricle, as well as evidence of transependymal flow as the CSF is literally going through the ependymum. There are 2 types: communicating hydrocephalus, which is the most common, and obstructive hydrocephalus. They can be differentiated usually with obstructive hydrocephalus resulting from a narrowing or an occlusion of the aqueduct of Sylvius, which connects the third and fourth ventricles. The current standard of care involves using a surgical VP shunt or ventriculoperitoneal shunt. It's a procedure which involves placement of a catheter into the ventricle through the brain, drilling a burr hole, then under the scalp, passing the tubing. There's usually a valve that enables us to control the amount of pressure at which the flow begins. There's also usually an anti-siphon device here, because when the patient stands up, there's a tendency for the fluid to actually start flowing in the siphon mechanism. And there's an incision in the abdomen where you have to reach the peritoneum to put the distal tubing. So the entire side of the patient is prepped and usually 3 incisions. This is what you get after the procedure. You check for placement of ventricular catheter. The catheter goes across the chest and then into the peritoneum. Now, there is no relationship between the pressure in the brain and the pressure in the peritoneal cavity. And so a number of complications can occur. One of them, as you can see here, is the presence of subdural fluid collections as a result of overdrainage, usually related either to a low pressure in the valve setting or to a siphon effect where the patient stands up and they get overdrainage. The other problem is, of course, although this is one of the simplest procedures that we train on, and now with stereotactic guidance, it's possible to get good, accurate targeting, but nonetheless, you still have malpositioned catheters, which can go through and affect eloquent portions of the brain. And of course, there's a complication with patients that are on some anticoagulant or antiplatelet medication, and sometimes even when they're on neither, when you can get a hemorrhage as a result of passing through the brain parenchyma itself. You have other challenges related to VP shunting. One is overdrainage, and you can have collapsed ventricles in patients with idiopathic intracranial hypertension, for instance, and having to replace this catheter, let's say if there's an infection, becomes a daunting task to actually find that track and aim for that single spot. And of course, you know, just the overall increase in BMI across the world, you have a tendency to have more complications with distal shunt malposition. VP shunt failures have been well documented, and they can be up to 40% within the first 2 years. It can be quite frustrating both for patients and clinician alike. We all have patients that have had shunts for over 20 years without any complications, but also a number of them that have required multiple revisions. And so, as you have heard from the multiple other talks from my colleagues, aneurysm treatment has really been revolutionized. It went from open microsurgical clipping, which we all really enjoy technically, to much more advanced, you know, combined techniques with stents, coils, fluid diverters. And one of the things that got us interested, me and my colleague Carl Hellman, was he was always amusing and upset that we were stealing all the good cases, and he'd still have to come in the middle of the night to do a shunt revision. And so we got, you know, started talking about 10, close to 12 years ago now, about how can we come up with an endovascular solution to take away those painful cases, kind of treat hydrocephalus in a novel way. And as you know, the CSF is actually absorbed by these structures near the venous sinuses called arachnoid granulations, which act as passive filters of the CSF back into the venous system. And so the idea was, can we come up with a biomimetic device that can replicate these arachnoid granulations? Looking at different sites where the CSF adjacent to the venous system, the one that we thought was the one that would enable us the safest and simplest approach without compromising the existing venous system. For instance, if we were to use a transverse sinus, then that could put it at risk for thrombosing or clotting or injury. And so we decided to choose the inferior petrosal sinus, which is a highway that we use for many endovascular treatments, such as carotid cavernous fistulas, which are treated usually by a transvenous approach through the inferior petrosal sinus. And so through the help of many over the last 8 years, we founded this company Ceravasc that makes this e-shunt system effectively a biomimetic device that tries to reproduce the function of the arachnoid granulation. This is the actual device itself. It has a malacot, which will sit inside the CSF cistern, and it will actually drain into the jugular vein. It has a slit valve, which prevents backflow. If the patient coughs or bears down, we know that the ICP shoots up transiently. It's usually followed by a CSF pressure going up as well. So it's a transient phenomenon, but nonetheless, that prevents blood reflux into the system. And so the inferior petrosal sinus is very familiar to the interventional endovascularly trained operator. It is a vein that's encased in the bone and effectively is encircled by bone on 270 degrees, if you will, but on this side it has dura, and it basically separates, this dura separates the inferior petrosal sinus vein from the CSF cistern. And so the goal would be to place this device across this dura. So to do that, we devised a two-step system, which involves using off-the-shelf standard catheters. Here is a 6-French guide catheter that you use in the internal jugular vein. It's a transfemoral approach, can potentially be also done from the arm or even the internal jugular itself. And then you use a microcatheter to select the cavernous sinus, where you deploy a small anchor, and the anchor will provide a highway to use a rapid exchange system for delivery. This is what the anchor looks like. And what's special about it is it has a flat trail, which enables a very low profile for the system. And the second part of the system is this delivery catheter, which has a needle on it, which is protected by a guard that effectively enables us to navigate it into position and then retract the guard when at the target position, gently enabling us to advance through the dura into the CP angle cistern to deliver the E-shunt. The E-shunt itself is preloaded inside the needle. So again, this is the flat trail that you see. This is the needle guard that protects it. There's 2 wires that enable us to retract the needle guard. And as you can see, the flat trail enables a much lower profile for the system. If it was a round wire, it would make the whole system larger. And so the system is about 4 French, 4.2 French in size. Another safety feature is the fact that the flat trail exits at a certain set location, so that when you are advancing, if an operator is inattentive or ham-handed, they will not be able to penetrate beyond a certain depth, thereby protecting the nervous structures. The E-shunt itself is held in place by this micro stent called a shroud, and enable you to kind of really control it until the final release. And this is what it looks like live. It's a very small device. It's an 0165 lumen, and you'd think that's very small, but actually because of the short distance and the small size, there's very little resistance to the flow. This is seeing the valve in action. You have a high pressure in the CSF, which you see here in blue. We did experiments in a sheep model to assess the safety of going through the vein into the CSF cistern. Now, the CSF pressure is usually higher than the vein, so this is a lucky condition for us, because we were able to penetrate through the torcula into the cerebellar cistern and actually get a CAT scan showing no blood on multiple animals. And this is the CSF from the cistern through a tubing of similar size. So then how do we deliver this device now that we have it using an endovascular approach? To do this, we analyzed a number of MRI that we had from patients undergoing gamma knife or trigeminal neuralgia in multiple decades, and characterized using 3D software the cistern and the inferior petrosal sinus itself that you see right here. This is a jugular vein and the jugular bulb going to the inferior petrosal sinus and up to the cavernous sinus. And basically, we plan to deploy the system by going across at this site. So we published this data with this full characterization of the anatomy, and then moved on to trying this delivery system in cadaveric specimens using the actual angio suite with a Lexel frame to immobilize the skull. And this is the target of exit. We found this technique called 3D road mapping that is available in most of our angiography suite, and we rarely use, very useful. And what effectively it does is it enables you to select the spot in 3D space on the model, and then send it over to the fluorography machine, so that when you move your C-arm anyway, the point will be there in space. And as you magnify your image, that point will be constantly available as a reference to guide you in your device placement. So this is a quick video showing how you get a 3D rotational angiogram with a microcatheter in the cavernous sinus. You select the site of entry. You basically cut out, this is on the Siemens machine, but same thing on Philips. And when you have that, you send it to the machine. This is your exit site and the IPS. Then you can see here we're advancing the anchor. Excuse me. Sorry about that. We're advancing the anchor here. And as the anchor is deployed, that provides for the flat trail. And then we then work in the projection to be orthogonal to the exit site. Here's the delivery catheter. We're unsheathing the needle. And then as you pull out the needle, then you can advance the needle, go through the dura into the CP angle cistern, and then deploy the E-shunt. You can see the malachite flowering, and then you can tug it back against the dura. And so now the malachite is actually in the cistern. Then you go back and recover the anchor, which is just a temporary device. This is what it looks like in the cadaver at the site. This is a jugular tubercle. It's halfway point in jugular tubercle, and that's basically the exit site of the device. Again, showing the 3D road mapping, unsheathing of the needle, and then deployment of the device. So what if the device gets infected? What if the patient has an infection of the CSF or meningitis? Well, it's possible to retrieve it. This is a snare. You can actually grab the device and pull it gently back. It'll collapse the malachite through the dura, and dura will self-seal. So our strategy was basically first to start a first-in-human study, and then hopefully lead to a pilot studies in the US, and eventually to a pivotal trial. Right now, I'm going to show you some data from the first-in-human that was done with our colleague, Dr. Lilik in Buenos Aires, and also the first case of one of our pilot studies here in the US. So we set out to connect with Dr. Lilik. We had him come and visit Boston and do some training. He has a very unique background, having trained neurosurgery, also in pediatrics. We also trained at kind of close sister institutions. He trained at UCLA, I trained at UCSF, so it was always a little bit of competition, but we're always very friendly. And so we went down to Argentina and set up the trial, and this is the first-in-human results. In order to first determine whether this would work, we thought the best patient population would be patients with subarachnoid hemorrhage that already have an external ventricular drain, so we could actually measure their pressure and document that this device is actually working. And so those are patients that basically have subarachnoid hemorrhage, came in requiring a drain, and then after about 7 days, when they got an EVD clamp test, could not be weaned and had a spike in their ICP, suggesting they would go on to require a actual VP shunt. And so those patients were included. And then obviously there were anatomical considerations that will go in this study. So this is the first patient presented with a subarachnoid hemorrhage from a ruptured MCA aneurysm, which was coiled by Dr. Lilik's team. And then on subsequent testing, this is the clamp test of the EVD. You can see that the ICP spiked and the patient did not tolerate an EVD wean. And so she was enrolled. The anatomical imaging, we use a T1 weighted gadolinium study that shows you the depth of the cistern, as well as the path of the IPS that you can follow here and its diameter. We also do segmentation where we separate the IPS that you see in purple here, and in red, any arteries. Usually it's a branch of ICA, possibly PICA, or sometimes even the vertebral artery can swing by close to the site. And that will help you decide whether you choose one side versus the other, or whether the patient is not a candidate. This is the actual procedure, first in human case. Dr. Lilik performing already has the anchor in position, and he's actually pulling back. And you're going to see the needle guard come back. And then as the system is pulled back, you see it will straighten. This is what we call the straight shot approach. And that really leverages the whole fact that the IPS makes a curve. And that's what enabled us to then use a straight shot approach across the dura into the cistern. So the needle is exposed at this point. And now you see as Dr. Lilik pulls back the system, it aligns, Now we can advance and process the dura.
Well, Evie's with her, so I think that she's gonna be all right. When we were at summer
Actually
camp,
performed a
Chloe
run
was
to show
super
that even
afraid
though
of
the needles
anything
across
at
the
all.
dura, there's actually no contrast
Really?
leakage
Well,
into
girls
the
got one of hers.
cistern
You
or
can
CSF.
imagine.
And at this point, the E shunt was advanced, and then you can see it as the malachite opens and flowers, it will tend to plop down, and this is a sure sign that you're not in the IPS. And at this point, it involves stabilizing the malachite with the shroud and pulling the shroud back until it's released. And then the anchor is then removed. So what happened to the patient? Because we had the EVD in place, we're able to measure the ICP. So this is the ICP that decreased after the placement of the E-shunt. And this is really the first time, many firsts. One is the first time that you're able to access the central nervous system percutaneously through a catheter system. And the first time that this concept of placing a miniature shunt enables you to actually decrease the ICP. This is the malachite can be imaged with a regular CAT scan, and this is a cone beam CT showing the path of the body of the E-shunt into the IJ. And so the ICP stayed down, and then you can see some variation as the patient was turned and so on, and eventually was removed at day 36. These 4 more cases showed the similar pattern of decrease in ICP, and so all the primary endpoint was met, which is the ability to remove the EVD at 36 hours. What I want to talk to you today is something that really involves a very large part of the population, which is normal pressure hydrocephalus. It involves the elderly. It's probably thought to involve up to 700,000 patients in the US. It's one of the major causes of dementia, and it's a big social cost, in terms of both families that, place their loved ones in nursing homes, as well as, the need to kind of take care of patients that are debilitated by this. It is effectively characterized by impaired gait, cognitive dysfunction, and urinary incontinence. This is the classic triad, mostly is impaired gait as the first one. This is a very nice case study that was published in the New England Journal, a group from Harvard that shows a typical appearance of normal pressure hydrocephalus with computation of the Evans ratio, the beaking of the ventricles. And this is a picture of the patient before a shunt was placed. This is just a conventional VP shunt. And you can see how she's got very shuffling gait, where, it's kind of hunched over and really debilitated. This is after her shunt was placed, I believe around a week. You can see that she's already walking more upright, she's more spontaneous. And the next video is extended follow-up. You can see a completely different person who's independent and actually is able to walk very fast. And so one of the assessments for this and the response is something called the time up and go test, or TUG test, where you actually check the gait and how it's affected by shunting. A lot of patients undergo a test procedure where they have a high volume lumbar tap, and then their gait is tested. And if the gait improves, there's a high probability that would benefit from a shunt. Unfortunately, in this population, VP shunt can have a high risk. A lot of these patients are over 7 years old and are frail, and then the 3 incision and the anesthesia and the discomfort can sometimes throw them for a loop. So when you look at the number of patients that you help with, this is one that may develop complication from the procedure. Not all neurosurgeons offer this as aggressively as they probably should. So we thought that a minimally invasive approach may help. This is a patient in Buenos Aires, the first patient that had the part of the MPH trial. Again, you can see the IPS was kind of adequate size, and the cistern was appropriate. And this is actually the system being deployed. You can actually see the access across the dura. You can see the malachite here coming out of the delivery system, and this is the final result. This is actually a 30-day follow-up. You ask, how can you check for the patency of the device? One possibility is by using gadolinium cisternography. And you can actually trace that, and you can see this accumulation of gadolinium in the jugular bulb after the CSF is actually injected with gadolinium on the side of the E-shunt, but not on the contralateral side, consistent with the E-shunt patency. So at the 30 days and 90 days, there was improvement in the patient gait, the urinary incontinence, and the cognitive impairment. All were improved. This is on the left is the walk gait pre-treatment. You can see the gait is a little hesitant, careful. And on the right is at 90-day. A little more self-assured. So the 30-day results in the first 3 patients all show improvement, both in the top time up and go gait test by about 28%, improvement in the MoCA or the cognitive ability, as well as improvement in the bladder symptoms as well. And this is the 90-day test for one of the patients, which continues to show improvement in gait and cognitive impairment and urinary incontinence. Now, there are obviously anatomical considerations sometimes. This is an interesting patient we sought to enroll. And then actually, if you look at the segmentation here, we also segmented the bone. You'll see that although you can see the inferior petrosal sinus, this is one of those anatomical variants where the IPS is actually encased in bone and actually has no connection with the dura. And you can actually see that on the MRI as well. So anatomical screening is very important. This is a rare finding, but it just tells you that just like when you're treating a 2-millimeter aneurysm, you need to know what the anatomy looks like ahead of time as you're embarking on the endovascular procedure. I think I've already mentioned some of these results, but the point is, how do we compare surgery to an endovascular solution? Of course, we're extremely early. These are all preliminary studies, but usually the length of stay for the E-shunt has been, most of these patients could have been discharged the same day of the procedure. These were all done under general anesthesia, but were kept in for about a median time of 1.7 days. We have not had a procedural complication at this point. We recently started a IDE study for NPH in the United States, and this is our first patient that we just treated at Yale. This is the CAT scan and the MRI, and you can see the inferior petrosal sinus. This is the segmentation showing the loop of ICA and its relationship to our exit site. You can see we have more than 6 millimeters along the vector, which is what we need for safety. And we also look at the segmentation of the bone to make sure there's a good bony channel with that overhang that would interfere with the advancement of the device. This is, again, in New Haven. You can see the anchor, and this is the system where we have to access the cistern, and this is the device being placed. So in conclusion, percutaneous endovascular transluminal access to the central nervous system has really been shown to be feasible and reproducible. Transvenous to cisternal access can be done safely with proper pre-op 3D imaging and careful planning. The proof of concept of using a shunt has been shown to result in decreased ICP. And the Ceravasc E-shunt is a minimally invasive approach that could potentially be a solution not only for communicating hydrocephalus, but for normal pressure hydrocephalus. And we're hoping to enroll, multi-centers and obviously have a much longer follow-up period so we can confirm the efficacy and safety. So thank you very much.
Thank you, Adele. I saw a question there on the chat. I'm gonna get the name of the person asking the question. The question was, is this only for adult population or also for pediatrics?
Yeah, that's a great question. As you know, obviously, The system does have a certain size in it, and we are at this point centering on adults, possibly young adults, but really adult patients. Hopefully with time, we'll be able to miniaturize it as, technologies improve and imaging as well as, miniaturization. But at this point, it's for adults.
Thank you. Anything else, guys, for Professor Malik here?
No, just so I know you did a lot of the anatomical data is very helpful and allows us to have safety and planning the procedure and executing. Was any type of physiological impact? And I totally understand if you have, let's say, one inferior petrosal sinus as ideal, is there a compromising flow on that sinus if this is the only way that drains? I mean, is there any other physiological information that is important to consider here, or it doesn't matter?
No, that's a great point. I mean, as you know, you and I both have coiled cavernous fistulas and shut down and coiled the entire IPS. And usually patient has no complications. Luckily, we actually have follow-up MRIs, and we've found that there is no thrombosis of the IPS. So the IPS remains patent. The device has a heparin coating on it, and it actually goes through the IPS, but it's much smaller and ends in the jugular vein. But that's a great point.
Got another question from Zimbabwe. What is the rate of other shunt complications such as shunt infection?
For this device? Yeah, we have had one case of a patient who had a ventricular catheter for a long period of time, and that had possible early low-grade infection that developed an infection. And so we were actually able to pull the e-shunt device with that snare technique that I showed, and the patient made a recovery. So. Great, thank you very much.
Thank you, thank you. And our last speaker that is also a frequent flyer here with us, Professor Matt Guinness from UMass Worcester, Massachusetts, is going to talk to us about new developments in brain aneurysm treatment directly from his lab to the world. I think we have the recorded version because of instability of the signal. We're going to play that, and then I think Matt is available to join us for question and answer. We may push 10 minutes late to lunch. Sorry, we're trying. And then we'll go start 10 minutes later. Okay. Can we play Dr. Guinness talk?
Morning, everyone, and thank you so much, Ricardo and Eric, for the kind invitation. I regret deeply that I can't be there in person, but promise next year I will be there. Today, I'm going to discuss new developments in brain aneurysm treatment. I'm not going to discuss intrasaccular devices since that was already covered by Ansar Rai earlier today. So I'll talk about endoluminal devices and new exciting features that are coming with regard to coatings. I have to disclose with respect to this talk that I'm a consultant for both Stryker and Medtronic, and Phoenix, all of which have coated devices. A lot of the experiments I'll show were funded by Stryker Neurovascular. Surface modifications, and the ultimate goal, of course, to reduce the need for dual antiplatelet therapy or reduce the duration of dual antiplatelet therapy. And everything that we know about this is really hundreds of years old, coming from Virchow and the triad, which describes how throat clot is formed. And that could be as a result of circulatory stasis. So blood flow is important as platelets are activated in areas of recirculating blood flow, as shown here by this work by Edelman years ago. When you change the profile of a stent, for example, and you have these recirculation zones, distal to these stent struts, you have accumulation of platelets. Of course, the blood products themselves, as you know, this is just an example showing that in the setting of subarachnoid hemorrhage, clotting time it changes. So this is an important element. And of course, vascular trauma. If you injure the vessel, that's the body's normal response to help seal that injury, is to form clot. And as this is the extrinsic pathway, which I'll cover in a minute. And so here, you know, the first thing is the intrinsic pathway. You put a foreign body into the blood vessel. It is recognized by the blood products themselves, and there could be circulatory changes. And so ultimately you have accumulation of thrombus as a result of the intrinsic pathway. But more importantly, as you manipulate, and this is just a anterior spinal artery of a dog where we had placed a microcatheter, you can actually see where the microcatheter went on this SEM, unfast preparation of the vessel. And beyond that, this is actually where the wire went. So even micro wires, you know, you can remove the endothelium at a very small force of 309 per centimeter squared. So as you expose the subendothelial matrix, you of course get the accumulation of clot. That's the normal process. As you expose collagen and von Willebrand factor. So there's a variety of things that have happened that are very exciting to have antithrombogenic coating. So we have using either a sugar or a fat to hide the device from the body. This is called biomimicry, and it's been around since the 80s, this concept. Phosphorylcholine was originally described in 1982 as a material by which you could hide the device from the blood products. So this is addressing solely the intrinsic pathway. There's little data on this. I'll show a little bit toward the end of the talk on using CD31, for example, or CD34 to grab circulating progenitor cells or endothelium that are migrating to attract them to the device. There's this X coating for microvention that's out there. It is right now labeled as an anti-friction device, but there is data accumulating that might move this into the antithrombogenic category. But now I want to talk about active coating, which is coatings that address both the intrinsic, so the contact activation pathway from the stent surface, introducing that foreign body, but also addressing the extrinsic pathway. And this is done by using covalently bound heparin, which reduces, it activates antithrombin, so it reduces clot formation due to both of these intrinsic and extrinsic pathways. And it's been shown that if you basically delay the deposition of a fibrin matrix, that also reduces the accumulation of platelets. So it's both anticoagulant and has antiplatelet effects. This is developed by Carmita, who's been doing this for a very long time, I think almost 3 decades. And it was developed originally for the coronary circulation. We have wonderful data from the HEPACOAT trial, the HOPE study, which showed that the heparin coating in the coronary circulation reduced, protected the stent from thrombosis. And although these data were incredibly compelling, the problem in the coronary circulation wasn't just thrombosis, it was more importantly, total late loss or restenosis. And that was being addressed at that time in the early 2000s with drug-eluting stents, which are anti-proliferative medications are eluted. And so you don't have restenosis of the vessel, and that was the key problem. So this technology kind of went by the wayside for the coronary circulation. But I think for neurovascular, this could be a really exciting approach. And so Stryker has developed, you know, the standard, what everybody's done with these in vitro flow loop models. This is the Chandler loop, and this is a more aggressive model using a roller pump, which activates blood products. So there's more likely to be thrombus. And they're showing here with this active heparin coated that, you know, qualitatively and quantitatively, you have reduction of thrombus. But again, this really only addresses the intrinsic pathway. And so we wanted to use a model that looks at both categories. So as you deploy a flow diverter and you do the manipulations to get good wall apposition, you of course cause a vascular trauma. And so can we prevent thrombus accumulation and thromboembolic events in that setting? And so to do that, we implanted the basilar artery of the dog. Just want to highlight that it was actually Ricardo and Elad Levy and Eric who taught me how to do this basilar implant. It's actually quite simple. We go through an anastomosis between the anterior spinal artery and the vertebral artery, and it's a relatively straight path to the vertebrobasilar junction and up into the basilar artery. What we did was we implanted 2 overlapping flow diverters in the artery. And then we did high frequency optical coherence tomography, which Demetrius has presented earlier today. And then we did weekly MRI. Really, our primary goal at the time was to look for areas of restricted diffusion indicative of thromboembolic events, but we also acquired flare and susceptibility weighted imaging. We, of course, did neurological exams, and then we did neuropathology at the end of the experiment. And we implanted, I'm just going to focus on our confirmatory results, 7 bare overlapping stents, so a total of 14 stents. And then we compared that to the heparin coated stents. The heparin coating is by Carmita, which is a wholly owned subsidiary of Gore, and they have entered into a relationship with Stryker to develop this technology for neurovascular. So here's an illustrative case of a bare implant where you can see we cause a significant straightening of the basilar artery post-implant with these 2 overlapping flow diverters. 30 days later, we have complete occlusion of the mid-basilar segment, actually in the area of the overlap, which is confirmed histologically. We can see on the post-procedure high-frequency optical coherence tomography thrombus accumulation over a perforating artery. This happens to be the ICA. And then we see on MRI, post-procedure 1 week, 2 week, all the way up to 8 weeks, we see the appearance of these magnetic susceptibility artifacts on SWI imaging, which we believe, based on the locations and their appearance, that these are thromboembolic complications. These are microhemorrhages as a result of an ischemic transformation to hemorrhage or the blood clot themselves. And here you can see an illustrative case of a heparin-coated stent. Again, straightening of that basilar artery, a little bit of thrombus accumulation, not over the origin of side branches on high frequency optical coherence tomography, a very nice intimal response, and then just one of these lesions post-procedurally, none on follow-up. Now, what was interesting is that the basilar arteries, independent of heparin coating or no heparin coating, bare stents, did cause occlusion of the mid-basilar segment in the overlap zone. I do want to highlight that these animals were not on any dual antiplatelet therapy. So there's no antiplatelet medication given to the animals. That was done because dogs are fibrinolytic, and we really wanted to test the effect of the heparin coating. But what was interesting was that we did do routine TOF MRI, and we found that if the top of the basilar was present in the TOF, of course, in the area of the stent, we have a loss of signal. But if the top of the basilar was present, that was perfectly correlated with a patent basilar artery, whereas if it was missing, that was perfectly correlated with an occluded artery. And so using this as a surrogate, we found that the coated devices, the heparin coated, the active coating, reduced the time of occlusion in those animals that occluded by 1 week. So in the case of the bare stents, they were all occluded 1 week post-implant, whereas in the case of the heparin coated stents, that was delayed by a week. Another interesting finding is if we took a measure of the acute thrombus that formed during the procedure, and we looked at the number of these susceptibility artifacts on SWI imaging, what was interesting is that they were perfectly correlated with a very strong relationship that was obviously statistically significant, and it explained 80% of the variation of the data, highlighting that the post-procedural MSAs seem to be correlated with the amount of thrombus that formed on the surface of the stent. Another interesting finding is that all flare abnormalities, as shown here, were either preceded or coincided with one of these susceptibility artifacts. And then here's a pathological confirmation. These are very, very small. On histology, it's nearly like looking for a needle in a haystack. So we found that one area that correlated with susceptibility weighted imaging artifact did indeed show histopathological evidence of emboli. If you look at the data altogether in terms of these susceptibility artifacts, we found that post-procedurally it was not statistically different, but it seemed that the coated stents had fewer, the coated stents had fewer of these lesions as compared to the uncoated stents. And then this continued it from 1 week all the way to the completion of the study at 8 weeks. This coincided, or this was statistically different. There were more susceptibility artifacts on bare stents as compared to animals treated with the heparin-coated stents. Heparin coating is a really great first step because we have 30 years of experience with it. The technology is very well developed. It's very complex technology. But there might be other targets, and I think this is some interesting work out of France where they have bound 2B3A inhibitors and factor 10A inhibitors to the surface of metal. But there's another approach completely different than trying to prevent the formation of thrombus on the surface of these devices, and that is to reduce the duration for which dual antiplatelet therapy is required. And Satoshi Tatashima at UCLA has done some really interesting work. And what's nice about this is that it's just using UV light to passivate nickel titanium. And what he's shown is that this UV passivation increased albumin absorption, it increased endothelial cell migration and their attachment to the device. So the idea being, can you get a faster healing of the device so that you can ultimately reduce the duration of dual antiplatelet therapy? Our lab has shown that when we implanted flow diverters in rabbit aneurysm models, that endothelial progenitor cells, which are shown here, we use a compound that binds these nanoparticles, gold nanoparticles, to CD31. And what we find is that indeed these are endothelial progenitor cells, and they play an important role in flow diverter healing. And the question is, can you use, this is technology again developed for the coronary system, where they take CD34 antibodies and they attach them to the blood surface of the device. And the idea, of course, being to have a more rapid endothelialization of the device and reduce the risk of thrombosis. There's some great work being done by Émeric Richard in Limoges, France, where they're looking, I think they're working with silk technology from Balt, and they are using a P8RI peptide, which is a mimic of CD34. And that's, again, to take migrating endothelial cells and have them more rapidly attached to the surface of the device. And here in their rabbit model, they're showing that you have fast cell proliferation. This is the peptide treated device versus a bare device, and you have complete healing of this device at the same time point as compared to the bare. Well, how do we look at these new coatings? Because there's a lot of them under development. And we've been working in the canine basilar artery. This is yet not to be published, but we've done bilateral MCA stenting. So we can put a bare stent on one side or a coated stent on the other side. And in the same animal, we can track not only the progression of healing using optical coherence tomography, but we can also use MRI to track what we really care about, which is the risk of thromboembolic complications. So I'm really excited about this model. We do have to work on our diffusion sequence. We don't have adequate resolution to look for very small events. So we are working on that. I think optical coherence tomography, as presented by Demetrius earlier today, is a really valuable tool to assess not only the healing, but the presence of thrombus on the surface of the device. And I'd say it's one of the most studied technologies I've personally ever worked on. In vitro, we've done more than 30 phantoms. We've acquired more than 800 OCT imaging sessions and 550 cases across a wide range of preclinical models, rabbits, dogs, sheep, pigs, and even non-human primates. And we've recently done about 50 pullbacks and cadavers. Again, Demetrius has shown this, but this is the importance of this technology, is that it can take an image in tortuosity. That's a key advancement, because existing commercial technologies really don't work well in any kind of tortuosity, which is the space that you work in. And a really interesting finding by my colleague, Vania Anagnastakou, is the ability to image through the blood vessel wall and actually image the subarachnoid space. So you can see the subarachnoid structures. And I think this is going to be very interesting in our understanding of other disease states, such as traumatic brain injury, where these structures that are the mechanical support system for the subarachnoid space are not even modeled. And I think we can learn a lot by including these in our models. And just, I want to highlight, you can see perforating vessels. You can see how the origin of these perforating arteries and where they penetrate the pia. You can also see the connections of the subarachnoid trabeculate to the arteries. So this is a really exciting development. And we've also done some work where we're showing here doing a static imaging. So we hold the probe still and then we image over time. So we get one 40 micron slice, and you can see the motion, the relative motion and strains of these subarachnoid structures. And here, this is the first acquired image of an OCT in a human model. It's a cadaver where we went from the M3 segment and imaged all the way down to the M1, confirming that the device can work in the tortuosity of the human. And here is just a 3D rendering of the subarachnoid structures through the posterior cerebral artery. I'd like to conclude with something a little bit futuristic. This is a collaboration between our center and the Technion, working with Mark Epstein, who's now a postdoc in my lab, and his advisor, Nadi Karin, where the idea of pharmaceutical treatment of aneurysms is really goes from the beginning of the field, where I think it was the first endovascular attempt to treat an aneurysm was injecting ferromagnetic particles and then using a magnet to isolate them into the aneurysm. There's a lot of research that's been done on loading nanoparticles, but none of this has reached clinical translation. Of course, there were endovascular trials in the early 2000s looking at filler glues, their onyx and super glue, but most of those trials have failed. But these could be polymer structures for which you could elute a drug of choice. And so our hypothesis was that we could leverage the difference of hemodynamics within the aneurysm, which has velocities in the order an order of magnitude less than in the parent vessel, and we could use these and design nanoparticles that would then, because of these hemodynamic differences, would accumulate within aneurysms. And so we're doing an in vitro pulsatile model where the aneurysms are fabricated. They're coated with collagen endothelial cells, and then a pulsatile flow system is used to deliver viscosity matching to blood analogs. And working with Professor Gavatz in Tübingen, we've functionalized these nanoparticles by coating them with glycoprotein 6, which is helping to bind to collagen, which exposed collagen is a known risk factor for aneurysm rupture. And here's our model where you can see localized accumulation of the particles in a blood flow field in the areas where collagen was exposed. And this was statistically different as compared to control. We went on to test this in a new aneurysm model that we developed in the lab, where we do in situ decellularization of the aneurysm. We completely remove all the endothelium and all the smooth muscle cells within the wall of the aneurysm, making a very unstable aneurysm that's prone to inflammation and dramatic growth throughout the entire duration that we studied it, which was up to 12 weeks. And we found that when we inject, through a microcatheter, we inject these nanoparticles proximal to the aneurysm, we found that there was an accumulation of particles that was 5 times higher than in the parent artery that was used as a control. And you can see colocalization of the accumulation of the nanoparticles binding to exposed collagen. What's exciting about this is these are just nanoparticles. They don't have a payload yet, but we're thinking ultimately that we could load them with maybe a radiopacifying agent that could be used. Maybe we could start screening for aneurysms with a simple plain film X-ray to see if using these particles to see if there's accumulation that would be suggestive of an aneurysm. Since they bind to collagen, we could also use them potentially to screen with MRI agents, for example, to see at-risk aneurysms. We know the patient has an aneurysm, but if there's accumulation of these nanoparticles, the aneurysm may be at risk. And of course, looking way into the future, could we load drugs that target things that basically destabilize the aneurysm wall? We've done a lot of work on myeloperoxidase in my lab, and that might be a viable target. So thank you so much for your attention. I am here with you, so I'd be happy to take any questions. I just want to give a credit to a huge number of people who work in the lab and collaborators around the world. And again, wish you a wonderful meeting, and thank you so much for the invitation.
We have 6 minutes for questions for Professor Gunas. And you guys saw it is recorded, he promised. So next year we have our first speaker already signed or that. So I have you recorded, man. Can you hear us there?
I can hear you perfectly. How you guys doing?
Awesome. Thank you, man, for being here and doing this. Any questions for Matt?
Hello, Matthew. Good afternoon.
Hello.
So to the HEPA-coded, or the heparin-coded flow diverter that you presented, the HEPA code, the coronary BX velocity was heparin-coded that would consume over the 3 months period. What is the difference to this HEPA-coded? Is that permanent or does it also consume over time? That's the first question.
Yeah, excellent question, AJ, and good to see you. So It is, first of all, the HEPA coat is, from my understanding, almost identical. I mean, obviously, there's been some evolution of the technology over the last 20 years, but it's a very similar coating, and it's an excellent question. By the way, one of the most painful things in the world is to watch yourself give a talk, but I didn't mention it in a talk, and it's really an important point. It's covalently bound. It's not eluting heparin. So it's covalently bound to the stent, has no systemic effect. And, typically these flow diverters are being incorporated within the wall. In our animal models, it actually happens really quick, because they're young and they're healthy, and it's about 2 weeks. But we think in humans, it's probably, on the order of a month. And yes, basically the drug is available and active for the entire duration.
And Matthew, the other question was, when you place the devices in the basilar artery, you see a straightening effect that you emphasized in your talk. How much is, when you see the occlusion of the basilar, related to an injury, a chronic injury by straightening the vessel, rather than by clotting cascade, which in dog is probably different than in humans?
Yeah, that's another really good point. And I have to just say, and again, I failed to mention it in my recording, it's an incredibly aggressive model. I think if I had proposed to you before doing the study, AJ, I want to implant overlapping flow diverters in a 1.3 millimeter artery and not give any antiplatelet medication, you would say I'm insane. I'm frankly surprised that they didn't all occlude. What I can say is all of the occlusions happened in the overlap zone. So I really think, just taking that observation, I can't answer your question completely, but taking that observation, I think it means that there's just too much metal there.
Matt.
Thank you, Matt.
Of course. Thanks for the questions.
Demetrius here. Is great to see you. We're very impressed by the red color of your beard on the TV. But anyway, a comment on the biodegradable devices. Do you see a role for that? And if you could just comment on that. We saw during WNC a presentation on a Canadian idea for a pulsar flow diverter with the biodegradable possibility. Do you see that helping in any way, or that's a different issue that addresses?
The foundational idea is fantastic, right? To basically have the device there, but only for as long as you need it to achieve its therapeutic function. There's a few risks though, and as we've seen with the coronaries, that was introduced and then taken off the market. And by the way, OCT is a fantastic technology. It's the only technology that can really look at these polymer scaffolds. As far as I know, if you're looking at the traditional bioengineering scaffolds to construct resolvable or resorbable flow diverters, it's typically by hydrolysis that they disappear over time, that they resorb. And the problem with that is that's known to upregulate inflammation. And I think that could be a dangerous consideration for a brain aneurysm, because inflammation is probably contributory to wall destabilization and rupture. The other thing that you worry about for neurovascular indications is as these things hydrolyze, the shear stresses that they're experiencing could cause fragmentation of the materials. And as we all know, the brain is not very tolerant to distal embolization. So those are my concerns. I'm not saying, crazy idea. I think it's a fantastic idea. We just have to do that in a very thoughtful approach.
Thank you, Matt. And any comments on, can you populate areas that are not endothelialized, or try to target this in patches of, let's say, if we not all the device, but then secondarily try to accelerate endothelialization in areas that are not healing well. Do you think we'll one day, with the same approach that you mentioned, instead of targeting the exposed parts of the endothelium, but now exposed parts of metal to then make it heal, thinking about fusiform areas, things that may not heal ever, could you do that using the same technique you demonstrated?
Yeah, it's an excellent question. I do, not removing fusiform aneurysms for a second, we've done a lot of studies on saccular aneurysms, and we've seen that there is delay of endothelialization, therefore delay of exclusion of the aneurysm from the circulation with malapposition. So I think OCT is going to be very important, as you've highlighted it earlier today, is going to be really important in securing excellent apposition of the device and for intrasacculars reconstructing the neck so that you can have optimal treatment efficacy. Regarding fusiform aneurysms, I don't know, and I'm really hopeful that the work that America is doing, the stuff that Satoshi is doing, and others will provide devices that are basically tissue engineered scaffolds that are promoting a healing mechanism. Because as AJ eloquently pointed out earlier today, that remains really the fundamental challenge in the space.
Thank you, Matt. We're gonna break for lunch, guys, and we'll be back at 1 p.m. sharp.
Bon appetit.
Sharp. So are you coming? Thank you, Matt.
Just a reminder, everybody, we do have tables outside on the patio for you to eat lunch. So you're able to get your plate out here in the lobby, and then you can walk right around the corner to the outside tables. You can also eat
Knock, knock. Hey, guys. So we did 1 hour lunch. Everybody's well fed. A dessert still being served. I'm going to start the afternoon again with Professor Rai from West Virginia University. He's going to talk about a very provocative topic that is middle meningeal artery embolization for chronic subdural hematomas. Is this here to stay? Why is Dr. Rai again stealing procedures from neurosurgeons? That's the other title from the talk. I think we have this recorded. I think Ansar is with us for the questions and answers. Thank you again, Ansar.
Good afternoon, and thank you again for this kind invitation to speak on embolization for chronic subdural hematomas. These are my relevant disclosures, primarily relating to my role as co-PI for the membrane clinical trial. Briefly going over the pathophysiology of chronic subdural hematomas. These represent a combination of repetitive injury and response to injury. Basically, after a subdural hematoma forms due to trauma, there is an inflammatory reaction that leads to proliferation of fibroblasts and creation of new inflammatory or leaky membranes that are very fragile and keep on rebleeding and forming a chronic subdural hematoma. So we have this cycle of traumatic injury with initial subdural hematoma followed by inflammatory activation, angiogenesis, development of very fragile vasculature, inflammatory membranes that keeps on bleeding and repeating the cycle. And if you look at the inflammatory mediators that are involved, these are the typical host of inflammatory mediators as we see in any response to inflammation, interleukins, vascular endothelial growth factors, etc. And it is the interaction of these repeated inflammatory process and cascade that leads to the development of these chronic subdural hematoma membranes that act as a nidus for repeat bleeding and further inflammation. If we look at it under histology, this is a histological section of the outer membrane of a chronic subdural hematoma, which typically has these fibroblasts surrounding an inner layer of erythrocytes. Epidemiologically, this is a pretty significant problem, especially in the elderly. This is considered a sentinel event because once it happens, it leads to a downward spiral in the elderly because of causing significant dysfunction into day-to-day activity. Earlier incidences were reported at 1 to 2 per 100,000. This is in the 60s. And more recent data shows that this number is actually pretty high, 20 per 100,000 people overall, but exceedingly high in the 70 to 79 age group at 76 per 100,000, and over 80, 127 per 100,000. So as our population ages, this becomes a very significant problem with expected cases over 200,000 in the coming years. On the literature, again, we see that there has been a significant interest in treatment of these chronic subdural hematomas utilizing MMA embolization. Significant interest and increase in the recent years. And these are the clinical trials that are posted on the clinicaltrials.gov website evaluating the role of MMA embolization, utilizing different embolic materials such as squid from bald, NBCA true film, which is from Cerenovus, onyx particles. And these are being conducted all over the world, US, Europe, China, Iran, Sweden, Germany. There are currently 2 main modalities of treatment: non-surgical medical management or surgical intervention. Non-surgical or conservative management also employs the use of steroids, antifibrinolytic agents, and statins. And all of these have been shown to have some efficacy in clinical trials. Surgical interventions include either less invasive techniques of twisted craniostomy, SEPs, versus the traditional craniotomy or burr holes. And the decision to for conservative versus surgical really is dependent on the patient's symptomatology and presentation, with a conservative approach for relatively mild symptoms or asymptomatic symptoms and treatments involving discontinuation of anticoagulation and antiplatelet therapy, which are important considerations in the elderly, as there is a host of comorbid conditions such as atrial fibrillation that require these treatments, and stopping these therapies can be harmful in other ways. So that's why it's important that we do come up with other treatments that allows us to continue these treatments while breaking the cascade of injury and inflammation that leads to chronic subdural hematomas. Obviously, symptomatic patients with symptoms of cerebral compression require surgical evacuation. Now, the goal is to understand if MMA embolization can be offered as either a primary treatment without surgical intervention, or can be offered in conjunction with surgical intervention as an adjunctive therapy. The scope of MMA embolization for subdural hematoma, before we started our own practice, and we went over the literature and epidemiology, but we wanted to understand what is the scope in our own population. And as a first step, we looked at all the ICD-10 codes that describe this disease. And there are several of them covering both non-traumatic and traumatic subdural hematomas with or without associated comorbidities. We looked at our own hospital over the last 3 years using these ICD codes. And we find that traumatic subdural hematomas were the most common. We're a level 1 trauma center, so this is not surprising. We looked at the DRG codes that were associated with these ICD encounters. And we looked at the non-traumatic subdural hematoma, which were at 42%, because that seems to be the first break in defining chronic subdural hematomas. We don't want to be treating traumatic subdural hematomas acutely with middle meningeal artery embolization, certainly at this point. The next step was to determine what was the incidence in our population. And 3 key variables of good population studies are a well-defined population geography, which in this case is our 4-county primary service area in the northern part of the state in West Virginia, where our hospital is located. Another critical element is having significant access to the population and reliable markers of the disease. To determine the significant access to the population, we looked at all these diagnostic codes and DRGs and determined what percentage of patients having these ICD codes from our population come to our hospital. And this can be done by comparing the domicile of the patient to where they were treated. Data is available on the Department of Health and Human Services website, because all counties are required to report these ICD codes. So we determined that 97% of the patients with these ICD codes and DRGs come to our hospital, which is a fairly high indication of market penetration, and also implies that if we make any estimates as to what is the incidence of the disease in our primary catchment population based on what comes to our hospital, it should be very reliable, up to 97%. And we can account for the remaining 3% and come up with an incidence in our catchment population. We will not be able to do this if we were only treating 30% of these patients from our population. We looked at subdural hematomas by age, and 75% of these were in over 60, but there was no differentiation in coding in traumatic versus non-traumatic by age. However, when we looked at fall as a cause of the trauma, we found that as the age increased, fall accounted for 94% of the traumatic subdural hematoma coding. This is critical, as most of the falls in elderly are ground level falls. They're not major trauma. And because these patients are elderly, because they are undergoing anticoagulation therapy, that quote unquote traumatic subdural hematoma can initiate the cascade of chronic subdural hematomas. So even though they are coded as traumatic, they are essentially within the target population of chronic subdural hematomas. Then when we looked at, based on the 3-year data from our primary service area, for which we get 97% of the patients, and we extrapolated it to the US population. We found that all subdural hematomas, traumatic and non-traumatic, the incidence was 59 per 100,000 person per year, or just under 200,000. All non-traumatic subdural hematomas were 26 per 100,000 per year, 84,000 cases. That by itself is a significantly higher disease incidence and matches what is reported in the literature. But when we add the traumatic subdural hematomas, over 60 in patients in whom fall was the cause of the traumatic coding, because we feel that is an inciting event, then the disease incidence is 44 per 100,000 persons per year, which is more than the large vessel strokes from the same population at 31 per 100,000 persons per year. So what that tells us that this disease has a fairly large scope, possibly larger than large vessel strokes and M2 occlusions, existing somewhere in this range between 31 and say 50 per 100,000 persons per year. So a fairly large target population. And when we look at thrombectomy procedures from 2015 to 2021, we see a significant growth in the first few years and a relative flattening in the current years. This is actual data based on multiple sources. The reason I'm showing that is because we can use this growth phase to somewhat map what could happen in the MMA embolization procedures. When we map that out for the next 10 years, going out to 2029, and we use a 12% growth rate for endovascular therapy for stroke, which is fairly aggressive because we're seeing relative flattening. But if we use the same trajectory that happened to endovascular stroke therapy after this treatment was shown to be efficacious, we can see a fairly high growth rate and actually fairly high overall disease burden that could be higher than endovascular stroke therapy, and this could become a dominant endovascular procedure if these clinical trials are positive. We also compared MMA embolization versus standard management in our own population prior to initiation of these clinical trials. The control group was similar to the group that underwent MMA embolization, over 40 non-traumatic mixed density chronic subdural hematomas, over 1 centimeter in thickness, with the primary endpoint of % reduction in hematoma volume. There were 77 cases in the MMA and 96 in the control group, and majority of these cases were treated with NBCA. 10% were treated with Onyx. There was no difference in age, gender, admission, GCS, or initial hematoma volume. There was a slightly higher incidence of atrial fibrillation in the control group. However, there was no difference in antiplatelet or anticoagulation medication. And we find that there was significantly higher reduction of hematoma volume in the MMA versus the control group. And you can see a relatively tighter spread compared to the control group as well. When we separated it based on patients who underwent surgery versus no surgery, we see the biggest difference in the patients who went MMA embolization as primary therapy without adjunctive surgery, with a 70% reduction compared to 36%. And in the surgical group, we had a 90% reduction in the MMA group versus a 75% in the surgery alone group. The rebleeding rate was also significantly lower at 3% in the MMA versus the control group, no rebleeding in the surgery plus MMA group, and significant difference, the most difference was in the medical arm, 6% rebleeding versus 22% in the medical arm. So this is an example of a typical case of an MMA embolization in a patient with subdural hematoma. This is a traditional transfemoral access into the external carotid artery branches. This is the middle meningeal artery. This is selectively catheterized with the standard neurovascular techniques using a microcatheter and wire. In this case, this is placed in the frontal division of the MMA. This angiogram shows the distribution of that blood vessel to the anterior portions of the meninges, the dura. And after that, we prepare the NBCA. In this case, we are preparing a 20% mixture, which is one of NBCA, which is glue, with 4 of ethylidol, which is the oil that it is. The glue preparation is fairly meticulous, and after that, we prepare the microcatheter, bathing it with D5W, and then inject the glue. So you can see that 20-25 minutes of the procedure, 30 minutes of the procedure are just in access and preparation, and the actual glue injection is very fast, perhaps 15 to 20 seconds. So we can see the microcatheter in the frontal division, and here is the glue coming out on the lateral and the A plane from a wedge microcatheter position without a D5W push, with the good coverage of the branches arising from the frontal division. In this case, the hematoma was mostly localized to the left frontal convexity, but there is some retrograde filling of the parieto-occipital branches, and the microcatheter is then removed. This is the glue cast following removal of the microcatheter, and then we do a catheter angiogram showing the occlusion of the frontal division branches. This is another case that I showed in the beginning. This patient has a typical chronic subdural hematoma, multiple membranes, acute, subacute, and chronic hemorrhage on both sides, obviously larger on the right side, with significant mass effect midline shift, but also smaller subdural hematoma on the left side. It measured almost 3 centimeters on the right, measured about 15 millimeters on the left. The right side was evacuated with sepsis drain in place with significant reduction in the volume. The left side was not evacuated. This is a glue injection on the right side from a wedge position. This is in real time with significant good penetration of all branches of the middle laryngeal artery and good coverage along the entire cerebral convexity, because we don't want to limit it to a small portion. This is the injection on the right side from the parieto-occipital branch. Again, good retrograde filling of the branches, not only the parieto-occipital, but coming down to the frontal division. In this case, most of the hematoma was along the right parietal and posterior frontal convexity. This is the 3-month follow-up showing resolution of hematoma bilaterally. So patient had surgery on one side plus MM embolization and just MM embolization on the other side with good injections on each side. And this is another example of hematoma measuring just over 1 centimeters on the left side, no real midline shift, no evacuation was performed. This is the microcatheter injection in the parieto-occipital branch and in the frontal branch. Often we see arteriovenous strengthening, which is not a sign of arteriovenous fistula. It's just because the membranes are hyperemic and there is a rapid transit time. In this case, the injection was just performed in the frontal division, and compared to the first injection I showed, there is very limited cross coverage across the membrane, and this hematoma did expand over the next 3 months. So that is why these trials are important in showing whether the treatment is beneficial. And what this also shows that the quality of injection can have an impact. In the first case that I showed where the hematoma resolved, we see extensive coverage of the dura on the lateral plane. If you count the number of boxes where you see the NBCA embolic, you can see that almost all the frames are filled, whereas in this case, this is only limited to 3 squares and much less extensive coverage of the hematoma, of the subdural membrane in the second case, which did recur. So in conclusion, is MMA embolization here to stay? Well, first of all, the potential target for MMA embolization is large. And if the therapy is helpful, we can potentially help a lot of patients, especially as our population ages, and especially our largest growth curve is happening in the elderly over 70, in whom this can be a real sentinel event. MM embolizations could become dominant if the clinical trials show benefit. That is the big if. Early data shows some signal in favor of MM embolizations. The signal is certainly higher for the medical arm group because with less invasive techniques such as SEPS, evacuation of these hematomas is a great way to minimize the burden of the disease. Different embolic material may give the same result. We don't know that. We have to wait for the trials to conclude. And the quality of injection could also determine outcomes, and that all will be teased out as these trials conclude and we find out A, if there is a significant benefit of this treatment, and B, what kind of injection, whether it's unilateral, bilateral, what kind of material may help. At this point, I will stop and take any questions. And again, I'm appreciative of the invitation. And again, congratulations on hosting a very successful meeting with great relevant content. Thank you.
Thank you, Ansar. Can you hear us there?
Yes, I can hear you.
Thank you for making yourself available, man. Very, very kind of. Any questions for Dr. Rai, guys? Abby is telling me we have 4 minutes for questions.
Ansar, oh, sorry. Demetrius here. Quick question regarding the cost of the procedure in effectiveness. So like, you know, we're talking about one catheter, different embolic materials, different prices. Any evaluation on that at this point, using balloon catheters, you know, 2 microcatheters, different costs of embolic? When you start losing the benefit of this, obviously between the more effective embolization versus the cost of the procedure and how effective it is.
Yeah, hi, Demetrius. That's a good point, and that comes up often. I mean, PVA and particles are the cheapest. NBCA is fairly expensive, I think, as is Onyx, and these will be priced similarly. So I don't have a good sense of the cost effectiveness in terms of quality of life and long-term outcomes. And I'm not even sure if one embolic agent will be better. We think that a better penetration with visible penetration using say NBCA or an Onyx is better, but I have heard a similar argument from people who use PVA with that you can get the same kind of result. So I think it remains to be seen. Certainly if the trials, I mean, we went through Sampras with a lot of hope. And so we just need to wait and see if these trials are positive. And I think the cost effectiveness will be able to figure it out later. I think the procedure overall is less costly than an endovascular stroke procedure. I think it's less costly material-wise, direct cost-wise, but also the logistics and the infrastructure required to do the procedure in a non-emergent way compared to stroke, and that's why it could become a dominant procedure. But I don't know exactly cost saving wise in terms of a true cost effectiveness analysis if this is better. I think that if we do see a big difference, it'll be in the medical arm, less so in the surgical arm, because if we can prevent readmissions and other readmissions related to not only just the hematoma but comorbidities, that will make the procedure more likely to be cost effective.
Ansar, thank you. 30 seconds answer the next one. Now we have the time they're cutting us here, but we need to know local versus general anesthesia. What is your thought on that?
We do general anesthesia. We started with local, but I think it's critical that we clearly see where the embolic is going. So we do general.
I was gonna say a joke, but I'll refrain. My frontal lobe did activate this time. Thank you,
Yeah.
man. I really appreciate.
One question here.
Oh, hold on. There's one more from Zoom. I'm sorry, and we'll let you go. I see your scrubs are ready. I know what your plans are for the next hour.
Yeah.
Detachable, your microcatheter of choice. The question here is about detachable tip microcatheter. Do you use that on these cases?
We use the Headway Duo, or is the 17 Headway 17.
Thank you. Thank you. Hold on. Seniority here. AJ has a question.
Santa Claus here. So quick question, very provocative thought. You have so much data on epidemiology in your region. Is there a group of patients that are anticoagulation, have often frequent falls, have these little subdurals? And we know from repeated surgery that these patients don't do very well cognitive. Preventive embolization of both MMAs, low morbidity of the procedure. Is that conceivable?
Well, I mean, if we look at the endovascular stroke trials, which started with very strict inclusion criteria, low core, high NIH, good baseline pre-morbid condition. And now when we look at it, that it's evolved into, large core, et cetera. I don't know if we will do preemptively before we even see the disease, but if the trials are overwhelmingly positive, I think we can see treatment of most of these early on in the first setting. I don't know if we're to the point where we can do it before the hematomas even appears, because the incidence is still 20 per 100,000, and in that high risk population, the incidence is higher, but I don't know if we're not there yet at the preemptive embolization part.
Thank you, Ansar. Really appreciate, my friend.
Thank you.
Great weekend. Our last talk for this module is again Professor Malik. Very, very intriguing, new frontier, endovascular access for drug delivery to the CSF. There's a whole group of treatments and procedures that could come from different diseases. I really appreciate you being here and showing your forefront work.
Thank you very much, Dr. Hanel, for the invitation. So you have seen some of this before. So the idea here is to kind of focus on the system that enables us to get to the CP angle cistern. And as we mentioned, the delivery catheter that we built to deliver the e-shunt actually gets us into the CP angle cistern, which means we're actually right next to the brainstem to enable us to inject different agents. And so this is again the kind of privileged position that the system puts you on right in front of the brainstem at the CP angle cistern. Just reviewing, we use this anchor to get us up there. And at this point, this is where we stop. Instead of delivering the device, we actually use the needle potentially to withdraw some CSF and then actually introduce a pharmacological agent. So I'm just going to zip through that again, just to summarize the procedure, going through the femoral vein. This is the jugular vein, and then we go up into the inferior petrosal sinus with our microcatheter. We use that to deploy the anchor, which is a temporary device. This is the system coming up over the flat rail with the needle guard. The needle guard is going to be retracted here. And once we're in position, we basically are able to traverse into the CP angle cistern. And at this point, at the end, we actually are able to pull back. And so we're all done. Obviously, in this case, for the e-shunt delivery, we talked about the protection mechanism to enable the penetration not be too deep. This is what it looks like when you just have the needle in position. The flat trail, this is a cone beam CT showing the flat trail going up to the cavernous sinus. And this is basically what we are aiming for, access into the CP angle cistern. And it turns out that the velocity of the CSF flow is actually quite a complex model. You can actually spend a lot of time trying to model it, and it actually is dependent on whether you have any spinal pathology, if you have discs or any kind of spinal stenosis that actually can affect CSF flow pattern. And so for a lot of the typical drug delivery that may be done through a lumbar puncture, there are basically limitations to that approach that may not be so prominent when you actually deliver a drug near the cisterna magna or the subcerebellopontine angle cistern. So the idea, again, in a single delivery would be to go and traverse and then administer, for instance, to the gene delivery or a vector in single time, and then come out. The dura is self-sealing. It provides access to the cerebellopontine angle cistern, and eventually it may be possible to deliver that through a brachial, axillary, or cephalic approach, or using subclavian vein or a jugular vein. So what are the common methods of drug delivery right now? The most common one is via an Ommaya reservoir. It's basically inherently invasive because you have to make a burr hole, advance a catheter in the ventricle and go through brain. And of course, there's a repeated injection that can be fraught with risk of infection. The other one that is very popular in gene delivery is the cisterna magna injection. This is done on a lot of kind of non-human primates to demonstrate the effectiveness of gene delivery. Unfortunately, it's a lost art for doing it in humans. I don't know if any of our hospitals have an old-timer radiologist that can still do these safely. But again, that's one that a lot of pharmaceutical companies are espousing. There's, of course, the lumbar puncture technique. The problem with it is the distribution is variable. And then there are cervical injections, which again, is a bit higher risk, and there are fewer operators that can do it routinely. We think that using patient-based image guidance to help us determine the ability to access the CP angle cistern and being able to use it in a single time fashion, would basically enable us to achieve this result. What if you need kind of a repeated drug delivery? Well, it is possible to have a eShunt equivalent device, if you will, but instead of having it drain CSF, it can actually be connected to a port or reservoir that's subclavian that can then have multiple infusions. You would think potentially if something like this, either perhaps not with a port, but going externally, temporary device for treating vasospasm potentially, or other diseases that may require repeated injections, or for potential chemotherapy. So the CNS drug delivery challenge is that you have to go across the blood-brain barrier, and this is kind of one of the major obstacles for successful drug delivery. And so you can do it intravenously. Unfortunately, you have to use high doses, and the toxicity for the systemic system obviously is going to be high. You can use a lumbar injection, but again, the amount that actually will get to the brain is unclear and very low. You can use an interventricular approach or a cisterna magna approach. So if you look at the kind of this plot between invasiveness on the y-axis and biodistribution on the x-axis, you see that you go all the way from intravenous. Let's say if you're using an AAV and an associated virus, the invasive is low, but so is the biodistribution. If you go directly into the brain, you have localized distribution, but also highly invasive. And you're really looking for something that is less invasive, but gives you the best biodistribution possible. This is a comparison of high dose cisterna magna versus lumbar puncture of AAV by the Stephen Gray's group. And what you see is, if you look at the lumbar puncture, is significantly lower actual signal than when you compare it to cisterna magna, which is much closer to the brainstem. And so this is what you're trying to achieve ideally, is to achieve a much higher signal around the brain area and less systemically. And the cisterna magna approach, as you can see here at the top panel, compared to the lumbar puncture, gives you a whole lot more signal near the brain, the brainstem. Of course, this is an old picture showing how the cisterna magna is performed, and it's going to be difficult potentially to have it used widely in a clinical setting for any of these gene therapies that may come to market. This is another study, again, comparing the cisterna magna as being superior to both lumbar and IV. So we're trying to kind of achieve the same result at the cisterna magna injection, but be more controlled and less invasive. This is a very nice study by Matt Guinness' group and Heather Gray at UMass, where they actually demonstrate going from a lumbar approach in the sheep model with a microcatheter all the way up to the cisterna magna for delivering a gene therapy. And so we actually set out to see if we can get to the cerebellopontine angle cistern using the same sheep model with a microcatheter technique. And a lot of this work and the whole concept of traveling from a lumbar puncture was previously described or espoused by Phil Purdy. This is kind of where we started. And you can see we're just starting with a lumbar puncture in the sheep model. This is an SL10 microcatheter with a synchro microwire. We're now in the thoracic region. And then actually we're able to consistently get to the cerebellopontine angle cistern, which is the same site as the eShunt drug delivery system would be able to get us to. You can actually see the contrast injection. And this is the 3D reconstruction, the sheep showing that the microcatheter at this level. So we've been working with Dr. Gunes and Vanya at UMass to actually see if we can reproduce the results that they obtained with cisterna magna injection when using this with the cerebellopontine angle cistern injection, to see if this would be a viable approach for gene therapy that is kind of potentially less daunting than the cisterna magna approach. So what's next? It is also possible to use this approach for going further. As the imaging that you saw with the high frequency OCT becomes possible, you can envision using the IPS access to actually navigate through the subarachnoid space and then potentially reach the third ventricle or the lateral ventricle for drug delivery at this point, or potentially even for treatment of obstructive hydrocephalus if we can achieve that safely. Potential with a small balloon, effectively performing a third ventricular EVT from below. And that's kind of where we are, and some thoughts about the future when it comes to using this platform for drug delivery. So in conclusion, the CERVASC cisternal access system provides a minimally invasive approach to the central nervous system for gene therapy. It can be both used in a single or multiple infusion sessions, and also provides an approach for reaching other parts of the ventricular system in the future. And we are currently awaiting the results of gene therapy injection in that region to compare to the gold standard of the cisterna magna. And thank you very much. Thanks.
Thank you, Adam. Can you illustrate to the crowd what pathologies you're talking about when you talk about gene therapy and drug delivery, specifically which pathologies you're talking about?
Sure. I think, a number of movement disorder, a number of neurodegenerative disorders, something like Tay-Sachs disease, which actually has been treated by the UMass group using this small catheter. All of these rare diseases where it is possible to augment or replace a gene, a single gene, with an adenovirus approach. It also opens the opportunity for treatment with stem cell therapy. It also offers the opportunity for treatment of tumors, potentially drug meds with medulloblastoma and others. So I think it's a way to, anything that we treat with an Ommaya reservoir potentially could one day potentially be approached with this minimally invasive kind of percutaneous approach. That's the hope.
Adele, fantastic talk. Can I ask a question?
Thank you very much.
Phenomenal work. Thank you, man. Naval. The
you hear me,
patients are
Matt?
surgery.
You hear
No,
me?
we're gonna take care in a different unit.
I can. Don't worry about it. No big deal.
Hey, welcome everyone to the neurocritical session of innovations. This audience, the postprandial audience, resembles my neuro ICU right now. Like average ECS is like 6 to 7. So hopefully we get something going. The first person I want to invite is Dr. Santosh Murthy. I worked with him back at Hopkins in 2013, I think through 2015. He's the medical director of New York Presbyterian, Cornell University at the Neurocritical Care Unit. Did his fellowship in Baylor, Texas, his fellowship at Hopkins, has over 100 publications. I have no idea how anyone can write so much. I would never have the patience for that. He has a bunch of grants, a lot of money from the NIH. The NIH gives no one any money anymore except Dr. Murthy, apparently. He has K23s, R01s, things that I don't even know existed before. So Dr. Murthy will be talking to us about restarting blood thinners and secondary stroke prevention after ICH. Thank you, Dr. Murthy.
Hello, everyone. Thanks very much for the eloquent introduction and for the opportunity to present my talk at the Innovations Conference here. And hopefully you'll find some of the things I'm about to present innovative. I'm just trying to figure out how this works. All right.
Apologies, stand by just for one moment, please.
Sorry, just trying to figure out how this works, but okay, sounds good. All right, here you go. All right, there you go. So I'll be talking to you about the secondary stroke prevention after ICH and if it's time for a paradigm shift. And these are my relevant disclosures. So I'd like to make three hopefully compelling arguments. The first of which is that intracerebral hemorrhage or ICH is in fact associated with an increased risk of major ischemic cardiovascular events down the road. The second argument is that ICH is actually associated with covert brain infarction or silent brain infarction, as we call it. And third, that some of the proven secondary stroke prevention strategies that we have currently in place, like antiplatelets, statin medications, are in fact safe and maybe even potentially efficacious in patients who have an ICH. And where do we go with this potentially exciting new information? So just to give you a little bit of background, we've all been told that the incidence of ICH is about 70,000 to 80,000 patients in the US alone and almost 3 million worldwide new cases. We've also been told that the mortality is still pretty high. 30% of the patients die in the first 30 days and nearly 50% or half of all patients have poor outcomes. However, we do have a lot of exciting emerging data that have suggested that nearly half of all ICH patients who are deemed to have severe disability, even at the 1 month stage, end up having favorable outcomes at the 1 year mark. And so clearly, we now know that ICH patients require a lot more time to recover and rehabilitate compared to patients who have an ischemic stroke or maybe even a subarachnoid hemorrhage. And we also know that 1 in 4 ICH patients who end up having mild disability early on eventually do end up having significant functional decline. And a large part of that is mainly because of recurrent stroke. Now, a rather disturbing statistic was published recently where they looked at the national trends in the incidence of ICH. And as you can see in the purple arrow, that's the trend that represents the non-Hispanic Black population. And clearly the incidence is extremely high. It's also pretty high in the Hispanic population. But if you look at the screen to your right, you can see that not only is the incidence increasing, it's actually increasing in patients who are relatively young, between 18 and 44 years of age and 44 and 65 years of age, which is a major shift in how the ICH statistics have been described before. So let's look at ischemic conditions in general. We deal with ischemic stroke and myocardial infarction. We know that the two are actually associated with each other and they're actually a risk factor for each other. But ICH also happens to share the same set of risk factors with both ischemic stroke and MI. Despite these statistics, we still somehow have the old paradigm where we look at an ischemic event and assume that the patient is at a risk for further ischemic events in future. And similarly, that ICH begets another hemorrhagic event like an ICH. So with that, I'd like to make my first argument that ICH is actually associated with an increased risk of major ischemic events. So if you look at case series, you'll see that the rates of ischemic stroke vary anywhere between 3 and 6%. And you could argue that 1/5 of all ICH patients have atrial fibrillation, which is by far the most significant risk factor for these ischemic events. But if you look more closely, the CHA2DS2 score in most of these ICH patients is usually 2 or above, and that corresponds to an annual stroke risk of about maybe 2 to 3%. But the ICH patients with the same set of risk factors have a much higher risk of stroke. It's as high as 8 to 10%. So clearly there are more factors here at play. In this epidemiological study out of Denmark, the author showed that the cumulative rates of a major vascular event, which is recurrent stroke, MI, or cardiovascular death after ICH, is almost as high as 15% in the elderly population at the end of the 1 year mark, regardless of men or women. And this rate significantly and proportionately goes up as we look at the different time trends between 2 and the 10 year mark, and going almost as high as 40%. In another study, which was done in China, where they looked at 500,000 patients in a population study, you can see that the risk of recurrent stroke was highest in patients who survived an ICH in the red line on the left side, and compared that with ischemic stroke or subarachnoid hemorrhage, which were significantly lower. And similarly, the graph on the right also shows that patients with ICH have the highest potential risk of a major vascular event, and this is the 5-year cumulative trends. So we did a study where we pooled data from 4 different NIH cohorts, and in about 50,000 participants, we observed that patients who had an ICH had a 2.5-fold increased risk of a major vascular event. And this was a composite of ischemic stroke and MI, and the rate was almost 4 to 4.5% compared to 1% in the general population. When we looked at ischemic stroke and MI separately, we found that patients with an ICH had an increased risk of both ischemic stroke, which was 3-fold higher, and MI, which was 2-fold higher. And this was regardless of all the risk factors, different age groups, and whether patients were on antiplatelet or anticoagulation. We also replicated the study in another data set, which was among 1.8 million Medicare beneficiaries. We saw that there was still a significantly increased risk of stroke and MI in ICH survivors. And what was striking was that the hazard ratios of the risk was significantly higher in the first 6 months, almost as high as 7-fold in the first month after ICH. So what about the risks with different locations of the ICH. Now, all ICHs are not the same, obviously. So we know that lobar and deep hemorrhages behave differently. And in this large population study that was done in the UK, what they found was that patients who had a lobar hemorrhage ended up having a much higher risk of recurrent ICH as compared to the statistic on the bottom, where deep ICHs were more likely to result in major cardiovascular events. They also looked at patients with ICH with and without AFib. And interestingly, though, regardless of the presence of AFib, both had similar rates of recurrent ICH. But when you look at ischemic stroke, as expected, AFib patients had much higher risk of stroke. But when you see the risk of the serious vascular events, even in patients who don't have AFib, the risk is pretty significantly high. And finally, you can see that in this particular study out of France, where they looked at lobar and deep ICHs and how patients fare in terms of major vascular events or recurrent ICH, it's very striking that major vascular events were significantly higher, almost 7.3% per year in patients who had a deep ICH, compared to about 3.5% in patients who had a lobar. Conversely, patients who had a lobar hemorrhage, not surprisingly, had a significantly higher risk of recurrent ICH. So where do we go with this information? So the new paradigm that seems to be appearing is that lobar hemorrhage increases your risk of recurrent ICH more so than arterial ischemic events, while a non-lobar or a deep ICH increases your risk of arterial ischemic events more so than the risk of a recurrent ICH. And so perhaps our hypothesis should be that non-lobar or deep ICHs behave very similar to lacunar strokes and should therefore be treated with similar interventions. What about ICH and silent or covert brain infarction? Now, we get MRIs in patients who have ICHs all the time. We see that these diffusion positive hits, or DWI lesions as we call them, are pretty common, as common as almost 30 to 40% in the acute phase of the ICH. And these lesions can be right next to the or around the hematoma, where they're called perihematomal lesions, or removed from the hematoma, where they're called remote lesions. Now, the standing hypothesis is these lesions are mostly attributable to the acute blood pressure reduction that we do. We have patients presenting with systolic blood pressures in the 200s, 250s, and we acutely bring the blood pressure down to less than 140 sometimes. That can probably cause these lesions. The other two hypotheses are that there is pre-existing severe cerebral small vessel disease, and finally, some amount of hypercoagulability and potentially even microembolic phenomena. Now, in a secondary analysis of a blood pressure trial in ICH patients called the ICH ADAPT study, where patients were randomized to a systolic goal less than 150 versus less than 180, the authors did a secondary study where they performed CT perfusion studies in all patients. And they looked at three different zones. One was right next to the hematoma, which was the perihematomal zone. The second was what they call as the internal border zone, and the external border zone between basically looking at the watershed territories. And as it turned out, regardless of how significantly the blood pressure was reduced, there was no reduction in blood flow in any of the three zones. And in another study where the authors used a validated ADC method to define moderate to severe ischemia, they again tried to correlate changes or controlling blood pressure with presence of these DWI lesions. And what they found was, regardless of how the blood pressure was controlled, either in the first 6 hours or the first 24 hours, there was absolutely no perihematomal or any perfusion deficits in patients, regardless of the blood pressure. So to understand what these punctate lesions are, we performed a meta-analysis where we combined data from 3 different randomized trials and from one of the prospective NIH studies. And we had about 1,700 patients with an ICH and MRI data. And what we found was DWI lesions were more common in patients who were younger, who had larger hematomas to begin with, and more importantly, those who had significant small vessel disease, such as microhemorrhages like the slide on the top, and significant white matter hyperintensities. And regardless of how the blood pressure was controlled in the INTERACT-2 trials, so less than 140 or less than 180, you can still see that there is no difference in the incidence of DWI lesions. Interestingly, though, this study from China actually showed that there could be some ischemic stroke mechanisms at play that can potentially cause these DWI lesions. For instance, what they showed was that if patients had large artery stenosis, then the DWI lesions tended to be much larger than 1.5 centimeters, while those who had small vessel disease had significantly smaller DWI lesions. So perhaps we are missing a trick or two by not paying attention to any potential stroke mechanisms that are at play. Now, what we do know is these DWI lesions are obviously not benign. They're associated with worse mortality and functional outcomes. We also know that these DWI lesions, in fact, are associated with an increased risk of recurrent stroke down the road. And we have shown that the risk of recurrent stroke after DWI lesions is almost 7% absolute increase. So what this means is that ICH increases your risk of clinically overt and clinically silent ischemic events in the brain. The emerging data seem to suggest that perhaps this risk is higher in patients who have a deep or a non-lobar ICH. And this risk persists regardless of whether patients have AFib. So what about potential secondary stroke prevention strategies in these patients? Now, the current guidelines, if you look at AHA, NCS, or the ESO guidelines, they sort of equivocate about the use of secondary stroke prevention strategies, particularly antithrombotics or lipid-lowering strategies, because they are all perceived to have an increased risk of ICH. So the focus is mainly on ICH, prevention of recurrence of ICH, which is essentially blood pressure control. Now, we know blood pressure control is very important, and history has taught us that. We all know the three gentlemen in this picture don't need any introduction. This was at the conclusion of World War II at the Yalta Conference in 1945. And FDR apparently was looking extremely pale, only to be examined by Churchill's personal physician and was found to have a systolic blood pressure of 260 over 150 and ended up dying from a fatal hemorrhage 3 months later. Stalin, on the other hand, also suffered from long-standing hypertension and ended up dying in 1953, if I'm not mistaken, also from a fatal ICH. And Winston Churchill ended up having several strokes and eventually died from one of the strokes. So clearly, blood pressure is the way to go if history has taught us anything. Unfortunately, in the secondary stroke prevention world, this is not as easily implementable as we think. So let's look at another option, which is to look at a combined efficacy of antiplatelet and lipid-lowering strategies, so aspirin and statin, for instance. Now, we know that the combined efficacy is about 0.7 hazard ratio, which translates to a 30% risk reduction. So if you combine these two medicines, then you decrease the risk of secondary cardiovascular disease by almost 30% based on meta-analysis, the Picasso trial, and even in primary prevention trials like the TIPS-3 trial. So maybe we should be using these in ICH survivors. Unfortunately, all the data that we have today, the ICH patients were excluded. So let's look at antiplatelet therapy. Now, if patients were on antiplatelet therapy and end up having an ICH, there is compelling data now to suggest that pre-morbid use of antiplatelet therapy is actually not associated with hematoma expansion or, in fact, worse outcomes after the ICH. What we do know, though, is the pre-morbid use of antiplatelet therapy may actually impact the initial volume of blood or initial hematoma volume on the CAT scan. And that is more so in lobar hemorrhage patients and not so much in deep hemorrhage patients. Now, what about considering antiplatelet therapy right after an ICH? So this was a meta-analysis of two very, very old stroke studies called CAST and IST, where patients were given aspirin purely based on the clinical symptomatology, so even before CAT scans were done. And when the authors looked back and saw that a subset of patients actually ended up having an ICH to begin with and got aspirin, they went back and did the analysis and found that aspirin was not associated with increased mortality, even in the hyperacute phase. But the more convincing data in this aspect is from the RESTART trial, where about 500 odd patients were randomized who had an ICH and were previously on an antiplatelet therapy, were randomized to either restart antiplatelet therapy or stay off of it completely. And the primary outcome was risk of recurrent ICH. And interestingly, what the study showed was that patients who were restarted on antiplatelet therapy had a near almost a near 50% reduction in the risk of recurrent ICH, which was counterintuitive. So maybe antiplatelet therapy is in fact protective in these patients. Now, what about statin therapy? Now, statin therapy obviously is the big elephant in the room, but if you look at using statins after some 30% risk reduction as far as secondary stroke outcomes were concerned, and that included recurrent stroke, MI, and mortality. And there was a meta-analysis that also showed that in fact statins after ICH can improve mortality and also improve functional outcomes. So maybe there is some benefit there. But what about the risk of statins? Now, we all know that after the Sparkle trial, which showed a potential risk of ICH with statin therapy, there is a divided opinion, and this is a highly debated and contested topic. But there was a large meta-analysis that showed that there was absolutely no increased risk. And to your right, you'll see that there was another meta-analysis that came out very recently, and that seemed to suggest that statin use was actually maybe in fact associated with an increased risk of ICH, but the number treated to harm was almost 250 compared to the number treated to decrease cardiovascular risk, which was 35. And in another analysis where they looked specifically at patients who presented with an ischemic stroke, there was absolutely no increased risk of ICH. So we also do know that the location of the bleed seems to be associated with statin use. And in this study, they showed that patients who were more likely to have a lobar ICH had statin use. And that obviously we know is the basis for the Saturn clinical trial, which is an ongoing NIH trial looking at the safety and efficacy of statins in lobar ICH patients. So at this point, I think it is safe to assume that our observational data so far suggests that maybe antiplatelet therapy is safe and even potentially efficacious, and that statin therapy is safe and efficacious at least after a deep ICH. So we find something new. Hopefully everyone's getting excited. And how do we help our patients with this? So perhaps it's now time to plan a randomized clinical trial. So with that in mind, we proposed this to the NIH called the OPTIMA, and it stands for Optimal Prevention of Thrombosis After Intracerebral Hemorrhage with Intensive Medical Therapy and Antiplatelet Medications. I'm joined in this endeavor by Dr. Wendy Zia from Hopkins, Kevin Sheth from Yale, and Ralph Sacco from the University of Miami. And we are proposing OPTIMA as a multi-center prospective randomized clinical trial, which is placebo-controlled as well. We hope to enroll patients who have a non-lobar ICH, no known prior AFib, and no immediate indication for either statin or antiplatelet therapy. And the intervention arm is very simple. It's a fixed dose of aspirin, so low dose aspirin, 81 milligrams, and atorvastatin or Lipitor, 40 milligrams, and the other arm gets the placebos. Our main aim is to show that a combination of aspirin and statin actually results in a significant reduction in your risk of recurrent stroke, MI, or cardiovascular death. And the secondary aim is to show that a combination of aspirin and statin does not increase your risk for recurrent ICH. So very simply put, the inclusion criteria in a nutshell are spontaneous non-lobar ICH, which is going to be defined as hemorrhage within the basal ganglia, the internal external capsule, thalamus, brainstem, or cerebellum, and no known AFib in patients who are over 18 years of age. And the exclusion criteria are pretty standard to all ICH trials. So the study design is, this is a secondary stroke prevention trial. So patients will be enrolled even after discharge, potentially, hopefully within 45 days after ICH onset. And the two interventions will be performed in a double-blinded randomized design. And patients will be followed every 3 months for the first 1 year, and then after that, every 6 months thereafter. So I already described this. And all the statistical considerations point to the fact that we will end up needing 1,606 patients with a deep ICH in the trial. So the trial will hopefully be recruiting patients from the US, Canada, and also 10 different international countries, including 100 international sites. And what we hope with this trial is that hopefully we can find a better answer for secondary stroke prevention trial, prevention after ICH. And perhaps this could be a major paradigm shift where currently if you have a patient with a lacunar stroke, you start aspirin and statin without batting an eyelid, but maybe it's the same approach that needs to be done for a patient who presents with a non-lobar or a deep ICH. And given the fact that deep ICHs tend to involve or affect the minority populations, it also aligns with the NIH's priority goals. So to summarize, hopefully I've convinced you by now that ICH survivors face a heightened risk of major adverse cardiovascular events, and ICH patients can also have silent or covert brain infarctions, that we are in dire need for better secondary stroke prevention strategies in ICH survivors, and perhaps the need of the hour is a randomized clinical trial. So I'd like to acknowledge and thank all my collaborators, and I'm happy to take any questions.
Hey, Santosh, thank you. Excellent talk. Two questions, man. So since you showed that 40% of the ICH can have ischemic strokes, so let's say you have a 50-year-old gentleman with some LVH, they have a deep lower hemorrhage. What would be a trigger for you to start thinking, does this patient maybe have vasculitis or something else going on? Like, what's your threshold? How many DBI do you tolerate before start thinking outside the box?
Yeah, no, that's a great question. I mean, I think obviously LVH is one indication for underlying long-standing hypertension, right? At this point, we actually did a survey to get a sense of what the current practices are for secondary stroke prevention after ICH. We sent out a survey to all the StrokeNet investigators. And as it turned out, what was very striking was there are some centers in the US where any patient with a deep ICH automatically gets started on aspirin regardless. Like centers like MGH and Hopkins, they openly do this all the time. Our stroke colleagues have also started increasingly doing that. But obviously there is no data to support any potential benefit, at least without a randomized clinical trial. But you know, if the data is anything to go by, hopefully we'll have answers in the next few years.
And with the placebo arm in our study, you're not going to give them any aspirin? I mean, what are the practices to start
Because
aspirin within 3 days?
the placebo arm will be in accordance with the current AHA or standard current guidelines, which if you have no prior indication or you were not on any aspirin or statin and the patients end up having a deep or a non-lobar ICH, then there's no indication to start them de novo.
Any other questions?
Wonderful talk. Thank you for that. As you were describing, you know, you've got common risk factors, right? Hypertension for an ischemic stroke, hypertension for ICH. Do you have any biomarkers, or have they found any biomarkers that suggest that a patient with chronic hypertension is more likely to have an ICH versus an ischemic stroke, or vice versa? And if so, wouldn't that be more compelling sort of evidence that a particular patient population is better served with antiplatelets and maybe another one not?
No, I think that's a very, very interesting question. And I think decades of research have gone into discerning who ends up having a lacunar stroke and who ends up having a deep ICH, because they're essentially part of the same spectrum of chronic hypertensive disease. A lot of investigations have looked at different cerebral small vessel disease markers. For a very long time, people thought that having microhemorrhages in the brain is a reflection of increased ICH risk, which many people still believe is still the case. There was a very big meta-analysis that came out in JAMA Neurology a couple of years ago, where they looked at all these different cerebral small vessel disease markers. They looked at microhemorrhages, prior lacunes, and white matter hyperintensities. And unfortunately, what they found was across the board, all these three markers individually were associated with both an increased risk of both ischemic stroke and intracerebral hemorrhage, and even cognitive decline and dementia down the road. So at this point, you can argue and potentially take the hazard ratios and make a case, but simply put, I don't think there's a clear way in which you can say who's at risk for what.
Thank you. Any other questions?
All right. Thank you very much.
The next speaker I would like to invite is Dr. Freeman from the Mayo Clinic. He's obviously well known to all of you that have lived in Jacksonville for any length of time. We always talk about how there's no one that's indispensable to an institution. The institution is bigger than the person. I cannot envision the Mayo Clinic without Dr. Freeman in it. He is not just the director of neurocritical care there. I think the Mayo Clinic in Florida basically stands on his broad shoulders. He's been a role model for several of us as neurointensivists, not just as a clinician and a researcher and a teacher, but also as a truly wonderful and humble human being. So thank you for coming. We can never imagine having innovations without Dr. Freeman. He's not missed one of them. So again, thank you.
Thanks, Niraj. Thanks for the kind introduction. And yeah, and just wanted to thank you and Ricardo and Eric and Wendy and the organizers. Really a fantastic course, and definitely cerebrovascular and innovation is in my blood. And this is like an extended family in a beautiful location. So I have, befitting, I guess you asked me to talk about this topic, I think it was like a couple of years ago. So I kept digging, and I have my contact info on this QR computer vision code if you want to reach out, or I have little papyrus cards if you'd like. First off, I guess it's appropriate that I have my CAPTCHA disclosure, which is actually the acronym for the Turing test. I am not a robot. I have no financial disclosures with relation to this talk. I do have some mathematical models that are not patentable, so I don't have any financially anything to gain from those, and happy to chat about those. And for those of you who know me, I'd like to think very big, and I'd like to take you through literally a light year tour of what and how artificial intelligence has come around. Only the dinosaurs, I think, made an entire galactic lap, and I hope that human civilization makes it at least that far. So these are my objectives. Sort of what define is artificial intelligence, and to do that, I think we really need to get into the history, and I love history, and I'd also like to really highlight someone who I think did not get highlighted appropriately, John von Neumann, who's a contemporary of Einstein. Second, I'd like to talk about AI and neurocritical care. There's certainly a big reality of AI that already exists. There's also some hype of what it is not. We can go through some examples, and Niraj, you couldn't have picked a better month for your conference because the entire issue of neurocritical care is focused on big data and AI last month. So you got your wish. And then we're going to talk about some future. So this is, I've been an OpenAI user since they were founded by Elon Musk and the group, and they opened up DALL-E 2, which is a GPT-3 generator of images. So this is DALL-E's gift of art to your conference. So when I typed in the words neurocritical care, artificial intelligence, hospital of the future at sunrise, this is what DALL-E produced for you. And interesting that it looks like Baptist Weaver Tower there in the bottom right. So a brief history of time, about 13.8 billion years ago, and we'll zoom through this, right? Why is this important? Because the first recorded history happened about 3000 BC, as we know, in neuro. And you're looking about 1600 BC, the actual glyphs, language. We take this for granted that part of the cortex evolved to decipher, put symbols are language. Later in computer science, we'll talk about code. And then for neurocritical care, rapidly evolved really in the last 50, 70 years. And neurocritical care emerges, and then we are at now, and then where we're going. So to compress this further, the reason why we're able to have the organ that named itself, right? The only thing in the universe that named itself is our brains. And primate is a bit anthropomorphocentric that we named ourselves prime. And Homo sapiens, one who knows, which is quite profound. And as I mentioned, these glyphs and languages emerged. And then around 1940, we're starting to see glimpses of artificial intelligence with Alan Turing. He created this giant mechanical machine based on math that decrypted and deciphered the German code. And not even the best mathematician could crack the code at this time, and he built this machine. And so this is probably the first computer, except for I'll show you these earlier attempts with things. And then in 1950, he wrote Computing Machinery and Intelligence, the so-called Turing test. So the Turing test remains sort of the defining thing that defines intelligence of an artificial system and compared human and interaction. And 1954 is actually really the earmark when Marvin Minsky from MIT, John McCarthy at Stanford had an 8-week retreat on the topic of artificial intelligence. And that's where the term originated. Professor Dev Shah, who's a mentor to me with some coursework, who knows Dr. Minsky, said that the goal of artificial intelligence is to mimic human behavior in an intelligent manner. Zooming forward, we sent people to the moon with a computer that's, many of you have in your pocket that is millions of times faster. You can see the Apollo computer was 2 megahertz. Most of your computers are in the gigahertz range. The iPhone was then introduced, and then we're speeding along here now. AlphaGo, DeepMind defeated the world's champions. And many of you may know this, but what a lot of people don't know is that the artificial intelligence program actually created a move that no human had ever seen before. And no human has ever beat this AI. And in fact, the last human that faced DeepMind actually retired and said he had not encountered such an entity before. And so why is this important as we go into the future? As I mentioned, OpenAI GPT-3 is about a 0.5 trillion parameter AI, can write. I've actually had it write the preamble on some of my websites. And then this year, DeepMind, also the same line of AlphaGo game, created a journalist agent to think, not a super intelligence, but just a journalist agent. And then, as I mentioned, DALL-E, an art program. There's ones called Jukebox that make music. And then this year, the iPhone 14 released a 16 billion transistor phone. And by comparison, your brains have about 89 billion neurons. So we're speeding on a very fast path. So what is artificial intelligence? It's a relatively new term I mentioned with Marvin Minsky and the team, but it's based on the fundamentals. The fundamentals of it are in mathematics. They go back, way back. Isaac Newton, who invented calculus, statistical methods, which I think we take for granted how powerful those are and how we don't like them in medical school when we go through them, but it's good medicine to go through them. And then Reverend Bayes became the prediction machine. We talk about Bayes' theorem, and that becomes increasingly important. And just a comment about this contemporary era of World War II with Einstein, some brilliant, brilliant people, Claude Shannon, who basically wrote an entire paper. The reason why computers are so incredibly good about information and data is they've broken down all signal and language down into zeros and ones. So it can't be corrupted. It can be reconstituted and transmitted at an extremely high fidelity that we don't do with human language. And it's his contemporary, John von Neumann. It's interesting, Einstein said he was the smarter one, which says a lot about John von Neumann. And so most of the computers we have to this day are based on von Neumann's computing machines. This is a little book, a foreword by Ray Kurzweil, if you know him. And just some screenshots of, and probably Dr. Hanel could probably pronounce this better in German, which is, I think, the Einstein-Dunction problem, which is, I think, basically in German, a thought experiment, if I decipher that correctly, by Turing in 1930. And then you can see the article on the right from 1950, calling the imitation game or the Turing test. So there will be math. I should have warned you. And so I think this one slide to me hopefully really drives home the main differences. And so this equation, which is a simple linear equation, really embodies all three. And so on your far left, math and statistics, you have your variables. And this is important. You can do this on paper. And this is critical to do hypothesis testing and the like. So rejecting the null hypothesis, you can prove and disprove things. It's very important. And then you get in the middle category, which is machine learning. So it can solve things for you. It can make predictions. And linear regressions are very powerful as a mode of machine learning. And then on the far right, what is AI? What is artificial intelligence? Again, going back to those definitions you can see in the upper right, this is where it can make adjustments. It can have control. You can look at the dose response, the skew, and the spread or heteroscedasticity of those variables. And also there's the newer forms called Q-learning, detect if it's a linear relationship or not, or multilinear, collinear. And we think about an example is, does anybody have full self-driving cars? So, right, I mean, I think if you've got a time machine and you showed someone car driving itself, they think you were crazy, but here we are in 2022. So why is this important? The backdrop is actually we're living in what's called the fourth industrial revolution. This is not the steam engine, this is not computer, but it's the coalescence of multiple technologies. And so all of them coming together have made the rapid pace of technology happen faster than any other time in human history. So extremely important time in which we're living, and our kids pick this up immediately. This is just a graphic showing you what this looks like in terms of a visual of the fourth industrial revolution. All these technologies are coalescing and combining in different forms. So augmented reality with robotics, AI with human interfaces, smart sensors, and Internet of Things, 5G, and so forth. And a brilliant physician scientist, Dr. Richard Eman in Rochester, once cited Vannevar Bush, which is Science: The Endless Frontier, and he said that all knowledge is like a lens, which allows us to see further into the future, and each future technology lets us see even farther. And I believe that is correct. And this is just a crazy number, right? Since the iPhone came out in 2007, there's 7.89 billion people with some kind of on Earth, and then 5.29 that have a smartphone. I can tell you 10 years ago, you go different parts of the globe, they didn't have these. Now you go there, the parts of the world haven't changed except for the fact that they're holding a massively powerful computer with a satellite comm link in their hands. So the world is incredibly connected nowadays, more than ever before. So how does this relate to neurocritical care? I would argue that the ICU is a giant big data laboratory, and that's why what makes it special about neurocritical care and in the neurosciences. And every airplane cockpit has been very carefully, if you ever read Atul Gawande's book, The Checklist Manifesto, they do a brilliant job really curating what is essential, the signal to noise ratio. And that's the thing I think we're lacking in today's healthcare. So enough on the history, I think we're moving on. I wanted to provide some examples where we're going. So here's a model we built with one of our nurse practitioners at the bedside. You know, she didn't believe the Charleston Comorbidity Index. We said, this doesn't seem right for the neuro patients we were discharging. So we built the model. It's called R2 based on a linear regression. We just kind of went over that math. These are very simple to do, very powerful. You run through the rows and columns, and it will come up with variables. And you can have a prediction model that'll tell you before you discharge a patient, you can see on the bottom right, the risk of bouncing back and coming in the hospital. Here's another one that we did across about 6,000 critically ill patients with the question, what's the risk that they're going to fail extubation and I'm going to have to re-intubate my patient? Seems like a very good question. It's also PSI 11 on National Quality Index. And you can see this very, ICH score, like a la Hempel kind of score, very easy to do with spreadsheet kind of data. Also, a big shout out to Dr. Naval there. I came across your SH score when you're at Hopkins, and love that model. It has a very similar score. It's like the ICH score. So I just wanted to mention a fan of your work there. And what about EEG? I think EEG has been for a long time one of the prime examples of machine learning. So I just wanted to share that as an example, because I noticed there's a speaker later talking about, I think, ischemic stroke, and probably talking about large vessel occlusion, so I'll stay clear of that. But quantitative EEG uses a fast Fourier transform. And this is a paper that just, you think of Fourier analysis as sort of like a prism. It fractionates light. You can take the light and it goes into different bins. And these bins, this is sort of what I teach our fellows down the bedside EEG, the very similar frequency, amplitude, symmetry, morphology when we teach EEG at the bedside. And this is how it looks like if you compress it. And this is a nice slide from Dr. Schuer, but these red blips are areas that the machine has tagged using neural networks saying, I'm concerned that's a seizure based on its evolution, its amplitude, its frequency. This is what the EEG looks like in 4 dimensions. So you've got the 3 sort of frequency, amplitude, evolution, and also time dimensions. And it literally allows you to see the forest and the trees more like an airline cockpit, right? You just want to see high level data. You can always zoom in on data if you're concerned. And this is just their paper about using neural networks. They've also shown that you can do a statistical Turing test, and it was non-inferior for human tagging of areas for seizures. So EEGs come a long way. You can also plug and play with EEG, put in smart devices like Apple Watch accelerometers, ECG. Apple continues. Now they've added oxygen saturation. The rumor is they're going to add blood glucose next. So this continues to go on and on and on. So this is the entire issue. At the end, I have a QR code. You can download all these. And this is great. I love this. Giuseppe from Oxford says, blah, 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 Greta Thunberg, about big data and AI, right? That's kind of like the public thought about when you say AI. And the counter is that it's all about the V's, right? The high velocity, high volume. This is what we see. These patients are super sick. They change very rapidly, and there's a lot of data coming at us very fast. So, right, how do you filter that data, right? You need to have some kind of filter from the data so you don't have information overload. And I think it's incumbent upon us as the users to really curate what data displays we want. And this is just, again, going back to John von Neumann, think about the visualization of data and the representation of data. We need to be able to visualize the data so that our brains can see it accurately on these dashboards. So my last part is more moving into the future for NeuroICU care. And I would call this the A's of AIs. I think we should lead to automation, at least, or what we call augmentation of human intelligence. These dashboards should help you be better at what you do. I don't think we're living there now, but we need to give feedback to these systems. They need to have analytics, predictive ones. Amazon knows what shoes I want when I type in brown shoes, right? And how does it do that? It knows what my prior purchase history. This is crazy that our healthcare records don't do this for us now, but it's all there. We just need to get under the hood on this. There's also the component of ambient computing, right? NLP, sort of AI that can listen and scribe, and they should accelerate workflow, and they should make us more efficient. And I think this is an important concept, that part of visualization or seeing problems and the right important data is known in the data science world as the curse of dimensionality. So if you're looking at a spreadsheet of 200 rows and cells, right, it's bewildering. But there's a way to denoise that, and I'll show you some examples of that. So some other cases, we need filters, common filters, other things I showed you. EEG's got amazing ones that have taken a lot of time using neural networks. You can zoom in, zoom out. Syndrome sniffers, I'm going to give you the data science, computer science equivalent that Google's actually done, but you can use data to detect syndromes. AI scribes are emerging, algorithms, but I think they need to have a hypothesis-driven thing like readmissions and the things that I showed you. What is the mortality rate in SAH? And then automation. AI is more the cognitive side, but you need robotic effectors to be the muscle in the arms. And then these are just 2 companies out there using non-invasive vital sign monitoring. And so I'm going to zoom through some of these articles. Claude Hemphill put that it's all about expertise, but I'm going to show you a diagram that what is expertise, what is knowledge? And I think wisdom is the high form of having some prediction. You've seen something before. This translates into tree diagrams, which is another machine learning model, or computable knowledge. And this is by Dr. Suarez at Hopkins. There's a big push now that AI should be fair and it should be ethical. And so, because we have to be concerned, your data set can create bias. You have to be very concerned of what data set you have, because you can create a biased data set. Some more papers. Bob Stevens looks at this from what we call phenotyping and precision medicine. This impacts your effect sizes. So if you don't get down to the actual endophenotype or things, you can miss or have what's thought to be a failed treatment effect. And this is a large study just looking at length of stay in stroke, 17,000 cases using different machine learning models you can see in the table. So you can have this data at your fingertips. The key thing is getting it all together. This is by Lori Shooter. You're looking at automated robotic TCD. So instead of manually, I'm holding and wiggling that thing. Thankfully, somebody's focused the imaging of the MCA signal. DCI prediction could also be obtained using this mathematics and the data as shown here. Blood variability, and this is the concept I wanted to mention called high dimensional or high resolution data. Again, if your brain can't parse out what's important, you can't see the obvious pathophysiology in front of you. So this, again, using power spectrum data like an EEG. And this is from Eric Rosenthal. And this is important because literally this week, neurologists like you gifted this to the NIH announced Bridge to AI. And this is a big ICU funded group called Chorus, tying together all this data. You can see on the left diagrams looking at ICU, TBI predominant outcomes. So this is what I was talking about. How do you fix the curse of dimensionality? This is a Google group of all these molecules that they put out there, and a PC is a principal component analysis. It squishes all this high dimensional data into a lower dimension. You heard me right. Yes, squishing things into lower dimensions. They spread them out so you can see patterns. It's kind of a radical thought. So you can see what things smell like grapes and lilies and things like that of molecules. And this is how you discover like type 3 diabetes and things like this. So how do you do this? You got to have stable inputs in your model. You got to have the data input into a computable model, and then you get wisdom or prediction once you have machine learning models called PCS from the Berkeley group. So where's this all going as we finish here? I hope in the future, if everyone's going to have a supercomputer on their wrist or their pocket, why not harness it to make prediction models? I think Apple's already moved into this space. They have a great commercial about somebody who fell and shall I call 911 for you? But how about in the middle, right? We have all this data in the hospital. How do we harness it and collaborate among multiple hospitals to improve outcomes? I think this is a nice slide about what people think AI is like. It's data, it goes into a magic hat and boom, you get value. It's a little more than that. There are open non-code AI models out there, but there are some plug and play features. And at the very bottom, we can't forget the ethical and equity implications of this data. This is just the Bridge to AI course. Dr. Rosenthal, I think they just announced as one of the sites. This is an ICU-based collaborative. And as I close here, I just wanted to mention, these are some kind of spooky, we're not at Halloween yet, but there's an article about a man who coded what the woman he fell in love with after she died, talking to her. And it was he mentioned very realistic, like she was still alive. And then in the middle, this recently, a Google employee was fired because he whistle blew that he felt that Google had a sentient AI. And then a billionaire, actually, Dr. Martine Rosenblatt, is working on a robotic AI for, I guess, to upload the brain and live and be immortal. So to summarize then, I hopefully you've gained about a few billion years of information in a short amount of time. This was high yield and smarter from it. I do believe that AI is a new literacy, and we've gotten there very, very quickly. There's a book called The Age of AI by Dr. Eric Schmidt, former CEO of Google, and Henry Kissinger. They're quite clear. We need to get in front of AI now. We don't want to get behind it. And they point out that social media, we have gotten behind, and social media has gotten out of hand. They even refer to some form of AI, if it's not ethically used, can be on the level of nuclear concerns. So, usually there's other folks that are concerned about that as well. It's important to know the difference between math statistics, ML, and AI. That's foundational. There is no code AI that's out there and it's free to learn. And we need more scientific collaboration in neurocritical care with these bridge funding. So I hope that comes about. And if there's open source or if anyone's interested, I'm happy to talk about. Sorry, this is a quick spiel, I think, about healthcare or the globe in general, but I hope that we ethically think about our purpose in life and not profit. I hope that we think about building networks. I hope we focus on empowering and educating others and our children and experimenting and making it trustworthy, transparent, and interoperable. So I'm gonna leave you with a few quotes. So this is probably my daughter, felt like this quote by John McCarthy. It's not, as soon as it works, we don't call it AI anymore, right? It surrounds us, but we've kind of, become it, it's like, whatever. It's not AI, but it's very detailed if you look under the hood. And then Douglas Adams, the author of The Hitchhiker's Guide to the Galaxy, sort of said it's age dependent too, right? If you're born into the world with all this stuff, it's not really technology. If you're in the middle part of your life, it's going to be great if you want to get in your career. But if you're older, you're kind of a nihilist or a Luddite about it. You don't really care about it. And I'll leave you with this last quote by Arthur C. Clarke that said, any sufficient advanced technology is indistinguishable from magic. As a magician as well, I find this always fascinating. I was always fascinated with the iPhone when it came out, a combination of multiple technologies. Magic is the things we don't understand. There are still things we don't understand on some of the AI models and how they exactly work. It's called the black box. And then, I'm sorry, last thing, I think the Schopenhauer quote talks about the things, trying to see things further. Talent hits a target no one else can hit. Genius hits a target no one else can see. So our goal in life is to try to see and push humanity farther. And as I mentioned, this is a QR code, all the PDFs references. It's in the slide deck as well. And yeah, I'll stop there.
Questions?
I promise it's not downloading a virus.
David, thank you so much. As usual, really interesting and thought-provoking. You're quite over here.
I'm right in the line. Okay.
You're quite optimistic. I could see it. I mean, even that you seems to overhype your Tesla self-driving capability. I don't know. I mean, to get a bit philosophical, I mean, you look at the iPhone, I mean, it's amazing the power we'll have in our hand, but on a daily basis, I mean, it just allowed a bunch of grown-up to play Candy Crush at all time of the day. So do you really think that we're taking this turn and it's really helping medicine? And don't you think we're slow to adopt, I mean, what would you recommend for us to basically, as physicians, be able to embrace that and be behind this? Because, an example, I was reading one of the quote, I think it's pretty depressing that, we're like in the ICU neurosurgery, like weaning of EVD. Like, am I better at this than I was 10 years ago? Probably not. You would think there's a way with using this data that we could have a clear understanding and we could be sure whoever is going to fail with change of microscopic change in the ventricle size and things like this. So I don't know, what is your, I just feel like it's hard for those, it's hard to align this with the other competing force in medicine to kind of move in the right direction. So any thought about?
Yeah, Eric, that's great comments and question. I think, I always think, somebody asked Eric Schmidt, is AI gonna replace a lot of what we do? And he said for healthcare, he always wants a human in the loop. And I think that's very wise. And, you want someone there to hold your hand. You want someone, and you always have to have a human fact check what the models are doing too, from a compassionate and supervisory standpoint. I think the comment about sort of I guess it's like a human drift versus reality. I've noticed just since introduction of the iPhone, we like to go to the Bahamas once a year and totally unplug. And I tell my daughter, I said, you know, let's go analog, unplug. And it's funny when we come back, we notice everyone's head is like this, even at dinner, at the dinner table. So whether we realize it or not, people have become more pulled into these the algorithms that are about ad dollars. So I encourage people to study this, become the masters of this rather than be subject to it. Same for healthcare. Does that answer that?
Not really, but it was good response. I liked it.
We do have, everyone creates protocols, right? We talk about protocolization of care all the time. And sometimes those protocols are not based on, evidence. It's based on the expert panel, and the expert panel has their own biases. Maybe AI gets us away from that. It actually, does things in a non-emotional, non-biased sort of fashion. And I think that always plays into decisions we make on a day-to-day basis. So yeah, I think we fear it, but at the same point in time, I think the advancements are better for all of us.
Yeah, and I think that I should have mentioned that I think, and then maybe that answers Eric's question more directly, is there is a use of Bayesian adaptive models like randomized trials to take the population data and feed it back into the system and use a smaller sample size. So like your EBD weaning, yeah, what are we learning as humans? I don't know, but I think the answer is we should collaborate more. We should create a data platform to study it more and build the system to pioneer these protocols based on data.
I think there's a general sense of everyone being worried about their autonomy and their freedom and my rights, and I should have a right to do whatever I want to do. But I think the reason this perhaps may not take off in the future, even though there's all this additional input and information coming, is people feel, well, again, it does make the humans redundant. Whether it's a human touch, it doesn't matter. It's still like, wait, someone else is telling me what to do, even if it's a supercomputer. And I think that will always be, that hesitancy will always remain for that reason, because of the autonomy factor, perhaps. But this is awesome. Thank you.
And I think what I think it's difficult. Like if we get back to the iPhone, I think, it's hard sometimes to get rid of the noise to go to the answer we want to find, or you get distracted. And I think the potential with AI is so large that it's easy to just basically get, inundated towards those data and not really, pay attention to what's really matter. And I think on the flip side of that, so if I look, and again, I'm above 35-year-old, so obviously I don't see that probably as advanced as I should, but like to get back to the Tesla, I mean, the AI in the Tesla, it's pretty dangerous. I mean, where we are right now, it's not up for prime time. There's vendor here, Viz AI and all that. So, I mean, you would think aspect, there's no reason that a computer you would think is not better than UI. I mean, most of those companies are not doing the algorithm is not doing a fantastic job. So it is kind of disappointing because you feel like it is there. We talk about this all the time, falling brain tumor, whether they've grown or not. We should have a volumetric measurement that should be super easy to implement on any basically system. So you feel that all those things are available. There's no reason you feel they're available in other field. But why in medicine we don't even embrace that? And it just remain more like a concept. And I just feel like, is it because physician, we don't get behind that? We don't cooperate enough with the industry, or what? Yeah.
Yeah, no, I think clinicians if you look at talking to people like Tom brought, we are probably 300% busier than they were 50 years ago clinically. And we haven't been able to scale back and be more the scientist mentality and deeply study these things. That's my 2 cents on that. But I hope we can.
Thank you, Dr. Freeman. Amazing talk. So we'll take a little 15-minute break. Just stretch your legs, come back in maybe 3:10 for the next lecture, please. Thank you. How are you? Nice to see you. Whoa. Hello. Is that light going to keep shining in my eyes? That's like 3rd degree, man. Thank you. All right, slight change of plans. Dr. Gomez from the Cleveland Clinic is presenting virtually. So we are working out some kinks in the system. So he's going to follow me, which is easy. It's impossible to follow him. So whenever we're ready to go. And say some knock jokes maybe while we wait. All right, knock. Tank. You're welcome. Oh, it's good to start really low so you don't disappoint everyone. You can't go downhill when you start at the bottom of the hill, right? I crack me up. All right, we're good. Is this a laser? Okay. All right, we ready to go? All right, so unfortunately for all of you in the audience, this is amateur hour. You listen to a bunch of really good professionals talk about neurocritical management, neurosurgical management. I'm going to take you down a notch to my level. So we're going to talk about the fragility of neurocritical care. When we talk about the fragility of neurocritical care, we need to understand what fragility really is. There's different kinds of fragility. To start off, I have nothing to disclose. No one pays me any money on the side. No one pays me, period. Actually, there is one thing to disclose. It's a long winding talk. So I come from Mumbai, which is Bombay, which is Bollywood. Our movies are 4 hours long and you watch the movie for 2 hours and then you have an intermission so you can empty your bladder, eat a samosa, wash your hands, no particular order, of course. And at the 2-hour mark, you finally get, okay, this is what the movie is about, right? So we will get there, I promise you. But the first 15 minutes, you'll be like, what on earth is going on? Like, am I high? I don't understand, but we'll get there, I promise. All right, so again, this is about the fragility of neurocritical care. So let's first talk about the fragility of life, right? We've all been exposed to the pandemic of COVID. Once upon a time, people said, it's fake news. Clearly, it's not. 6.5 million people have died. Some say it's associated with COVID. It's not necessarily because of COVID. Well, the life expectancy in the US has gone down from 78.6 to 76.8. That's about a 2-year drop. So clearly COVID is real. It's not fake news. There's always silver linings to everything. So this is New Delhi, the capital of India, and that's India Gate. What you see on the left side is what the Delhi Gate typically looks like every morning when you drive. The smog, you can't see anything. The only positive of COVID in New Delhi, in any case, was all these trucks and buses went off the road, public transportation was stopped. And a month later, on the right side, you can actually see what the world looks like. So, environmental changes are real. And I think people often mistake the fact that it's cold outside, it means global warming doesn't exist. Weather and climate are not interchangeable. And we need to know that, we're scientists. So the environment is fragile too. We know peace is fragile, and we've seen the fragility of peace, over in Ukraine and Russia. Famous thing, love thy neighbor as thyself, right? Maybe that's overkill. You don't have to love your neighbor, but you don't have to walk into their house and blow them up. So, and then sit on their ruins and own it. So, that's fragility of peace. And the most disappointing of the lot is true love. True love is fragile. Two beautiful, beautiful people you would think would make beautiful, beautiful love. Somehow this devolved to, Johnny Depp saying, you took a dump on my bed, her saying, it wasn't me, it was the dog. And then him saying, I know what dog's poop smells like, that's you. I mean, what on earth has this world come to, right? So in context of all of this, perhaps the fragility of neurocritical care isn't that big of a deal. But nevertheless, it's a neurosciences conference, so we'll talk about fragility index in neurocritical care. So what is fragility index? For some of you that have never heard this term or understood it, it's a statistical thing. So let's go back to the very basics. When you want to study if a drug works or an intervention works, what do? You do a randomized control trial. You take one group that gets standard care or gets, let's say, a placebo, and then you have an intervention or you have a drug, and you compare outcomes. And when you compare outcomes, you want to show superiority. How do you prove superiority? You have to show a statistically significant benefit. How do you come up with a statistically significant benefit? Where do they come up with those numbers, right? It's this p-value less than 0.05. What does p-value less than 0.05 means? It means you're saying with 95% confidence that the benefit of the drug or the intervention outweighs, the downsides, or outweighs is greater than the option. So typically, if your p-value is less than 0.05, you've proven statistical significance. If it's over that, you haven't proven statistical significance. You can't say that something is potentially beneficial or not. So where did fragility index come into all of this? Well, so if you've got a study where you're showing a benefit of a particular intervention or of a drug, how many patients in that placebo group or the control group that had a bad outcome, if they would have had a good outcome, would it have rendered this study negative? In other words, by how much did you show that benefit? So if you've got a study, let's say, where you've given a drug and you've said p-value is 0.01. Well, if it took only a couple of patients in the placebo group that had a bad outcome to have a good outcome, that means your fragility index is low. It is that number 2. You've lost your statistical significance. In other words, it is not a robust study. It is a fragile study. If you require 50 patients in the placebo group that had a poor outcome to have had a good outcome, to lose the statistically significant benefit of your drug or of your intervention, that makes a fragility index 50. That makes it a robust study. So the number of patients that have to flip their outcome to lose statistical significance is fragility index. Now, the low fragility index, where it takes only 1 or 2 patients to move the study outcomes the other way, is a bad thing. A high fragility index is a good thing. So I know it doesn't sound intuitive. Low fragility index is bad. High fragility index is a good thing. All right, so just so some of you, I see some confused faces because some of you have never encountered this concept of fragility index before. So look at the column on the left. All right, you have an intervention. And with your intervention, 80% people survived, 20% people died. Okay, there's 100 patients. With the placebo, you had 60 people survive, 40 die. So there was a difference in outcomes. Obviously, the intervention helped. sufficiently to give a p-value less than 0.05. So your p-value in this statistical analysis is 0.003. Well, now, if you want to calculate the fragility index, keep changing those placebo numbers, go up by 1. So 61 had survived and 39 died, 62 survived, 38 died. At what point in time do you actually narrow that difference sufficiently enough to lose statistical significance? So in this analysis, your fragility index is 7 because your placebo group had to have 67 good outcomes versus 33 bad outcomes to narrow that difference sufficiently enough that you lost statistical significance. So you added 7 good outcomes to the placebo group in the good outcome category from the bad outcome category. That's what fragility index is. 7 is kind of a middle of the road fragility index, and we'll talk about that a little bit more. So this seems like a super cool concept, right? It's like, oh, this is some deep spiritual Indian thing that, you know, I kind of came up with and concocted. And it's like, wow, this is deep stuff, man. I have not had in my 47 years of existence, one single original thought that I can take credit for. The credit belongs to something else. I'm just repeating what the smart people have said. My mentor always told me, you should be like an amoeba. That's the perfect animal. What the amoeba does is it phagocytoses, right? To take nutrients into itself. So what I do is I phagocytose smart ideas of other people, make it my own. And now I can say, hey, check out my talk. This is a good talk. So fragility index in surgical trials was first studied and published by this group, the Italian group, where they said, hey, there's something called a fragility index. When you publish major randomized controlled trials and you announce this is the p-value and it's statistically significant, you should, to actually have real context, also say what the fragility index is. And that way you can tell if the study is statistically sound, the finding is robust, or it is borderline, okay? So after that, there's a major seminal paper that came out that first actually got me interested in the fragility index. Is the first paper that I really read about, which talks about the statistical significance of randomized controlled trials, a case for the fragility index. So this paper basically presented the concept of fragility index and looked at studies that were conducted and not published in tiny little journals with an impact factor of 1. But no, these were like high-level journals, NEJM, JAMA, Annals of Internal Medicine, The Lancet. These are huge journals who don't publish crap. They actually publish good, sound evidence, right? And so they looked at these papers that were published and tried to look at the factors that impacted fragility index, which were the major factors that allowed you to say, okay, this study is going to be more robust and this study is going to be more fragile. So they looked at a total of 1,300 articles, roughly about 400 of them met inclusion criteria. And over 50% of them actually didn't just have a p-value less than 0.05, 50% of them had a p-value less than 0.01. So very statistically sound. What they found, and if you go to the bottom, you will notice the last 3 criteria, p-value, the closer your p-value is to 0.05, the more fragile it is. That makes sense, right? It makes intuitive sense. The further you get away from that, p less than 0.0001 is going to be more robust because the difference is much more statistically significant. The number of events. If you do a study where 5 people die and another group 10 people die, well, that's very few events. So those are studies where even if you find a statistically significant p-value, the likelihood of chance impacting those outcomes is much greater. But if you do a study with like 10,000 patients and you have maybe 500 people die in one group and 600 in another, there's a huge difference there. So those numbers matter. The number of primary events you have matter. The more primary events you have, whether it's mortality, whether it's functional outcome, whether it is recanalization, those differences matter the most. And then finally, the sample size of your study. If you're going to do a little study of 50 patients and say my study showed a statistically significant difference, statistically significant benefit of one intervention over another, it's probably going to be fake news. It might be hypothesis generating. It might be suggestive. It might be the basis for a larger randomized controlled trial. But it is very likely that in a follow-up study with 10 times that population, it may end up being negative. But if you do a study with 1,000 patients and you see a significant difference, well, that study is probably going to be more statistically sound. So larger trials with more events, with a p-value much lower than 0.05, tend to have a fragility index that is much higher. So they tend to be much more robust. So moving on to critical care trials. So obviously, like when the fragility index concept came out, everyone started reviewing a bunch of papers and a bunch of trials, started calculating what the fragility index was. So the fragility index in critical care medicine was calculated in the high impact critical care journals. Okay, so they looked at 20 different critical care journals, and some of the findings were actually shocking. So only 50 of those studies were good enough that they met inclusion criteria to begin with. The median fragility index was 2, which means on an average, if you took away 2 patients in the placebo group who had a bad outcome and gave them a good outcome, you would not have had statistically significant benefit of whatever they were proposing in that study. 40% of these trials had a fragility index less than 1. So you had 1 patient in the placebo group. If that 1 patient in the placebo group would have had a good outcome instead of a bad outcome, you would have lost statistical significance. Now, these studies in journals like critical care medicine, intensive care medicine, are studies that we use as landmark trials to determine what we do. And it explains why in critical care, we go back and forth so many times. Proning is bad. Proning is good. Pseudomonal pneumonia, you should treat it for 8 days. No, you should treat it for 14 days, right? I mean, insulin, aggressive blood glucose control is good. Oh, no, wait, it's really, really bad. Oh, wait, it's good again. It's like, what on earth is going on? And this is exactly why, because the fragility index in these studies is so narrow, is so small, that the likelihood that it's a reliable, robust finding is actually extremely low. The shocking part is 23% of these studies, the fragility index was 0. Now, someone's going to ask, how can the fragility index be 0? Right? Isn't the whole concept of fragility index based on the fact that you are showing a statistically significant benefit, and you actually have to flip at least 1 patient in the placebo group from a bad outcome to a good outcome, which would give you a fragility index of 1. How can it possibly be 0? Because, and I know this because in order to get papers published, I've done statistical manipulation of my own, is if you have different ways of doing statistical analysis, you have chi-square test is one of them, a Fisher's exact t-test is another one. You can try when you input this information and try and see a benefit of whatever you're trying to propose. When you see a p-value that is statistically insignificant with Fisher's exact t-test, you can actually try that same thing with a chi-square test. And sometimes the chi-square test will show you statistically significant benefit. With the Fisher's exact t-test, which is the gold standard, you will lose that statistical significance. For the fragility index, they use the latter. Okay, so they use the Fisher's exact t-test. So there are some of these patients, 1 out of 4 trials that were positive, if they had used the Fisher's exact t-test, would have not shown you the statistically significant benefit. But guess what? What are your headlines? You're going to have these huge headlines. This is the new great invention that you should use, or this new drug that you should use. You've got this abstract. No one really goes into the statistical analysis. You see, even the font for that is so small, you can't read it even if you want to. So that's an easy way of getting around the problem. So that's why I keep saying, stop reading the headlines and believing the headlines. Read the entire paper, analyze it yourself, or have someone who knows some statistics analyze it. So you can see on the left side, you look at those tall bars, and that is those studies with a very low fragility index. See how many of them as you go down, there are really few that have a good fragility index. So what are the factors that impacted fragility index in critical care trials? Trials that had smaller number of patients had a low fragility index. Trials with a p-value very close to 0.05, and I'll talk about some of them that are 0.048, 0.046, very fragile. And ones where they didn't analyze mortality as a primary outcome. Guess what? You pick up the phone and say, well, sir, are you able to walk? Are you able to shower? Are you sure you can't do that? Are you sure if you really tried, you can't do that? Oh, I think you said yes. Okay, you mark that down. Somewhat subjective, somewhat biased, right? As opposed to mortality. Is he dead or alive? Oh, he's dead. You're either dead or alive. You can't be halfway, right? So if you have mortality as your primary endpoint, more likely it's going to be a reliable study. If you have all these other functional outcomes based on telephone questionnaires at 90 days, 180 days out, I don't know. So now getting to the main part, I told you we're going to get to this intermission point where we'll actually talk about what's relevant to our patient population, right? No more foreplay. We're going to focus on this now. So the reproducibility of cerebrovascular randomized control trials. So looking at randomized control trials, this paper in World Neurosurgery looked at thrombectomy trials, malignant MCA strokes, carotid stenosis, aneurysm, subarachnoid hemorrhage. So let us look at their papers and what it said. So some landmark trials up here, some of which you will recognize is Mr. Clean, Escape, Revascat. Look very closely at Revascat and Extend IA. Your fragility index for those studies is only 2, all right?
So if you look at isolatedly, let's say Extend IA or Revascat was the only trial out there showing you that thrombectomy is superior to no thrombectomy, I would be a little worried. I would say it's hypothesis generating. I would say it's very promising. I wouldn't change the guidelines based on a small study with a fragility index of 2, where if 2 patients in the placebo group would have had a good outcome, then you would have lost statistical significance. So again, it doesn't mean that by itself, it is not a good study. These are good studies, but when it starts with that low of a fragility index, you need a greater patient population, greater analysis to be able to figure out if that is the first step of several steps to get you to where you need to get. So you look at Mr. Clean, Escape, Revascat, Swift Prime, Extend IA, all in comparison, and you're like, look, it's not just a signal, it's actually clearly a benefit of thrombectomy, right? So that's why you need to have more numbers of studies, more numbers of patients to really know if something is really fragile or if it is robust. Some other studies is EVA3S, which is an old study that looked at symptomatic carotid stenosis. Do you stent them? Do you do a CA? And the ultimate outcome was CA superior to stenting. Look at the fragility index. It's all the way at the bottom. You've got a score of 1. You lost 34 patients to follow up, okay? So if one patient from that placebo group would have had a good outcome that was lost to follow up, or one patient that was lost to follow up in the study group that basically had an aortectomy, had a bad outcome, you would have lost statistical significance. So when your fragility index is less than the number of patients that you've lost to follow up, that by itself makes the study very fragile and not robust. So sometimes don't just look at the number, which is a fragility index, look at the number of patients that you have lost to follow up. Again, this doesn't mean that CA may not be superior to stent or vice versa. I'm just saying that specific study doesn't have enough data to give a compelling argument favoring one over the other because of the fragility index, despite the p-value being less than 0.05. Some of the other famous studies, ISAT. Now that's a great example of a study that's pretty robust. Okay, so you had a fragility index of 38, would have taken 38 patients in the placebo group, which I shouldn't say placebo group, in the clipping group, to have had a good outcome that had a bad outcome, to flip the results where the p-value would have not been statistically significant anymore. Let us say, look at the number lost to follow up, that's 33. Let's say all of those 33 patients, of those patients, the ones that got clipped, they all had a great outcome. And of those that were lost to follow up, those that called, all had a bad outcome and they all died. Still, you would have still had 38 minus 33 equals to 5. You would have still had clear evidence of statistically significant benefit. So again, your fragility index number should be more than the number lost to follow up. So I'm going to make this a little more interactive now, just so that I can involve all of you guys and you guys can do some, guessing here. No criticisms if you get the wrong answer, okay? So NINDS, right? If it wasn't for NINDS 2, if you call me for a code stroke, I'd be saying, if someone's on aspirin, I'd be like, give another aspirin. What else can I do? Or you know what, throw in a Plavix. I wouldn't be giving TPA, right? We needed NINDS and NINDS 2 to basically inform us that TPA should be the standard of care for patients that come in within 3 hours of an acute stroke. Total number of patients that were enrolled was 624. Improvement by greater than 4 points on NIH stroke scale at 24 hours, while there was definitely a difference, was not statistically significant. At 90 days, there was a significant benefit. All right, your relative risk reduction, if you're looking at patients having an outcome of modified Rankin 0 or 1, so no disability or very minimal disability, there was a relative risk reduction of 30%. So what do you think for this landmark trial that we use as the basis for giving every patient TPA within 3 hours is? What do you think is the fragility index? Anyone want to hazard a guess? 20, 30, 40, any number? Single digits. So that's right. So the fragility index actually is 3. What does that imply? You've got a study of 624 patients, okay? If 3 patients in the placebo group that did not get TPA would have had a good outcome and not a bad one, you would not have had statistical significance here. You would have lost statistical significance. We may not have been talking about IV TPA. Now, again, there's some flaws with the way the analysis was done, but nevertheless, if you're just going by the analysis that they did in NINDS2, you would have lost statistical significance, okay? ECAS 3, remember we extended it out from 3 to 4.5 hours. FDA didn't give approval for a reason. P-value was 0.043. Remember, it's very close to 5, or very close to 0.05. Mortality was actually non-significantly higher. TPA is one of those few agents that, because it improves functional outcomes, it's used more routinely and as a standard of care. Yet, consistently across a lot of trials, it has been associated with a slightly higher mortality. Okay, don't ask me to explain it, it just does. So p-value of 0.043, what do you think the fragility index is for ECAS3 for extending your time window from 3 to 4.5 hours? Like this is ingrained in you, right? Up to 4.5 hours, we're giving TPA. What is the fragility index? Anyone? My nurse practitioner group out there in the corner. It's calling you. No, okay. God. Fragility index of 1. Okay, 1. If one patient in the placebo group, 821 patients, okay, one patient in the placebo group would have had a good outcome instead of a bad outcome, you wouldn't have had a p-value less than 0.05. That's 1, okay? This is standard of care. This is bread and butter. This is what we do for a living. I'm not saying don't do it. I'm going to make counter arguments. I like to argue with myself. I like the sound of my own voice. So I first debate, and then I stand, and then I counter debate. I was an only child. It's how I've been brought up. All right, Ross trial. I miss Dr. Muradia, one of my colleagues, because he hates hypothermia with a vengeance. It's almost like, I think like it's a whole Indian thing. Like it's a sign of weakness to complain of the heat. So he's like, no hypothermia for anyone. So unfortunately, he's not here to ask the question, but I'm going to pick on anyone that wants to answer this. Dr. Murthy, let's pick on you, since you and Dr. Muradia were colleagues. Bernard, the famous trial along with Haka, that had 77 patients. You did 33 degrees versus normothermia. There was a benefit, and that's why now we started cooling all our patients post cardiac arrest. Recently, a study came out, Hyperion, not recently, a few years ago, which actually looked at not just shockable rhythms, VFib, VTAC, but even non-shockable rhythms. And for functional outcomes, showed a benefit, even though there was no difference in mortality, showed a benefit of outcomes with 33 gold compared to 37 gold. So what I wanted to do, Dr. Murthy, is add up the fragility index of the first study and the second study and tell me what the total is. Just hazard a guess. Okay. It's actually 1. So if you look at the Hyperion study, again, one patient to flip the outcomes and lose significance. If you look at the Bernard study, again, if you're going by Fisher's exact t-test, the fragility index is 0 because that study was not statistically significant. Right? It seems that way, 49%, 26%, that's a huge difference. But if you're looking at statistics, you have not been able to show with 95% confidence that the findings you've had are not by an element of chance, okay? So again, hypothermia is something we used to do all the time. We don't do as much anymore. This is the reason. This is the standard of care we are basing on the abstracts that you read, the headlines that you read, and what people tell you, which is why I keep reinforcing, actually read the papers. Other fragile trials, one of my favorite topics, but I'm not going to go off on this, PFO closure, like Dr. Hanel knows. If I have time, that's all I'll talk about and why, why I hate it so much. Anyway, the old PFO guidelines was don't close PFOs if you've had a stroke, there is no benefit, based on the first 3 trials that came out. Subsequently, 2 more trials came out, and then there was an update from one of the studies, which was a RESPECT trial. RESPECT trial probably was the one that flipped the switch a little bit more. So in the PFO closure group, 18 strokes, medical management group, 28 strokes. They combined medical therapy into anticoagulation and antiplatelet therapy. If you really break it up, you can see 3.6% for PFO closure, 4.1% for anticoagulation, no major difference. But by combining 2 groups and having one group be really weak, they were able to show a statistically significant benefit. Guess what they did? At 3 years, you had a p-value of 0.08, not statistically significant. You're supposed to do a follow-up analysis at 5 years. They did one at 5 years. Your p-value is going the other way. It's not going in your favor. It's 0.16. Let's just wait one more year. Let's just try. Let's just look at the numbers, guys. So you get the number. You get 0.046, just so close to 0.05, but you're less than 0.05. Bingo. You're not going to do 7-year outcomes, 8-year outcomes, 10-year outcomes. You finally got the number you were looking for. Statistically significant benefit. Close those damn PFOs, right? And now everybody's PFOs get closed. And has anyone gone back and looked at the study and the statistical flaws? Absolutely not. Fragility index of 1. If one more patient in the medical management group would have had a good outcome instead of a bad outcome, your p-value is over 0.05. It's not being recommended. All right. This is one of the 3 trials that led to the changes in PFO guidelines. Other fragile trials. This is one of my personal favorites. It's very close to my heart because it's a Baptist thing, right? We've implemented some changes at Baptist because we're very concerned. Abby's saying 5 minutes. I'm not even close. But so fragility index of 1 for this study. This is a study where they took 100 patients, split them up 50-50, gave half of them that were on broad spectrum antibiotics, oral vancomycin, so they wouldn't have C. diff. took the other 50, didn't give it to them. None of the patients in the group that got oral vanc prophylaxis had an infection with C. diff. It's unblinded study. We don't know how many times it was checked in that group versus the other group. That's the problem with unblinded studies. Now, if one patient in the study group that got oral vanc prophylaxis or one less patient in the other group that did not get oral vanc prophylaxis would have had C. diff, this study would have lost statistical significance. One single small study of 100 patients, we're using that as the basis to do oral vanc prophylaxis on all our patients on broad spectrum antibiotics, right? It's an institutional protocol. And that to me is the problem with not understanding science and statistics, right? And so my guess is more studies will come out, and when we have more numbers, we won't see this difference. Can't prove that. So as a result of that, now everyone's on oral vanc prophylaxis. So I think it's really important to keep in mind what studies you're looking at when someone comes out and makes guidelines or protocols. Now, the problem, like I said, I like to debate myself, right? Fragility is inevitable, right? If you've got a study where, man, you first came up and you got funding somehow and you showed proof of concept, and then you finally get to phase 3 and you're trying to show that something's better than the alternative, and then finally you enroll enough patients and you have all these type 1, type 2 errors and loss to follow-up, and you're finally able to conduct a study, then you're fortunate enough to show benefit. And then someone comes out like me and says, hey, your study is pretty fragile. It's like, what are you talking about? You wanted 95% confidence that this intervention is beneficial. I gave it to you. You can't now say, well, you only gave it to me by this much, right? If Tom Brady scores on the last play of the game and wins, we don't take away his Super Bowl ring from him, right? I mean, he won, right? Michael Jordan scores the last basket. You don't say, hey, what the hell? You know, like you were tied, like you're lucky. You don't win. No, you win, right? You lose the election. It's not like you go and start an insurrection. That would never happen. Right? So, anyways. So, but fragility is, like I said, it is inevitable. You're going to see some fragility. And as long as you met your statistical significance, should you not respect those findings? It doesn't matter by how much you win. You won, right? So, as a counter argument, you know, of course, a little bit of a nerd. All neurologists are. We like our Marvel comics. So what are your ironclad defenses against fragility index? So I came up with 6 infinity stones for you guys. Anytime anyone comes up with, hey, wait, what's the fragility index? All right, so infinity stone number 1, and Shakespeare was able to predict this years ago, like to P or not to P, that is the question, right? Avoid over-reliance on the P-value. We are so obsessed with P less than 0.05. Like P less than 0.05 tells you there's a 95% chance that your findings are accurate, they're reproducible. Right? If you've got a p-value less than 0.05, in other words, 0.049, there's only 4.9% chance that it's an element of chance there, right? So 95.1% chance that your findings are actually accurate, reproducible. If it is 0.051 p-value, so more than p of 0.05, that just flips it from 4.9% to 5.1%. What is in a number? Why does it have to be 95%? Why can't it be 90%? Why can't it be 85%? Or better still, why can't we find better ways of interpreting the results of trials that are conducted, right? So if you go to a patient, are you going to tell the patient, listen, we found a p-value of 0.032 and our fragility index was S, and that's why I think you need to get TPA. I mean, they'd be like, what are you talking about? You know, am I having a stroke or are you having a stroke? No, you would go to them and basically tell them, hey, you know what? If I give you TPA, there's a 30% greater likelihood that you would have minimal to no disability. Right? And this is based on a study that was conducted that had over 600 patients in it. I would buy the TPA. I'd be like, why are you wasting time talking to me? Give me the injection, right? So it's that simple. Sometimes we have to get off our high horse and start talking about what actually matters to the patient. Number needed to treat. How many patients do you have to do a thrombectomy on so that you can potentially save one life or you can potentially affect one outcome positively, right? So number needed to treat, relative risk reduction, that matters. Your p-value is just a number. So we need to get over this whole p-value. One of the first things I learned when I came to America in 2000, right? Size does matter. Everyone talks about it, right? Size matters, supersize me, all you can eat. So the bigger your trial and how you use it, the bigger your trial, the more numbers of patients in your trials, the more likely you're going to have robust findings. We spoke about how Revascat and Extend-IA by themselves had a fragility index of 2. Throw in Escape, throw in Swift Prime, you've got a large analysis, you've got reproducible studies showing you a benefit. Nimodipine trials, one of the original ones by Allen, one of the big Problems with that was fragility index of 1. Nobody knew how nimodipine worked. Oh, it doesn't affect angiographic vasospasm. It's neuroprotective. How is it neuroprotective when it doesn't neuroprotect anything else? But then finally, when you've had 16 clinical trials where the overall numbers seem to favor the benefit of nimodipine, it becomes level 1 evidence, and good luck not giving it to your patients. You'll probably get sued, right? So you need more numbers. You need more number of trials. You need more number of patients to actually show a significant difference. Again, a sample size makes a difference. Remember what I told you about that trial with oral vanc prophylaxis. So if you have 5 times as many numbers, then maybe those findings are in fact real, and they are robust, and they're reproducible. We had the NOVA 7 study that actually showed decreased mortality, improved outcomes when you actually gave a hemostatic agent, activated factor 7 to spontaneous ICH. Guess what? You doubled up those numbers, had over 800 patients. Placebo was better. Placebo had lower mortality than activated factor 7. That's why numbers matter. You had the HACA trial, the Burner trial. We hypothermized and cooled patients left, right, and center for years. I made a lot of money doing it because you kept consulting me. How should we cool? How quickly should we cool? How much should we cool? Right now, TTM1 comes out and says, guess what? 33 isn't better than 36. Then TTM2 comes out, says, guess what? 37.5 is no better than 33 is no better than 37.5. So now we're not randomly cooling everyone. If we had better conducted trials with more numbers before you jump to conclusions and made guidelines, perhaps we wouldn't have gone this route for the last 10 to 15 to 20 years using an intervention that was never statistically sound. Unfortunately, we always figure these things out in hindsight. You need to do it. You need to have some foresight. We're scientists over here, right? So again, statistically, it's useful to have someone who knows a little bit of statistics, who can actually talk to you about these things and say, hey, I have some issues with this. Don't go by the headlines, read the actual study. Infinity Stone of Wisdom, number 4. Again, like I said earlier in my studies, there should be a difference in the positive direction of fragility index compared to how many patients were lost to follow-up. So again, like I said, with the ISAT trial, fragility index of 38, even if every single of those 33 patients lost to follow-up would have gone the other way. In other words, all the clippers lost to follow-up would have done well, and all the coilers, would have done awfully. Still, you would have found a statistically significant benefit of coiling over clipping. So that's a robust study. You have the nice sugar trial, the one that said, hey, you shouldn't do 70 to 110, to like 80 to 1 or 120 to 180 for glucose control. In that study, sure, you showed a statistically significant benefit, but your fragility index is 11. It is significantly lower than the number of patients lost to follow-up. That difference is a problem. And maybe that study is not as statistically sound as we think. And finally, there's CRASH 2, which is somewhere in between. Yes, your fragility index is lower than the numbers lost to follow-up. It would have taken a lot of patients lost to follow-up to actually have outcomes that were unanticipated, to actually lose their statistically significant benefit. So some are not that clear-cut. Clearly, the take-home message is you need to look at the fragility index. You also need to look at the number of patients lost to follow-up. Number 5, the COVID effect, right? So, we don't know much about COVID yet. We didn't know anything about COVID in 2019, 2020. We had a bunch of people telling us use chloroquine or hydroxychloroquine, because that's how it works, like chloroquine and hydroxychloroquine. We had ivermectin. We had all these weird guidelines people came up with. And at some point we were like, wait, what's going on? Like everything you told us like 2 months ago, you say is contraindicated. Then you come up with something else. And then 2 months later, you say it's contraindicated. They have my sympathies though, because they were dealing with a pandemic. You were doing the best that you could in real time with a disease process that you did not understand. But in the setting of stroke, in the setting of head bleeds, traumatic brain injury, neurocritical injury, anything, status, these diseases have been there for decades. So you can't make that same excuse. You have to have different standards. It is okay on a guideline to say there is insufficient evidence to recommend for or against. Trust me, I was the same guy reading these guidelines 25 years ago saying, this is bullshit. Why don't they actually commit to something? Why are you so weak, man? Have a spine. But as you get a little bit older, maybe just marginally wiser, you understand that it is okay to say, we don't have enough evidence to make a compelling evidence one way or another. And that's okay. But unfortunately, this is the Insta generation. You want an answer for everything. Guess what? You don't always have all the answers. We don't. We definitely don't for marriage, right? I mean, just nobody does. And finally, and this is the most important thing, some of you guys may erase this lecture from your memory bank when you leave here, and that's okay. This is a lot of statistical mumbo jumbo. But if you forget everything that I've said today, absolutely everything, it is really imperative that you remember what I say on this next slide. If you have someone that you know that has a stroke or has a bleed or any neurocritical illness, please call Baptist. Right. We would love to take care of you. It would be our everlasting joy. So this is a picture from way back in 2016. You can see that weird guy in a suit sitting up front who looks way out of place. That's me. If you look really closely, that's the same suit I'm wearing today, which goes to tell you that even though I work for Liley Neurosurgery, perhaps I don't make enough money. So this is a call for a pay raise here. And I can see some of my nurse practitioners, and there's some tears coming down because they look so much younger there than they do now. But it's okay. We all age gracefully. It's part of the aging process. It's okay. If you have any criticisms related to this study, or I said anything offensive, please direct them at these two individuals. Gustavo Cortez and Victor are responsible for everything offensive in this presentation. Thank you.
Hey, man. Hey, I feel like you're playing mind games with us with those numbers. So, I mean, you're just making an argument we shouldn't probably be following the p-value. I think along the same lines, I'm not sure how to interpret the fragility index when the number needed to treat in the TPA patients 1 and 8, and the index is 3 or 2, right?
Yeah.
So I don't know how can those two don't make sense.
No, I
agree
with
trial, number needed to treat is 3, yet the fragility index is 22, so, and that's only 10% of the sample. So
you know how, they say 2 wrongs don't make a right, right? And the way I look, and that's why I was making the counter argument with the fragility index. It's like the reason there's a fragility index is because there is a p-value. If the p-value wasn't something that everyone set as, your role model, as, that's your gold standard, there wouldn't be a fragility index. So you're exactly right. When you're presenting to a patient, like I said earlier, talk about relative risk reduction, talk about number needed to treat. Those are important numbers. I actually do think IV-TPA works. I do think IV-TPA works at 4.5 hours. A lot of the studies that I cited where the fragility index was low and the statistically significant benefit was borderline. The point I was trying to make was not that those studies are bad studies. The fault is not in our stars, but in ourselves, right? We pick the p-value to basically determine what is statistically sound and what isn't. And what my point is, if you're going to use the p-value, you have to also throw in a fragility index. Otherwise, ignore the p-value. Never talk about the fragility index. Talk about, like you said, number needed to treat. Number needed to treat of 8 or 3, depending on whatever outcome you're looking at with IV-TPA. Absolutely.
Any other questions?
Thank you. Is Joao good to go? All right. Our next speaker is Dr. Joao Gomez. We good?
Hey, Niraj, how are you?
I'm getting some shrugs, some questions. So Dr. Joao Gomez is, I've known him from 2004. We've known each other for several years, close to 20 years. He did his stroke fellowship with Dr. Kaplan at Harvard. He did his neurocritical care fellowship after that at Johns Hopkins. He is the medical director of neurocritical care at the Cleveland Clinic. So it's hard to top that. I don't know what else I can say in terms of an introduction for him. But I will say one more thing. I think his greatest accomplishment was, he was my senior fellow, and the number of patients that would have otherwise died at my hands that he saved to this date remains his greatest accomplishment. So Joao, thank you for being a wonderful physician, a wonderful mentor, and thank you for coming and speaking with us. Thank you.
Thank you, Niraj. I want to make sure that you guys can hear me well. Can you guys hear me well? All right, I'll assume so. I'm just gonna stop my video just to make sure that I preserve bandwidth since I'm remotely. I apologize I cannot be there in person, but I certainly appreciate Niraj, your kind invitation to join you guys today. I'll be talking a little bit about multimodal monitoring neurocritical care, in particular, how we approach it here at the Cleveland Clinic. I'll start by saying that I don't have any relevant financial disclosures associated with this talk. I will mention a number of medical devices and technologies that we utilize, most of which have FDA approval for the indication, but in case I don't, rather, in case I speak about any technology that doesn't have any FDA approval, I will make sure to point that out, of course. Old slide, as you know, whenever we think or talk about brain injuries, you have the primary sort of brain injury that takes place, whether it is an ICH, subarachnoid, TBI, etc. And but however, in the hours and days following that primary injury, of course, there is a number of potential injurious mechanisms that take place, or secondary injuries. And these are the injuries that we as neurointensivists are trying to minimize or trying to placate as much as we can. Some of these injuries can be predictable and others are a little bit more difficult to predict. And they can come in various flavors, right? So it could be ICP elevation because of cerebral edema, it could be hypoxia, some ischemic component, fevers, infections, alterations in the internal milieu in terms of glucose, sodium alterations, etc. So as I mentioned, some of these are predictable and others are not. And the less predictable they become, the more impact that neuromonitoring could potentially have in preventing them and modifying their course. Now, for years, if you look at your any ICU, any neuro ICU room, you have your bedside monitor, and primarily the focus there is on cardiopulmonary function, right? You get your EKG tracing, you get your SATs, blood pressure, of course, and the one sort of neuro item that you get is intracranial pressure, and that's that, right? That's it. You don't get much else. But there is a wealth of data that we can now obtain that would be quite helpful. I would like to be able to have display in that or some sort of monitor. Cerebral metabolic rate of oxygen, intracranial pressure, cerebral oxygen delivery, cerebral blood flow, any sort of electrical dysfunction, cerebral autoregulation, just to name a few. Now, here in the US, we have primarily one platform which does have FDA approval for multimodality monitoring. Is the Moberg here in the right upper hand corner. And it does sort of connect to the bedside monitor and can display a lot of the data. It also connects to a myriad of devices, TTM devices, pupillometers, Bowman for cerebral blood flow, et cetera, Lycox for cerebral oximetry. There is another platform called ICM Plus, which actually is really a research platform, doesn't have FDA approval, so that distinction needs to be made. But actually, it's my preferred. We have both here at the clinic. I prefer ICM Plus because of the flexibility in terms of doing manipulating the data and doing sort of different types of research. They both try to do at some level the same thing, but at another level are quite different. And I'll elaborate or show a few real life examples in a little bit. Now, when we look at or talk about multimodality monitoring, it can come in different flavors, right? And some of the questions that one has to answer is, do we want invasive or non-invasive monitoring? Do we want continuous monitoring, ideally, or episodic, such as even a CAT scan, right? One of the great potentials, at least, of this type of monitoring is that you could hopefully individualize the approach to care. But as Dr. Freeman mentioned before in his AI machine learning talk, you could easily end up with data overload. Just to give you an example, ICM Plus samples data 300 times per second. So depending on how long you monitor a patient for, some of the recordings that we have, we end up with millions and millions of data points. It's difficult for the human mind to analyze that, right? And really, and I think he made a plea for this, we need to get more trained in bioinformatics and understanding machine learning and AI to be able to effectively use all this data and try to positively impact patient outcomes. And as I mentioned before, there is a wealth of different devices. And there is actually some guidelines put forth by the Neurocritical Care Society. There was a consensus conference on recommendations for multimodality monitoring. I think even though a lot of them have strong recommendations, the quality of the evidence, as you can see, for the most part, is actually quite weak. As I mentioned, there are different probes that we can use. Some of them are invasive, as depicted there, and they range from EEG leads that go sort of on the surface and the cortical aspect of the brain quite popular for the detection of CSD or cortical spreading depolarization, which is sort of a hot topic in subarachnoid hemorrhage. And now for quite a few years, we've been using cerebral oximetry probes that are invasive, as well as cerebral microdialysis probes. They both have pros and cons, if you will. But there was last year this paper that was published on patients with subarachnoid hemorrhage, looking at was a small meta-analysis looking at the literature on different approaches for multimodality monitoring, showing that on top of the standard management, if we added one of these three modalities, and most of them, to be fair, included either oximetry or microdialysis, but if the management includes one of these modalities, the outcomes of the patients actually seem to be better. So making well, not a randomized controlled study, of course, making an argument for this type of monitoring, at least in subarachnoid hemorrhage patients. Now, in our ICU, we have taken a little bit of a different approach. Instead of going for invasive probes, we actually want to do exactly the opposite. We're doing all non-invasive monitoring devices, which I'll share with you in a minute, for a number of reasons. One, because then we can capture anybody we want, or almost anybody we want. We're not depending on the surgeons to come and do a burr hole and place some of these devices. And of course, they're reluctant because the potential risks of placing invasive probes in someone's brain. So I'm going to take a little bit of I'm going to deviate a little bit from monitoring and talk about cerebral autoregulation, just because a lot of aspects that I'm going to discuss next, it will be helpful to have a sort of a brief working knowledge of what I mean when I'm talking about cerebral autoregulation. Everyone in med school remembers the Lassens curve, sort of that ability to maintain blood flow more or less constant regardless of changes in blood pressure. Turns out that in reality it's a little bit more complex than that. I think is from a theoretical standpoint is perhaps helpful to visualize it that way, but we know that in reality it doesn't quite work that way. But at the most basic level, if your blood pressure drops, obviously your cerebral blood vessels vasodilate to try to keep up with cerebral blood flow. Conversely, if your blood pressure increases, your vessels constrict and try to minimize the flow so that you don't have major alterations in autoregulation. Now, it turns out that a lot of patients with brain injuries have impaired autoregulation, and that could potentially be a basis for that secondary injury that I was referring to earlier. We also know that autoregulation doesn't really fix quick changes in blood pressure, and I think that's an important point. We're talking about sort of a slow fluctuations in cerebral blood flow, or blood pressure rather, that can be sort of addressed with autoregulation. The easiest example is the one you have there on your bottom right. Most of you are sitting down, I presume. If you were to quickly stand up and we were measuring your CBF, and presumably all of you are normal, with normal intact autoregulation, you would still have a drop on your blood flow of some degree. And what autoregulation is going to accomplish over time is try to restore that balance, but that's going to take a little bit of time. It's not something that happens right away. Also, in terms of the different technologies we have to assess autoregulation, ICP, invasive ICP waveform, by far is the most common technology utilized, but certainly not the only one. One can use transcranial Doppler ultrasound, near-infrared cerebral oximetry, which is non-invasive, of course, as well as, it turns out, as I'll show you later, non-invasive ICP devices. The other deviation I'm gonna take in my talk today is talk about blood pressure control in ICH. And I have to say, when I realized after the kind invitation by Dr. Naval that I wasn't going to be able to be there in person, I actually was quite disappointed for a number of reasons, including the fact that knowing that Santosh was going to be there and his interest in ICH research, I really wanted to have this discussion with him in person. But through the magic of data massaging, right, we started with 2 negative studies on blood pressure control in ICH, INTERACT-2 and ATTACK-2. As the authors themselves recognized, their primary endpoint was negative. And somehow, as I said, with a little bit of data manipulation, we end up with positive data. And if you look at the most recent recommendations for the management of blood pressure in ICH in 2022, they give you a target, to 140, keep it between 130 and 150. Again, based completely on two negative studies and a lot of post hoc analysis, which is sort of another fancy word for massage. Interestingly, though, the whole concept of blood pressure control after ICH, at least the theory has for the longest time been that you're preventing hematoma expansion by controlling blood pressure, and therefore that explains the improvement in outcomes. Well, it turns out, and this is from the famous editorial after Interact 2, they acknowledge the reasons behind this trend, remains a mystery, and remains a mystery because there was no such reduction in hematoma expansion in this patient population. So, and if you look more closely at the strength of the recommendation for blood pressure control, it's actually quite weak. I don't know, Dr. Naval perhaps has the fragility index for that particular studies. I'm going to venture here that it's pretty low. But even the recommendation, the American Heart Association had to soften it quite a bit, and very close to class 3, to be honest with you, which personally I think is where that recommendation belongs. So how are we approaching that here, leveraging our multimodal monitoring program and some of the tools that we have? So we use a lot of near-infrared oximetry, as I mentioned before. It's a couple of stickers that go in the forehead. They measure relative percent of oxyhemoglobin, and all things being stable and equal, in particular the FiO2, is a surrogate marker for cerebral blood flow. So an actual patient of ours came with that ICH depicted there. We monitored that patient for a number of hours, and you have sort of a graphic summary of what autoregulation looked like for that patient. Green, of course, being normal autoregulation, and red being quite abnormal. And as you can see, there are big chunks of time where the autoregulation in this particular patient was quite abnormal. Now, what the way autoregulation works or is calculated, the dynamic autoregulation, is based on a Pearson correlation. So +1 is as impaired as it can be, -1 is completely normal and intact autoregulation. The question is, where do you draw the line? So we did this last year, about 20 patients that we monitored when we decided to just stop and analyze our own internal data, and use different, as you can see in table 3 there, different thresholds, try to find out what the right threshold was. And it seems that 0.3 it has the best predictive value for in-hospital mortality. Now, small numbers, obviously, but the important thing is that if you look at other studies in stroke, ischemic stroke, and TBI, that threshold of 0.3 keeps coming back. We didn't want to assume that was the right thing to do, so we wanted to go back and analyze different thresholds. But that sort of re-emphasizes that seems to be quite relevant. And as you can see, patients that spend the percent of the time that they spend over that autoregulation index of 0.3, remember, higher is abnormal, lower is normal, actually correlated quite well with mortality. Now, as I said, small numbers. And besides the small numbers, obviously, doesn't necessarily mean causation. It could be that the injury is so severe, and that's why the autoregulation is impaired, as opposed to the impaired autoregulation leading to secondary injury. So we acknowledge that. However, our hypothesis and the way we're moving forward with our patient population is using autoregulation guided, personalized, optimal blood pressure in ICH. What do I mean by that? We looked at the blood pressure at which, or the mean arterial pressure at which the index of autoregulation is the lowest, as you can see in this parabolic black curve over there. And that to us indicates that that's the blood pressure range where autoregulation is the best and the brain is the happiest, if you will. But also it allows us to calculate, at least theoretically, the upper and lower limits of autoregulation, meaning as your blood pressure decreases, your autoregulation index goes up, and once it crosses that magic threshold of 0.3, as you see here on the left, you potentially are risking hypoperfusion, and you increase the risk of ischemic stroke. As you know, depending on which series you look at, 25 to 40% of patients with ICH can actually have ischemic strokes. And we think that one of the variables that contributes to that, besides the presence of a vasculopathy, is the fact that they may be hypoperfused. And you're doing that because you're going blind by what the American Heart Association is telling you in terms of blood pressure range of 130 to 150, which may or may not be right for you, particularly if you live in the 220s and your autoregulation curve is shifting. On the other hand, the percent of the time that you spend above the upper limit of autoregulation, we hypothesize, actually can increase your risk of hematoma expansion. Something that they failed to demonstrate either ATTACK-2 or INTERACT-2 with this one-size-fits-all approach, but we're theorizing and we're actively looking at. So this is, I should mention, this project is has been done primarily by one of our fellows, Katie Hassett, who now joined us and is doing a master's in clinical research, and this is sort of her project. So we're hoping to get closer to 10 patients and reanalyze, 100 patients and reanalyze our data. But it's not just hemorrhage or ICH. We also utilize some of this technology for our ischemic stroke patients. So you can see here an 82-year-old woman with various vascular risk factors, had a common carotid occlusion with fluctuating exam. By the time she came to us, her NIH stroke was 4. So at the bedside with interventionalists, there was no plan to go after this because she really had minor symptoms. All of a sudden, as we're talking about what to do for the night in case anything happens, right there, her exam worsens, her NIH increases to 20, so she quickly goes for stenting. So they're able to stent the common carotid, that recanalize, and everyone is happy. Again, I connect her to our near-infrared, and post hoc, when we analyze the data, as I said, we don't use this yet because it's not FDA approved to make any changes unless patients are part of a clinical study of a trial. We realized that for a period of time, as you can see, her optimal mean arterial pressure predicted was around 76 millimeters of mercury. But for a period of time, though, we actually were above the upper limit of autoregulation. You can see that early on, there is a lot of red, and as time goes by, that red becomes less and less prevalent, and we see a little bit more green, and we know that autoregulation improves over time. Unfortunately, she did develop a little bit of hyperperfusion syndrome, have some degree of cerebral edema and a headache, and we think that was related to having blood pressure goals that were within the parameters that the endovascular team wanted, but evidently for her, because she tends to run a little bit lower, were a little too high. So this is potentially another use for this sort of multimodality monitoring and autoregulation-based blood pressure management. This is from a group from Yale looking at patients with acute stroke and LVO, and the percent of the time that the patients spent above the upper limit of autoregulation was associated with worse discharge modified Rankin and 90-day modified Rankin scale. And that worsening sort of functional status seemed to be driven primarily by the presence of perihematoma edema and symptomatic ICH. Again, being above that upper limit of autoregulation and causing trouble. There is an ongoing, or I should say, there is a study that recently finished, the COGITATE study on TBI, also using autoregulation-based blood pressure or CPP management instead of using near-infrared. Because it's TBI, most of them have some sort of invasive ICP monitor. They're using an ICP-based index of autoregulation. We don't know what the results are, but so far, and this is from the Cambridge group, looking at their data, historical data, patients that spent a significant amount of time above that threshold of 0.3 that I mentioned before actually had much worse outcomes and increased mortality. I work at the Cleveland Clinic, and if you know anything about the Cleveland Clinic, of course, it's a heart hospital with all of us here basically at their disposal to make their lives easier and make them happy. So we get a lot of LVADs and ECMO. And as you know, these devices can be associated with a lot of neurologic complications. They have a need for anticoagulation. But more importantly, there is loss of pulsatile flow. And it's always been theorized that the brain doesn't like this lack of pulsatility, that actually wreaks havoc in different vascular beds. There was a study not long ago in patients with LVAD that they actually looked at the aorta, and they found that the aorta was quite rigid. There were significant changes in the histology of the blood vessel that it led to vascular stiffness. There was a lot of fibrosis and collagen deposits, etc. And they theorized that these vascular changes may actually be responsible for some of the complications that we see, not only in the brain, but in other vascular beds, as I mentioned, including the kidneys. So this is the graphic representation of autoregulation in the patient that we had on ECMO. This was during the COVID pandemic, somebody who was quite sick in ARDS. As you can see in red, you have left and right, is abnormal oral regulation. So basically over 90% of the time, this particular patient had completely abnormal oral regulation while this patient was on ECMO. When the patient woke up, had a lot of, did well overall, but had a lot of cognitive issues. So eventually ECMO was discontinued. He went for an MRI, and lo and behold, this guy was in his 20s. We see a lot of microbleeds. So no history of familial amyloid angiopathy, completely intact neurologically before that. You see superficial desiderosis and what have you. Granted, he was anticoagulated. He was never above sort of supratherapeutic levels. He was therapeutic for the most part. And the theory, of course, we cannot prove it yet, and we are actually studying this here with our cardiology colleagues, is that the loss of pulsatility led to impaired oral regulation with probably hyperperfusion during ECMO, and that led to multiple microbleeds that you see there. So one of the studies that we have with our cardiology and cardiothoracic surgery colleagues is looking at patients in acute decompensated heart failure, and we monitor them during multiple sessions before and after LVAD implantation, and we're trying to understand what that loss of pulsatility means for the brain. So hopefully we'll have more data on that. But it's not just for patients who live in the neuro ICU, if you will. There was this study looking at impaired oral regulation and delirium in medical and surgical ICU populations. So while our diseases, ICH and subarachnoid hemorrhages, are really not that common, for medical ICU, sepsis, ARDS, and all the surgical ICUs, they tend to be a lot more prevalent than ours. And this could have a prominent impact. And that abnormal oral regulation was tightly correlated with delirium. And as I showed you before, they actually were able to calculate sort of optimal mean arterial pressure. And there are ongoing efforts to try this approach in patients in the medical ICU to see whether that leads to decreased delirium incidence. So that remains to be seen, but may have application, beyond just the four walls of our neuro ICU. And of course, I don't think any talk about multimodality monitoring, especially non-invasively, would be complete without talking about transcranial Doppler ultrasound. We have this robotic probe that holds it in place. The nice thing is that the robot, the machine, the AI, if you will, knows what a TCT waveform should look like. It searches for it automatically and then clamps it there and follows that as long as the patient doesn't move excessively. So that takes away some of the human error. And one of the studies that we're doing, and one of the things that we started doing here a few years ago was using we started with the Montreal protocol and intravenous milrinone, and then when nicardipine was not available for ventricular intrathecal use anymore, we switched to milrinone intrathecal. And the question has always been, what's the right dose? So we're doing a pharmacokinetic study to try to understand that a little bit better. But because we have this ability to monitor patients in many different ways, we're doing transcranial Doppler and looking at the percent change in mean flow velocities with TCD. So you can see by 2 hours, they have typically on average decreased about 40%, but by 6 hours, they're already back to baseline or close to it. But also PRX, or pressure reactivity index, another measure of autoregulation based on invasive ICP, is quite abnormal in this patient population. And with milrinone, though, we're actually able to correct it quite significantly. Once again, that red line indicates a 0.3 sort of magic threshold. By hours 4, 5, 6, we see abnormalities. And that abnormalities in autoregulation sort of correlates the increase in mean flow velocities. We need one more patient to plug into our pharmacokinetic model, and hopefully we will have completed the study at that point. But so far, it looks quite promising based on what our preliminary results. All right, now non-invasive ICP is something that I've been interested for quite a period of time now. I truly believe that in my lifetime, we're gonna be able to non-invasively determine very close, if not, quite accurately, what the actual intracranial pressure is. And I'll show you a couple of devices that one we have worked with extensively, and the other one we're about to engage with the company to work on it. So the first one is a mechanical extensometer. As you can see, it's a headband. It has this particular sensor. There is now a more modern looking version of this, but basically that sensor can detect micro expansions in the skull associated with each heartbeat. And as you know, the heartbeat is sort of the precursor, the engine for that ICP waveform. So it gives you a surrogate for what the ICP waveform looks like. They don't give you a number just yet, just the ICP waveform, and then you can do some sort of analysis with that. This is an actual snapshot that I took on the patient bedside monitor. The top white line is actual invasive ICP through a ventriculostomy that is closed, that is clamped. And the bottom or P4 waveform that you see in white is the one that we derived from the non-invasive ICP monitor. And I just wanted to highlight that not for everyone, but for some patients, the similarities are actually quite remarkable. I showed just the similarities at the bedside. We did, we have monitored a number of patients now. We did a spectral density waveform analysis, and we're actually able, whether it is invasive or non-invasive, to replicate or to capture the different frequencies, the waveforms that you would expect from cardiac, respiratory, the B waves that Lundberg described a long time ago. So all of those different waveforms that you would expect to capture and that you can capture with an invasive ICP waveform, you similarly can capture with a non-invasive, with this non-invasive device. I don't want to make things too complicated, but we decided to explore whether with this device we could actually use it to measure an index of autoregulation called pulse amplitude index. And basically what that index looks at is how much the amplitude of your ICP waveform changes in relation to changes in mean arterial pressure. Obviously, by definition, if increases in mean arterial pressure result in increases in the amplitude of your ICP waveform, your autoregulation and cerebrovascular reactivity are impaired. So we ended up with 24 patients that we retrospectively looked at that had undergone invasive and non-invasive ICP monitoring for a period of time, usually about 30 to 40 minutes, using our ICM Plus platform and RStudio software. We analyzed the data. So this is a table summarizing the clinical characteristics of the patients, also summarizing the sort of the outcomes, duration of monitoring, etc. I really don't want to belabor the point other than to say that these are typical neuro-ICU patients, most of them with ICH or subarachnoid hemorrhage. All of them had ventriculostomy. On your left, you have repeated measures, linear regression analysis, showing that there was actually quite good correlation between invasive and non-invasive PAX. More importantly, the Bland-Altman plots showed quite significant agreement between both technologies for the determination of pulse amplitude index. So we actually think this is a very good, reliable tool to determine autoregulation non-invasively based on an ICP waveform, which still remains the gold standard. Now, not to deviate too much from that, we are venturing out a little bit more and getting a little bit more greedy. Besides autoregulation, can we look at compliance? And there is a number of techniques that have been validated for the estimation of compliance, but we're trying to use this particular one using transcranial Doppler and non-invasive ICP. And so far, as you've seen these repeated measures, linear correlation again, the preliminary results, this is only 11 patients, a project that one of my residents is going to present at NCS. It seems to be to work and perform quite well. The device that I mentioned before does have a software platform that calculates a number of different things, including the P2P1 ratio, which is thought to represent an estimation of compliance, as well as the time to peak. And this is the type of output that they provide. And they give you a minute average, so minute by minute average. And you need at least 50% of good waveforms for the platform to work. Another thing that we're looking at of these three different ways of estimating compliance, namely time to peak, P2P1 ratio, and the combination of TCD and ICP waveform, which one has better agreement non-invasively with the invasive counterpart. So we're working on that now, and hopefully we'll have an answer for many of these patients that may not be candidates for invasive ICP. Let's say ischemic stroke patients with malignant MCA syndrome, acute liver failure patients. We seem to have quite a few of those here with cerebral edema. Really not feasible to go and drill a hole and put an ICP monitor, but perhaps we don't even need ICP. We can trend compliance over time and hopefully impact their management in a positive way that way. Nonetheless, the heading of this part of my talk was non-invasive ICP. So, we heard about machine learning and AI, and that's exactly what we did. We teamed up with a computer scientist. And what you see there in blue is true or actual ICP or invasive ICP. And in orange, you have your estimated ICP based on our non-invasive device and A-line. We're still underestimating it by a few points, anywhere from 2 to 4 points. So we're narrowing in. The model is not quite ready for prime time yet, but I think we're going to be able to get it pretty close, where you put this device and you're going to be able to get a very accurate estimation within a couple of points of what real ICP is. Now, I mentioned that also there was another company we're working on, and they want us to do a validation study on their particular device. It uses oximetry, but it's a little different from the one that we have now in terms of how it works. But this is the type of output you get from this device. You get a waveform that looks very much like an invasive ICP waveform, but actually this is all based on oximetry data that they obtain. So you can identify your 3 components of the ICP waveform and temporally quite related to ventricular systole and to the ICP waveform obtained invasively. More importantly, though, they have some preliminary data looking at invasive versus non-invasive ICP that looks promising. So they want us to come and validate their device and to use some of that, leverage some of that machine learning sort of collaboration that we have to try to refine this product. The advantage of this over the mechanical extensometer, of course, is the fact that is less prone to movement artifacts. So I think there is quite a bit of hope for that in the near future. So to conclude, I think probing the brain in multiple different ways and with different devices, particularly non-invasive ones, provides valuable insight into the pathological processes that are going on in patients with acute brain injury, and may actually help individualize the care as opposed to using these blanket sort of one-size-fits-all approaches. I would say, though, that the platforms are very clunky. You can tell that they have been designed by engineers for engineers. And I don't have an engineering background, so you can imagine how that went. We need to also do our part and try to do a little bit more training in bioinformatics and machine learning. I think all this is preliminary studies, very interesting, but I think we need to take it to the next level and identify the right trends and the right thresholds so that we can translate this into the clinical decision-making at the bedside. And honestly, I believe it's the next frontier in individualized neurocritical care management. And as I mentioned, not just neurocritical care, but I think critical care in general may have a role as well, even though it's very brain specific. I want to acknowledge some of my collaborators here at the Cleveland Clinic. Once again, Dr. Naval and the organizers, thank you so much for your kind invitation. I'm happy to take any questions.
Thank you, Joe. Any questions? Hey, Joe, one quick question for you. I rather comment on, so I can gauge your thoughts. When the Cambridge group initially came out with, the concept of optimal CPP and optimal ICP, they made the argument of how an ICP of 15 can be pathological in one patient and an ICP of 30 in another one can be totally fine and not hurt the patient. Unfortunately, with all the data that they accumulated, ultimately, the Brain Trauma Foundation said, okay, we're going to change our ICP goal based on that data to less than 22 instead of 20. It's a little disappointing when the goal, I guess, of the Cambridge group was to show that different people have different thresholds for optimal ICPs and CPPs, was for another organization to take the average and then say, hey, guess what? Let's move it a little bit 2 points higher. How do you think, I know we're doing a lot of cool things, but do we really think that we can move to a point where therapy can be individualized based on some of the data that you're bringing up? I'm just disappointed by what happened with all the initial data that came out from Cambridge, where really different map codes based on whether it's ICH or subarachnoid hemorrhage or CPP goals. And it doesn't seem to matter. We have the same CPP goals for everyone, same ICP goals for everyone. How do you think, when we talk about the next frontier, how do you think we can actually achieve that from a practical standpoint?
Yeah, I mean, I think you make good points. I think you get a sense that I'm not a big believer in these one-size-fits-all approaches. Of course, that's what guidelines attempt to do. And I guess, if you take a population large enough and you give them some of these sort of ranges for blood pressure, overall you might benefit some patients, but I really don't think that's the best approach. What about somebody with a small ICH versus somebody with a very large ICH? What about somebody who lives in the 220s versus somebody who lives in the 160s, right? So that's why I philosophically cannot get behind this type of thing. And I know you're talking about TBI, but I think similar arguments can be made for ICH. TBI, they have Cogitate studied their effort. And I think they're going to push it to the next level, depending on the results of this phase 2 study, to see if they can do a phase 3 randomized clinical trial where they're going to be managed either by CPP goals alone or by this optimal CPP concept. In our experience, we have shown that you can feasibly calculate optimal map in these patients real time. We don't do it because the platform is not FDA approved, so we shouldn't use it for clinical care. And for all the regulators that are listening, we don't use it for clinical care. But the reality is that it's very easy to turn on that functionality and get that type of information. Now, I should mention that if you use the method described by the Cambridge group, you need about 4 hours of data to be able to come with one of those nice graphs that I described. There is a different method described by a group in Belgium using another index called LAX. I don't have a lot of experience with it because it's not open source, so they never publish their methodology. We're trying to reverse engineer it to see if we can achieve the same results that they did, but they claim that with that technique, you can get minute-to-minute optimal blood pressure or optimal CPP. If that's true, that would make things even easier and more feasible. The last comment I would say is that study that I showed you about LVO and autoregulation, that's from the Yale group. And my understanding is that they have secure NIH funding to actually enroll patients in the study after they undergo revascularization to actually sort of randomize them to autoregulation guided blood pressure management. So it's quite feasible. And I think that's sort of how we're going to get to the next frontier of individualized care.
Thank you, Joe. Very exciting.
Thank you, guys.
From a nerdologist standpoint. Thanks again, Joe.
Oh, my pleasure. Thank you.
You really didn't have to do this, Abby. Thank you. It was an honor and a privilege to just speak. What? I'm giving this away?
Yes.
Why?
Our winner for today.
I'm always a winner. Why did this person win?
That was the drawing.
Okay. The winner of this wonderful, I don't know, what is this? It's a gift basket. And what about that? Is that also for her? Yes. Okay. Yeah, I'm fine keeping the Chardonnay. The winner of the gift drawing is Jennifer Pepper.
Also, I just want to make a quick announcement for the nurses that we have in the room. Please, when you leave, there are eval forms out on the table that we'll just need you to fill out before you leave so you guys can get that added for your CEU credits, okay? Thank you.
But you shouldn't leave now. So the next talk should be quite interesting. So Thomas Oxley is a neurologist, an interventional neurologist who trained originally in Australia, who still shares his time between Australia and New York. He worked at Mount Sinai in New York, and he's the founding CEO of Synchron, which developed brain-computer interface. For people who may have looked at the news as recently as last week, there was rumor that Elon Musk with Neuralink was trying to purchase Synchron. So really a topic of actuality. Synchron is way more advanced, I would say, in the race towards developing a brain-computer interface. So I'm sure that it's going to be quite interesting to hear about Thomas himself.
Hello, everyone. This is Tom Oxley. I'm sorry I can't be there in person, but I'm very excited to be presenting on our project assessing an endovascular brain-computer interface. Okay, so I am currently in New York City, where I'm running a company called Synchron, and I'm still on faculty of Mount Sinai Hospital and interventional neurologist, as well as the Department of Medicine at the University of Melbourne, where the origin of this project really came from. So I do have a disclosure in that I'm the founding CEO and stockholder of Synchron, and the devices and procedures demonstrated in this presentation are still classified as investigational by the FDA. Okay, so I'm going to take you through the problem that we're trying to make an impact in with the use of a brain-computer interface, that of paralysis. What an endovascular BCI is, what the neurointerventional procedure looks like, the first-in-human results that are currently under review at a journal, and what the next stage of the clinical study is. Paralysis is a big problem. We work at the early stage of the treatment of paralysis in the treatment of stroke, but once there's been damage to the nervous system, there's typically not been any treatment or therapy for damaged nerves or neurons. And this is a really big problem. It's a big problem due to stroke, due to demyelination conditions like MS and NMO and transverse myelitis and ADEM and CIDP, neurodegeneration diseases like MND and muscular dystrophy, spinal cord injury due to trauma, traumatic brain injury, and even neuromuscular conditions. So there's a whole range of conditions that cause paralysis in our patients. And it's a very big problem. There are 5 million people in the US who have a severe paralysis syndrome. But when you start to consider the application of brain-computer interface, it actually is a larger problem even than that, because the concept of the BCI is that any condition that impairs your body's ability to engage with a computer, and the way that we typically engage with a computer is using our 10 fingers to control a mouse or a keyboard. And so any condition that impairs your ability to control a digital device is therefore treatable with a brain-computer interface. We happen to be starting in the very early stages of our clinical journey in the patient population that can be well defined, that is paralysis. So if you think about how we utilize digital devices to control our lives or to function within our lives, it starts with the intention of control within the motor cortex. And we don't think about this very much, but we know what the motor cortex does, but motor intention derives from the motor cortex. Then the motor neurons carry that intention down from the cortex through the subcortex, the spinal cord, into the periphery, eventually to affect an actuator, or an effector, such as a muscle, to then engage with a digital device to, for example, send your text message to your wife. So the concept with the BCI is that you go straight to the source of the motor intent. You bypass the entire journey of that signal of the message of the motor actuator all the way through to the digital device and create a bypass directly from brain to digital device, thereby offering a solution for any of the number of conditions that exist along that anatomical journey. So BCI is a broad concept for the engagement between an area of brain, and really we mean cortex, to interact with an external device that restores some lost brain function. And the types of brain function that most groups who are working in BCI right now are focused on is in the motor system, but there are other applications as well. And there are examples of all other ranges. But the concept is that you can really think of a BCI like a neuroprosthesis. BCI is synonymous with neuroprosthesis in my mind, in that a neuroprosthesis engages directly with the cortex or central nervous system and restores a lost bodily function, brain function. I think the early work, I'm not going to talk about the work around the Utah array, which was really the cornerstone of brain-computer interface work over the last 20 years. First reported by Lee Hochberg et al. In Nature 2006, in a very exciting piece that I first read in 2008, which utilized the Utah array to control an external robotic limb in a patient with severe stroke. Fast forward to 2016, and this was the first paper that came out in New England Journal, which was demonstration of not a penetrating array that goes directly into the brain, but rather let's just skip that a bit small, move over here. But rather use a surface array to record ECOG, in this case, a subdural array, implanted via craniotomy, but utilizing ECOG to control an external device. This was a really big deal because there have been challenges in translating applications of the Utah array all the way through to FDA approval. And there are very famous examples of groups and companies that are working on that problem right now, invasive needles. There are problems that come with putting needles directly into the brain. If you go onto the surface of the brain, you have a trade-off in the amount of information you can record from the brain, but you have a much more stable system that utilizes signal that can last for a long time for reasons that I'll get into. So this was a big deal. This was a Dutch group led by Nick Ramsey. Van Stiesel was the primary author. This is Nick Ramsey's group, open craniotomy, a 16-channel array, 2 bipolar features, and they utilized low frequency changes that occurred when the patient attempted to open and close her fist. It was a single output, high accuracy. It was very slow, but it was very robust. And for this patient who was ventilator dependent, locked-in syndrome due to ALS, this became her primary form of communication. And it continued to work for years, and it superseded the use of eye tracking because it was not light dependent, didn't require calibration every day, and it just worked. So it was a sign for me that BCI, had a future if you could do a few things, including making it fully implantable, making it safe over a long period of time. But for my mind, the question was, is there a way that we can do this that does not require craniotomy? Fast forward to last year, and I'm not going to spend too much time on this, but for my mind, Eddie Chang right now is probably the preeminent BCI researcher utilizing ECOG at UCSF. A phenomenal, brilliant, and humble person who is not only discovering elements of how the motor system works, but building these incredible machine learning models that can, in this case, utilize word prediction and apply data into an application that enables patients to communicate and attempt to speak. For me, at a high level, this demonstrated that if you can record surface recordings from the top of the brain, you don't need to go with penetrating needle electrodes. You can derive huge amounts of information and data, build models, and create outcomes that demonstrate that BCI has a really bright future, in that the ability to take the data and improve and improve and improve, utilize machine learning. There's going to be this, generational improvement that comes with continued learnings. This is what the Utah array looks like as distinct from a surface electrode, penetrating electrode array. currently under investigation, comes with challenges, really high data rates, massive data outputs, but the real challenges around biocompatibility due to the impedance changes that happen with gliosis over periods of time. But the linchpin of research over a number of years. So the concept that I had 10 years ago was, can we do all this from an endovascular system? Can we build sensors onto the inside of a blood vessel that can live within the body for a lifetime? We know that can happen based upon all the other work we do with stents and coils and other devices that live. But can we bring electronics into neurointervention, essentially? And so the first patent that I wrote in a Starbucks was putting a Utah array onto a stent. We didn't ever end up building that, but 10 years down the line, this is what the Stentrode looks like. It's a self-expanding stent that utilizes all of the properties of nitinol that we know so well, and then builds a second layer of metal. One of the major things that we had to figure out was, how do you manufacture a stent where there are 2 layers of metal? And that required a complete overhaul of manufacturing stents. So here's the concept of the device that's currently under investigation, not the immediate version right now, but stent inside the superior sagittal sinus, splits the left and right cortices in the motor cortex, records surface potentials from what is parasagittal regions, so lower limb representation of homunculus. Device comes down through the venous system out of the jugular vein into a device that sits in the chest. To put all that into, and then we record and we use different types of motor recordings that are representative of attempted types of movements. And they're spatially represented, they're distinguishable, they're classifiable, and then we convert those into individual discrete outputs that form the basis of switches or clicks that can drive systems over Bluetooth. So putting that all together, device inside a blood vessel, electrodes on a stent, self-expanded, connected to a lead, running out of the venous network, out of the brain, without any craniotomy requirement. Okay, so we're 10 minutes in. So I'm going to spend about 10 minutes talking through the neurointerventional procedure that we have developed, primarily with Peter Mitchell as the primary principal investigator based in Melbourne, Australia, who has conducted the first 4 procedures in Australia. Talk about pre-implant planning, co-registration, accessing the sinus, deploying, and then the transmission unit. So we are in the venous system. We're utilizing the superior sagittal sinus. So the trajectory is up through the jugular vein, transverse sinus, superior sagittal sinus. Patients have MRIs, both structural MR venogram and then functional MRI, to identify where the motor cortex is, where the precentral gyrus is, M1, in relation to the venous network. And then we take that information from the MR into the angio suite, do a spin in the angio suite when the patients first come in, make sure their heads don't move, had them under a GA, and then access the venous network. We are doing arterial access as well for angiography, but that's primarily to get the venous phase, because the mapping of the cortical veins is very important, because you really have to know where you are. And you do the co-registration, and if that works, great, beautiful. But the identification of local cortical venous anatomy and then a lot of studying of that before you do the procedure is very important to make sure that you are absolutely in the right spot. So we're entering into a phase of functional localization during neurointervention. So we get into the, so basically access using a microwire microcatheter into the superior sagittal sinus, then delivering a 6 French sheath into these target locations, preparing for the delivery of the Stentrode. And then this is, the Stentrode is prepared or loaded inside a 4 French catheter. So the Stentrode comes preloaded in a 4 French catheter. You bring that up in the 6 French, and then you pull back the 6 French with your eyes on the markers and unsheath the device in it. It feels a lot like a Stentreva delivery. We've got a radial force that's around Stentrevas, basically. Once it's in place, you then do a run to make sure that the vessels are open. You can see the device. I'm sitting in there, and here is a spin of so you can see the lead coming out through the transverse sinus, superior sagittal sinus. You can't see the device very well, but it's open up there. But then this is a reconstructed dyno demonstrating the opened up device inside the target location. Okay, so then you've got your lead coming out of the jugular vein, and you then have to create a pocket, do a tunnel from the access point in the jugular vein, just above the just in the sternocleidomastoid insertion, a small tunneling down to the infraclavicular region, and we put in what we're calling the implanted receiver transmitter unit, and then we do a check of the data flowing in the angiography suite to make sure we have ECOG running. And that's what the IRTU looks like here on the X-ray post-implant. So, the same location for a cardiac pacemaker with a lead going up into the brain through the venous network. Patients are on dual antiplatelet therapy for 3 months and then single agent aspirin for at least 12 months. That was based upon, what we do for transversinous stenting for IIH. Okay, so we've conducted a first-in-human study. That study is closed. It's currently under review with a journal. We have published some very early results. They were published in JNIS, just the first very early results. But we now have longer-term safety data, and we've moved on to a second stage of the clinical study, which I'll present in a minute. And so here's a reconstruction of many things. The pre-MR structure with the fMRI labeling of activation, with the MRV reconstruction, with the post-CT, they can't have an MR after the device is in, with the post-CT for electrode localization, showing where we've been able to land. And there has been a tendency for the device to slip back just a few millimeters back to over sensory cortex. So, there are lots of learnings happening over the delivery of the system, getting it right over the primary motor cortex, but we're getting deliveries within an error of 5 millimeters and getting better and better every time. The FDA wanted us to look at primary outcomes that are device-related SAEs, resulting in deaths or permanent disability. In other words, stroke. We've not had any of those events. And then secondary safety endpoints FDA were very interested in were device migration, thrombosis, and vessel occlusion. So to look at that, we did CT venography at 3 months and 12 months. There's been zero migration and there's been zero vessel occlusion. There's been zero thrombus formation with very high quality CT venograms, all patients taking their antiplatelet agents. There have been no thrombotic events. There have been some non-serious events. Headache has happened in about half of the patients for a couple of weeks, simple analgesia. Similar headache to what is happening with transverse sinus stenting. It's probably due to some dural irritation, which resolves after a couple of weeks. And there's bruising at the neck site. We're holding pressure to close the venous access and the jugular vein. The patients are on aspirin and clopidogrel, and we use heparin for the procedure. So triple therapy, not surprising to be having some bruising, post-op bruising around the neck. Here's an example of one of our patients with the device. There's the sagittal view of the baseline and then 3 months and 12 months showing there's no movement of the device. This is just to make the point. This is a paper that, this is actually from an animal work. This is not human data, but I just wanted to show, this is the data we presented to the FDA to mount the argument for why we do 90 days of dual antiplatelet therapy. The image here, so this is an animal model with the device implanted at baseline, and then here the device after 45 days. And what we demonstrated in this preclinical study was that 95% of the device becomes endothelialized within 45 days, possibly sooner. We didn't have time points between the two, so there's still some uncertainty around how quickly the endothelialization happens. But this is the justification for so we've gone conservative. Once the device is covered, the risk of thrombosis is reduced substantially. And so this was evidence that 90 days should be sufficient and possibly, quite conservative. It might be that 6 weeks is going to be enough, but we're right now running with 90 days. So then the way the system works and what we're doing in the study was we have the patients attempt to make movements of certain parts of their body. And we're in the parasagittal region, so lower limb representation. So we usually start with ankle, different types of ankle movements or lower limb movements that generates change in NECOG signal that we can threshold, extract, classify, and turn into a clear output. So, in the end, it becomes basically like a transistor, a 1 or a 0 for a certain type of movement in the body. And we then turn that into a click or a switch, and we send that switch or click over Bluetooth and have the patient control anything over Bluetooth. And we're building out clinical studies now to figure out the best way to utilize that type of control for systems that have a clinically meaningful outcome for the patients who are paralyzed. Importantly, signal stability was something that we've looked at very closely. And we have demonstrated out to 12 months in our first 4 patients that signal stability is statistically stable. And, over time, there are certain correct character minute varies from around 10 up to 30 in terms of typing speed, selection accuracy. We have set thresholding. It has to be accurate, otherwise it's not useful. So we've set high accuracies and, work towards that. And, working out towards multiple switch decoding. And the question for BCI from the way that we're going about this is, how many of these switches can you start to get out? And so, our data science challenge is to build software systems that enable the patient to get better and better at using these systems. But for a minimal viable product, for a minimal viable outcome, what can we have patients with just a low number of switches do? And so using things like your iPhone or Microsoft tablets with a low number of switches is very meaningful. So we use gamification to help the patients get better and better at the utilization of these switches. And then we apply these into use cases, sometimes in multimodal applications, but we're moving away from eye tracking now. But initially we started with the combination of eye tracking to get the cursor around the screen, and then the use of different switches to say left click, right click, zoom click. And probably the most powerful application immediately, this was our patient number 1 in Australia with a very sophisticated setup of books to hold up his tablet with a complicated system, was to use WhatsApp. And so, the navigation of using clicks around like the keyboard, think about, getting around a keyboard to change your Netflix password using your smart TV controller. That's kind of the target that we have for the first application. So once you're onto the keyboard in this space, you open up WhatsApp, you can type, you suddenly are able to text message. And for this patient who had ALS or MND, who had lost the ability to text message, this was a hugely meaningful moment in his life where he was going in one direction due to the ALS of a reducing of his ability to live independently in the world to suddenly getting back control over his digital ecosystem. So that's what BCI is really about, from my mind, is re-enabling your access into the digital ecosystem that we all take for granted now, but which you lose if you have conditions that stop your ability to type. So here's another one of our patients. He's also navigating his way through the keyboard, and he's sending a text message to his wife, who is in another room, who typically would have to be coming and regularly checking on him to see if anything was needed. And is this running? Yes, it's a bit slow. And then she is doing what she needs to do. Maybe she's out of the house, maybe she's somewhere else, but they are now in communication digitally, which was not possible beforehand. Smart system at home. So I think you get the idea here, like these Bluetooth control systems can use any sorts of things. So starting to wrap up now, what's next is we have approval from the FDA to continue. We have our first patient enrolled in New York. Pittsburgh has just opened as a site, UPMC, with Raul Magira. Sharam Majidi was an interventionist who performed the first patient in New York. We have a total of 6 patients to be enrolled in our early feasibility study and another 10 in the Switch 2 study in Australia, which are very similar studies. Again, we're looking at safety outcomes, but we're starting to get, and I don't have all of the pre-specified outcomes here, but we've worked very hard to, I think the real challenge for BCI is what are the outcomes, what does efficacy really look like? And what does efficacy look like in a way that Medicare is going to pay for these devices for our patients? And so, the diary is one of them, but I haven't listed them all here because it's still a work in progress. But I would consider this command study as a efficacy finding study as we begin to explore the use of the BCI to control digital systems that improve functional independence in a way that moves the needle on health outcomes. So the patient has to be between 21 and 75, severe paralysis in both arms and legs, English speaking, local to Pittsburgh and New York, accessibility to a caregiver, unable to perform finger tapping tests to a certain degree. In regard to certain conditions, for spinal cord injury, we're looking for high cervical, ventilator dependent is fine. For basilar stroke, so we need preserved cortical activity. Speech is not an inclusion or exclusion criteria. It's more about whether your hands are working or not. Multiple sclerosis needs to be fully progressed, resulting in severe paralysis, and muscular dystrophy or other conditions that we're looking to enroll in. So just to leave you, this was the moment our first patient was able to actually write out a sentence. Now he went on to then, use this on WhatsApp. So at this point, his wife still didn't fully get what had happened here, but this was the moment he wrote the first sentence. And just the joy on the two of their faces after this gentleman having progressed through his life with ALS and losing his ability, it was just a moment where the world opened back up for them. And I think that's the power of BCI. That's why I'm so excited about where BCI is going. And this is a completely new world for neurointervention. And, for my mind, neurointervention is the solution for BCI. The problem with BCI has been the safety, long-term safety and commercial translation that comes with craniotomy and all the challenges. And there will be other versions, but neurointervention has now moved to the forefront as the solution for BCI. And I think it's going to be a very exciting time as this technology rolls out over the next 3 to 5 years and offers new hope for our patients. So thank you very much. And I hope to, be available if there are any questions, or if we're gearing up towards the pivotal study over the next couple of years. You can reach out to me via email. My email is toxley@synchron.com. We'd love to hear from you. Thank you very much.
Thank you so much, Tom. Are you here with us? Could you hear us?
Hi.
Thank you so much for joining. Again, fantastic work. I mean, it's so obviously life-changing. And any question here in the audience?
Hey, thanks for this enlightening lecture. This could be a basic question, but I'm curious, why did you guys decide to go with a superior sagittal sinus versus, for example, an arterial vessel? You're away from the motor cortex. So I'm curious about the location. And if there's a subdural down the line or atrophy, would that probably make the cortex further away from that stand? So do you have to have a new stand there? Like, is one stand enough to cover the whole brain? Just honest your thoughts.
Yeah, I mean, the arterial system is compelling. I mean, the activity that we want to record in the cortex is in, the neocortex. So arterial vessels in the neocortex near the M1 region of motor cortex, that's very hard to get to. I mean, you're talking about distal MCA branches, and there's not much margin for error with any clot formation in any MCA branch, really. There are some external carotid branches, but they're not always near the M1 region. So the venous, network is what gives access to superficial neocortex. And yes, more coverage is better than less. There are huge technical challenges in delivering large channel counts into blood vessels that can exist safely. So there's a trade-off in how much coverage you can get in a first generation system, with constraints around the hardware system that we've had to build. So it was a, compromise across all things, hardware, software, and neuroscience and an algorithm that had to be made to get the right balance for the first generation system. But we know we're just at the beginning.
Thank you.
Do you require any antiplatelets chronically for these, or what are the recommendations?
Yeah, we've we basically looked at the literature on transverse sinus stenting for pseudotumor cerebri or IIH. So it's dual antiplatelets, aspirin and clopidogrel for 3 months, and then single agent aspirin for 12 months.
Tom, this is Tudor Jovin. You probably would. It's
Hi, Tudor.
Expected to see me here or hear from me here, but I'm also visiting. So I'm always fascinated by your lecture and what you're doing. It's incredibly cutting edge, and I think of great potential. Can you tell us where do you see this technology be applied in 10 years? What will Nima and Ricardo and Eric do here at Baptist in 10 years when everything is FDA approved? What kind of applications are we talking about?
10 years is not that long away for a class 3 medical device. So I think on a 5-year horizon, we have completed a pivotal study and we're looking at FDA approval. On a 10-year horizon, we're looking at getting this technology out to centers. So I think, I think what's more interesting is a 20-year horizon where this technology becomes, I think the possibility that this technology outpaces volume of stroke is substantial, given the size of the problem and the availability of elective cases for our neurointerventional community. I think this is going to become a very large elective component of our practice over a 15 to 20-year horizon. I think BCI commences in the domain of motor cortex for the treatment of paralysis, but I think there are going to be huge breakthroughs coming in areas that traditionally have required craniotomy. So deep brain stimulation therapies for movement disorders, responsive stimulation for epilepsy, sensing for epilepsy. I think, I have a view around a range of areas, depression, that are going to open up in the same way that in cardiology, cardiothoracics, developed solutions that could be delivered from an endovascular point of view. I think the same thing might happen where our patients can avoid craniotomy and we figure out ways to either sense or stimulate regions of brain from blood vessels.
Right. So you think that functional neurosurgery is going endovascular, and the time frame for that is 20 years, not 10?
I think.
Sorry.
Well, I don't know what others are going to do. I think what we're going to do is, it's really hard to build a technology platform that has the mechanical component of endovascular, the electronics and communication protocols of telemetry, the analytics AI components of data analysis, the software components of app control. I think all of these things had to come together. And so I think we are going to be really focused on this first application. But once we have this platform approved, then I have a vision of spreading out to a range of different applications. But I think, it's going to be on a 10-year horizon before we start to move into the other domains. But we have a patent portfolio that are going to open up these different areas. But we've got to be focused before, we've got to learn to walk before we can run. But I do think that neurointerventional electrophysiology is going to be a very large discipline. I think it's going to grow a lot.
Thank you so much.
I would like to introduce Dr. Nima, who's going to introduce the winner for this year's Innovators in Cerebrovascular Science Award.
Thank you. First of all, thank you for everyone who still stays and for an exciting day we had. And I also want to thank Ricardo and Eric, my partner, and a great team that we have at Baptist. It really allows us to do what we do. Every year we have during conference, we do give an award. And this year the award is special because we are lucky to have someone with us who is world-renowned neurointerventionalist. Not only that, he's actually one of the first interventional neurologists in the nation, and he is involved in multiple trials. For example, Revascat and Dawn, which were one of the earlier trials who actually took off thrombectomy, and he's a visionary. Remember, we were discussing Dawn. And when we're discussing Dawn, as you know, Dawn expanded thrombectomy to 24 hours. Thrombectomy hadn't even become a standard of care yet. So, but obviously the vision was there that, we don't need to restrict the time. However, what I really like about the person who's getting the award is not only he's humble, but he's a great physician and he really cares for his patients. But for me, it's personal. So I met him as a fourth-year medical student, and I told him that this is what I want to do. And there are few people in people's life that you can say are responsible for where you are. For me, Tutor Joven is responsible for where I am. So with that, I want to thank him for being here and his contribution to the cerebrovascular disease through different trials, not only directly, but also indirectly with all the hard work that he's done. So Tutor, if you could step here, please.
Thank you, Nima. I'm honored and humbled, and thank you for your very nice introduction. And there is nothing. This is one of the biggest satisfactions, if not the biggest. There's a lot of things that make us fulfilled in our careers, but seeing your former mentors thriving, doing so well, and being successful is really one of the highlights of one's career. I want to congratulate you all. I know what incredible work you're all doing here. It's a model for the country. It's a well-oiled machine and a center where there's perfect harmony between neurology and neurosurgery and other specialties, and that counts a lot. And it's something that you guys should appreciate here because it doesn't happen everywhere. And congratulations again for a great conference, and thank you again. I'm very humbled, and now I understand why you insisted that I show up at 5 o'clock. All right, so thank you.
What is next? So we have 10-minute break, and then we have our EMS symposium. Everybody's invited to join, and after EMS symposium, we'll rest. Thank you, everybody. Until tomorrow. Yeah. 10-minute break.
left arm. Left arm.
Can you guys hear me? All right. So thank you for being here. We're lucky to have our EMS crew here and have a small session on EMS, although EMS is a very big part of what we do. There are cocktails and food outside, so feel free to start. Let me get the clicker. Do I have to stand there to go forward? All right. So the purpose of this is really just to talk about some of the cases. I did want to talk briefly about, as everybody knows, thrombectomy when it comes to stroke care is a standard of care up to 24 hours. But the importance of that is EMS plays a very important role in acute stroke therapy. Why? Because they're the first medical contact for most acute stroke. They have to recognize severity scale. They can start treatment, appropriate triage. So there's a lot going on. And just highlight the importance of EMS. Actually, I just learned that you guys know what's the percentage of, so EMS obviously sees a lot of patients. What's the percentage of stroke that they see? I just learned that it's only 2%. So they have a lot of things going on, but stroke is one of the important part. And when it comes to stroke, time obviously is very important. So what does that mean? You have to find the stroke, recognize, take him to the right place, and start treatment as fast as possible. This is our circle. We're at Baptist. We also cover Southeast Georgia and Flagler. And for the purpose of this, I wanted to present to you guys our most recent Baptist time metrics. I like to look at the time data. So what I did, just went back, thanks to Wendy and the team, just look back over the last 1 year. So from August to August, how do we do at Baptist? Well, the dark blue is ours. So door to CT median is 15 minutes, but more importantly, door to needle is 31 minutes. So over the last 1 year, if you come to Baptist, within 31 minute median time, you're gonna get TPA, which is I would say is a great time. American Heart is a lighter column, which is the recommendation is less than 60 minutes. So obviously we're far below that. Door to puncture, as you can see, our median time is 41 minutes. So within 41 minutes, we can go from the door to getting the groin access to do thrombectomy. The other thing I wanted to highlight is the numbers. So our numbers have grown. The quality hasn't decreased, but we are able to accommodate. So if you look at 2016, for example, 2017, up to 2022, these are all in 1 year. And actually, I told Ricardo the incorrect number. The correct number of last 1 year that thrombectomies that we've done is 253, which is a large number of thrombectomies that we do. So that goes to the team, the great team that we have, who is able to allow us to do what we do. The total strokes that we see within Baptist is 3,556. So we obviously see a lot of strokes. And downtown alone, we see 1,613. The other important thing that we're involved with is Northeast Florida Stroke Coalition, which really allows us to collaborate with other hospital systems to better improve the care of our patients. Really, if we can collaborate, we can improve the care. And again, at the end of the day, it's about the patient. And I think with this collaboration, we're able to achieve that goal. So just a quick couple of cases. This is something that you guys have seen. 88-year-old comes with high NIH, LAMS of 5, has a occlusion. We go in, open up the occlusion, you see the clot. This is, this can take about 15 minutes to get this done. Thankfully, now we have great technology, but the challenge is obviously get the patient triage. That's the challenging part. but what does this mean? What is this pictures of these clots that we sent? Anybody who knows me knows that I like collect the pictures of clot. But what does that mean? What does that mean to really to the patient? Can you show the video, please? Hold on one second. Can you pause it? Yeah, good. So this is just I wanted to show you the video of what goes on. And for you guys, when the patient comes to the hospital with stroke, the important thing is obviously figure out what kind of stroke it is. And if there's a large vessel occlusion, get the patient to the angio suite to be able to do the picture that I just showed you. What does that mean for the patient? So here's a patient. Sorry about the quality or anything. This is not staged. This is an actual patient. Don't worry, she did give me consent. But this is actual patient. Obviously, it was during COVID. This is the angio suite. Anesthesia is over here working in parallel. We're not waiting for anesthesia. They're getting their lines, everything ready. We're over here setting this up to do that procedure. So you can see that she presented, and notice the time, 9:26 a.m. on that day. NIH of 14. So high NIH, lambs of 5. Play, please.
Okay. Open your eyes wide as you can. Good, good. Okay. Lift up your left arm. Left arm. Can you lift up your left arm? Okay. Lift up your right arm, dear. Good, good. Is our left arm not moving?
No.
Okay, I'm going to lift it up for you, okay?
Okay.
Hold it up. Hold it up. Okay. All right. And then.
And I think the importance of this for, for us is, now look, this patient is paralyzed. We just had to talk about paralyzed and regaining, being able to do stuff through the stents, through the wire. This patient is paralyzed. So this patient can no longer walk or take care of herself because one side of her body is paralyzed. Play.
Lift this leg up, dear.
Lift your left leg up, sweetie. Hold it up there.
Hold it up. Okay, lift up this leg. The right leg.
Hold it up there. Keep it up
Good,
there.
good.
Keep it up.
Okay. All right.
So pause. So here you can see that the right M1 is occluded. Play. So we went through there here. I used the stent retriever connected to the wire. The clot is right here. So we were able to remove the clot. So you can see now the flow is back.
Okay. Open your eyes wide as you can. Good. Look all the way to your right. Look all the way to your left. Good, good. Now what I want you to do is I want you to lift up your arms, okay? Both arms. Good, good. Now left arm, bring it up a little higher. Now both of them. Good. Now hold them like that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. That's great. Open and close your hands.
So this is right after the procedure. So you can see she went from the table to be transferred out. And now she's able to move her left side. Play.
Good, good. You can put your arms down. Great job. Now lift up your left leg. Bring it up, bring it up, bring it up, bring it up. Bring it up, bring it up, bring it up. Perfect. The other one. Good, good. Okay, doing better.
Very good. Look all the way on that
Again,
way.
the same day.
And all the way this way. That's perfect. You can relax there. Lift your arm up here. Like you're catching raindrops.
Put both arms there. Yeah, like you're holding something.
Like
a big push-up.
There you go. Maybe, if you can. Like you're holding a big box. There we go. Close your eyes. Hit the neck. 9, 8, 7, 6, 5, 4, 3, 2. Good. Touch your nose with this finger. And the other side also. Very good. All right. Don't lift this leg. Just wiggle your toes here. Good. Now lift your left leg up. Keep it up for 5. Okay. 1, 2, 3, 4, 5.
Perfect. So I just wanted to highlight, so what are your hard work of bringing the patient to the right place, all this stroke talk, middle of the night, calls. At the end of the day, it's about the patient, and that's what that means. That means that for this patient, she went from a disabled condition, no longer can take care of her life, to she was obviously able to recover, and she went home. So with that, I wanted to turn the microphone to Dr. Elias. I had a few things that talk, and thanks again for being here, and appreciate your hard work. I'm gonna have to go back to that.
Sorry, I kind of need to use the slide, a little bit of a prompt. Is this, this mic on? Okay, I know the 5:30 time slot's usually not the premier time spot, and especially the 5:30 time spot in front of the cocktails and shrimp is definitely not the prime spot. So I'll cut this down to about 2 hours, so we'll be good. So, all right, again, I'm Dr. Brad Elias. I'm the medical director of Jacksonville Fire Rescue. I've had the honor and privilege of being the medical director really since 2014. At that time, it was actually a part-time position, 2 days a week. In 2019, City Hall made this a full-time position, and you'll probably see why coming up. We're quite busy, and we're one of the larger fire departments in the country. So real quick, not only am I a board-certified EMS physician, I am a board-certified ER physician. I actually work for the Emergency Resource Group, which is the ER group based out of Baptist. So actually, I do work clinically with the NEMA and Dr. Hannell and the great stroke team. So I have that perspective as well. And additionally, the medical director of Life Flight, which is an EMS helicopter based out of Baptist South. The fire department, obviously, our vision is talking about improving quality and serving the needs of the citizens of Jacksonville. And just like any major fire department, our mission is to preserve and protect lives, property, and the environment. So a little bit about JFRD. We're like I said, we're fairly sizable. We're one of the larger metropolitan fire departments in the country. Our annual budget is almost $280 million that comes through City Hall and then the mayor's office. We have 1,800 personnel, of which 1,600 are firefighters, and of that group, probably over 900 paramedics. So we're fairly sizable in that regard. We have 62 fire stations. We happen to be the largest all ALS fire department in the country. So that means that every apparatus, whether it's an engine, a ladder, a fireboat, has a paramedic on that apparatus and is capable of performing ALS interventions. You see, we have 59 rescues next month. That will go up to 61. We're adding 2 new trucks. Those trucks actually will be enhanced capability or critical care paramedic type units, kind of with the adding paralytics, vent capability, and the ability to initiate blood transfusion on scene. So something exciting we're working on right now. The service area is again, one of the largest in the country, over 918 square miles. Jacksonville has a population of approximately 1 million, which probably flexes to 1.2 million during the day with commuters. And again, just like any major metropolitan fire department, we have all the subspecialty disciplines, obviously fire rescue, EMS, hazmat, urban search and rescue, technical rescue, aircraft rescue, and all the others. Like I said, we are busy, and the mayor and his administration has recognized that, and we've, over his time, we've undergone a significant expansion in apparatus, personnel, and fire stations, and this is why. Our calls for service last year were 171,000, with approximately 147,000 EMS-related calls, and we transported over 91,000 people to the hospitals last year. You can see kind of a general trend that's an upward trend. COVID probably resulted in a continued increase in that. We did not see any kind of decrease during COVID, that was for sure. Putting this into a national perspective, we rank 12th or 13th in the nation in terms of busyness, number of calls. So again, back to the point, we're one of the larger fire departments in the country, and so we're pretty busy. And as we'll see here, stroke, at least by the nature of the call, stroke is only about 1.2%. You see our top numbers. Sick person is kind of a generic catch-all, where people don't really fall into a category, but chest pain, accidents, breathing problems are major ones. But if you also look on this list, you'll see a number of neurologic conditions, obviously altered level of consciousness, seizure, headache, back pain, and then stroke too. So, in terms of neurologic emergencies, we do quite a bit of that. And obviously an altered level of consciousness could definitely turn into a stroke, as same with a headache and such like that. So that's the calls as dispatched. When it comes to actually stroke alerts, right now, as of last year, we had 1.6% of all transports were stroke alerts. And you see that number has progressively gotten higher, and kind of, I'll explain that a little bit in some later slides. When I first took over the medical direction in 2014, only 0.7% of the transports were stroke alerts. We've more than doubled that. That's probably multifactorial, but clearly there's an emphasis on stroke recognition and bringing stroke patients to the right place. So where are we taking our stroke patients? We're very fortunate here in Jacksonville to be stroke center rich. Within the city limits, essentially we have 4 comprehensive stroke centers and 5 primary stroke centers, plus another 6 stroke center primary in Clay County, which we actually go to on occasion. So you see the top 4 percentage-wise, those are all comprehensive stroke centers. So we lean very heavily on the comprehensive stroke centers. This is a kind of a look back of over the last 5 years. For the most part, again, we see a predominance that we rely heavily on the comprehensive stroke centers. There has been a fairly significant uptick in the last year or so to all of the comprehensive stroke centers. We also have standalone EDs in the community, which we will not bring stroke alerts to. This is actually just a graphic again of that kind of rise and a fairly significant jump up in patients being transported to the comprehensive stroke centers. You see that the primary stroke center numbers really remain constant there around that kind of 200 range, but over 1,200 strokes last year brought to comprehensive stroke centers. If you kind of break this down again, kind of numerically, Baptist on average probably getting around 50 stroke alerts a month. Mayo gets around 30, and so does in UF, also kind of our top 3 in terms of stroke alert volume. We're now averaging, even to this point this year, 146 stroke alerts a month. So we are bringing patients to these stroke centers. Where a lot of this changed is we had a protocol change in November of 20. So previous to that, we were averaging around 71 strokes a month. That was when we really changed the stroke assessment from fast to be fast. And there's another piece too that also changed. And so as a result, we're seeing progressively increasing number of stroke alerts and also increasing number of transports of stroke alerts to the comprehensives. I apologize, this slide really doesn't come out too well. But so prior to 2020, we were performing the FAST, basically the Cincinnati Stroke Scale. I always had a favor of the Cincinnati Stroke Scale. I went to residency at UC, and so I was there in the late 90s with the whole stroke team. And so I've always been kind of a fan of the Cincinnati Stroke Scale. But then we did stroke to identify a stroke was the Cincinnati, and then to identify the severity was the Lambs. So we made a change in November of 20. So we went from fast to be fast. And then that was, kind of a collaborative effort. We'd talked to a number of the stroke centers, obviously Baptist included. And, there was a concern that we were missing these posterior, circulation strokes. And so that we wanted to add that BE to the fast. And hence that came of the transition from fast to be fast. We also, around that time, there was some talk, there were discussions down in South Florida, they were no longer going to primary stroke centers. They were, going to purely go to comprehensive stroke centers. And I didn't feel, at least in Jacksonville, that was necessarily the right thing to do. I didn't want to take out the primary stroke centers completely. But one of the kind of hybrid approaches that I took was changing. We, continue to do LAMs, although historically LAMs 4s and 5s have been considered the LVOs or suspected LVOs. I added 3, 4, and 5. So we kind of broaden that LAMs category. And so the combination of BFAST and 3, 4, and 5 LAMs probably explains that fairly marked jump in the comprehensives. Actually, I'm sorry, just to go back to the stroke scales. So, remember we're big, right? So we said 1,600 personnel, 900 paramedics. For us to change things is tough. And I know there's always kind of a concept out there, is LAMS the best severity scale and what have you. There's RACE, and I know there's a couple others. For us to make changes, it's a big undertaking. And so we always have to kind of weigh the effort. Is the effort worth what we're going to get out of that? I currently feel, that the LAMS, the BFAST and LAMS is getting us where we need to be. We're not missing significant strokes. If another stroke scale comes along that shows markedly improved accuracy compared to LAMS, we'll consider it. But to basically change, I've seen some statistics where, RACE might be points higher in terms of accuracy. That's not going to be worth the effort for us to train 1,600 personnel. So that's kind of where we stand today. But again, part of the collaboration is all the hospital systems in Jacksonville work with us. And, we have our own training academy, and then we're even running training out of headquarters now as well. But all the hospitals offer on a fairly regular basis the ability to, hey, can we come to your station? Can you bring guys to our hospital? And we'd love to teach you stroke and show case reports and things like that. So we do have this good collaboration. So we have this force multiplier for training with all the hospital systems out there. And everybody wants to kind of, show their wares and show their success stories and all that. And again, as a community, we're trying to raise the bar for everybody. So some demographics about the strokes by age over the past 5 years, really not much has changed. Kind of typical bell curve as one would expect. This was a little interesting. So we looked at, in terms of race. And so if you look at the census data, African Americans typically comprise about 31% of the city of Jacksonville. So for them to have higher levels of strokes probably does at least show some implication of some healthcare disparity, since they're more unfortunately more represented in stroke alerts than what their actual population is. This was interesting too. We looked at gender, and this is repeatedly over the past 5 years. Unfortunately, women have more stroke alerts than men. And one would have thought this would have kind of normalized, over 5 years or something like that. But every year we see this trend. So somewhat interesting. Actually, I also need to give credit to Lieutenant Mark Rowley. He's one of our data experts, and he did a lot of this data. So I have to thank him. But this is a pretty interesting map too. Looks at all the stroke alerts. And so we were able to kind of GPS locate where they are. We also overlaid the comprehensive stroke centers, and we see that again, we're very fortunate to have multiple stroke centers and somewhat spread out geographic, and typically that's how our transport referral patterns go. Is typically we're not really bypassing one stroke center to get to the next in terms of the comprehensives. We are very clear in going, going past a primary stroke center to get to a comprehensive, especially when it's warranted. So a couple other additional considerations. Stroke care begins at the time people call 911 dispatch. So we have a computer-aided dispatch, the CAD, our 911 dispatchers are asking questions. So we're already trying to assess the nature of the call. Is that person having a stroke? And based on this CAD program, we're able to identify at least a suspicion that the nature of the call could be a stroke. And so then this gives the responding crews heads up information. So, whether it's, hey, I'm going to a stroke, and so let me refresh what BFAST is and what LAMS is. So, let me look at that. Let me know where I'm going and relative to the locations of the primary and comprehensive stroke centers once that decision's made. Pre-hospital communications. We have actually JFRD and Baptist did partner with this pre-notification trial. And so, we learned that by giving the LAMS and the onset time ahead of time to the ER, that the pre-alert notifications would go out to the stroke team, and that ultimately resulted in greater efficiency and better workflow. Working with our HIPAA compliance officer as well as the city legal, we've also learned that we can give the patient's name, date of birth, and the LAMS over the radio. We use encrypted radios, but that information can be broadcast to help facilitate pre-registration, and again, with an effort to try to improve that workflow and efficiency. Just as Dr. Nima mentioned, we are starting to develop this regional stroke dashboard and have this Northeast Florida regional stroke coalition across the state. Florida state, there's a Florida Stroke Registry, and so we've been asked to participate regionally as well. Some of these other regions have been quite aggressive and been in place for a couple of years, and there's some significant benefit to that collaboration. Orlando, South Florida, Tampa, they're all on board with this, and we're getting together. We're kind of in the infancy stage of that, but all the different health systems are participating. EMS is at the table. So ideally, this is a safe space to exchange best practices and share updates, as well as have journal club type discussions and things like that. Ideally, at some point there will be some blinded data that is shared amongst the hospital providers based on a number of the stroke metrics, and that's intended for the EMS medical directors to understand the various hospitals' performance. Telemedicine, another kind of interesting topic in relation to EMS. It's been tried here in Jacksonville, actually, some other agencies, not us, partnered with the health system. The benefit really wasn't there for us, that we could see. Again, in the city of Jacksonville, we're very fortunate to have such significant stroke resources that this benefit really didn't play out here locally. But I do think there is a role for telemedicine, particularly in the rural environment, to have that ER physician or that neurologist perform a stroke assessment on a patient in the back of a rescue unit that has triage implications. Does that patient need a primary stroke center? Do they need a comprehensive? Do we need to call for an air ambulance? So I think that telemedicine is something to consider in the future with EMS. I just think it's not really has a place, at least right now, a place in an urban metropolitan environment. I also think the mobile CT scan kind of falls in that same category for me. We were approached a couple of years ago to trial it. We couldn't, there were some logistic hurdles that we couldn't overcome. But again, I think for our surrounding counties, St. John's to the south, Clay County to the west, Nassau to the north, those I think might be better suited. They have a significant drive time to be able to get a scan and TPA sooner might benefit. I don't see how it would work here in Jacksonville, but I do think there's value in it. But always a challenge. If you put it more rural, how often does it get utilized? Versus you put it in a place, where we're doing 150 stroke alerts a month. So, that's the challenge. We just ran into kind of operational issues in the very early pre-planning stages of staffing. So which hospital system's providing the radiology? Who's providing the neurology consult? Which hospital now do you have to go to? You know, and it's just, at least at that time, it was just one unit. And so, you know, where do you put that unit? And so that just became too much of a challenge for us. And at the end of the day, we're very fortunate again. We've got 4 strong comprehensive stroke centers scattered throughout the city. Would you rather be brought right to a comprehensive or have this? And that's up for debate. I understand that. But I think for us, Jacksonville Fire Rescue, this wasn't for us right now. That's basically all I got. Hopefully I wasn't too fast, but I understand the timing, so.
I might use this one. I don't know. You guys can probably hear me, right? Everybody? So we have
Hello. Thank you, Nima and Wendy and the team for organizing this, and thank you guys for being here. We know it's a late afternoon. I think from 2014 to now, we came a long way. And thank you both for pointing that out. We're on the verge of throwing a monkey wrench in all the processes, what we do. We are installing now the software that we need in our angio machines. Like you see a STEMI, this patient doesn't get a CTA to prove that there is a coronary occlusion before it goes to get a balloon angioplasty and a stent. This is going to be an interesting process that we're going to run on an 8 to 5 in a working day when everybody's there, all hands on deck, because it's demanding and potentially it's up for discussion. We're going to be talking about that tomorrow, but we invest as an emergency room system. Every time somebody hits the ER coming with pre-notification, saw the numbers that Nima showed, you're investing 30 minutes of that time, whatever, 11 minutes to get your CT, but 30 minutes of the time is imaging, that we're doing a CT, CTA, CTP. What if we don't do that? So time is so critical in this business. So we're about to start that. And you guys are on the epicenter of that, because this pre-notification is sent. There's no way we can get a patient enrolled on this study to see if we go straight to the cath lab or go through the regular process. Without you guys involved, that is impossible. So you're in the center of that, because we need to find the family, get consent, and we're going to be having electronic consent for that. So we're counting on you again to help us move the needle again to try to show. And again, we know this is going to be interesting. Let me put it like that. To get all the systems prime for that, and it's going to be a low number of patients that we're going to be able to enroll because of all the complexity of that. But Dr. Jovin is here, direct to. I want a tutor to say something because I know he's a big believer on that. So what do you think, tutor? Take a patient straight to the cath lab.
I'm glad that the EMS folks are here because stroke is moving in the pre-hospital arena. It's very clear, and they're going to be more and more at the forefront of stroke. And with decision making and treatments, and that this ties very well into the whole story. Just like you know, the ST elevation segment tells you guys that patient needs to go directly to the cath lab. Cardiologists don't do a CTA of the coronaries. They could do it just like we do a CTA of the brain, but they don't do it. Why? Because they know that that takes us a lot of time. And our ST segment elevation, you were talking about FAST and VFAST. That's the NIH stroke scale score. That's our ST segment elevation. It's just a matter of probability of having a large vessel occlusion. If you have an NIH stroke scale score of 10 or greater, your likelihood of having a large vessel occlusion, we're not even talking about medium vessel occlusions, right, is about 80%. Well, you know what? In cardiology, the cardiologists, if you ask them what is their rate of going to the cath lab and finding open coronary arteries in ST elevation MI, is about 15%. So it's the same story. And basically the big difference is that if you go to your cardiologist here at your hospital and ask them what's your door to balloon time. Door to balloon time means reperfusion time, right? We're not even to door to puncture time. That's usually 30 minutes at large volume centers. And where we are, we're lucky, we're good, we're doing well if our door to reperfusion time is 90 minutes. And all this, there's no other source of delay that is longer than imaging. So we need to move past this imaging because, on the other hand, why do we do imaging? Well, one is it's all convenience, basically. One is to diagnose a large vessel occlusion, which we could accept a 15% open vessels rate and just go directly, because the 85% who actually are going to have an occlusion are going to be treated 30 minutes faster. And if you actually even do the math in terms of cost, you're going to come out ahead. And the other reason why we do imaging is to rule out a large infarct, which in the first 6 hours, because we're talking here about patients in the very early time window, the fast progressors, the ones who don't have good collaterals, those are the targets of this direct to angio approach. Well, it turns out now, based on all the studies that have come out, that even those with the largest infarcts still benefit from thrombectomy. So there is no reason to know what the size of the infarct is. It's a prognostic sign, it's like age. Your large infarct, it's going to do poorly, but if you don't treat them, you're going to do even worse. So we should treat everybody within 6 hours without concern about the size of the infarct. So if you think about what's the reason to do imaging and delay all this care, is just convenience. It's just to not treat patients. That's really the reason. And because of that, we're wasting 30 minutes at least in those vast majority, because you're not going to take everybody. You're going to take patients who have a high likelihood of large vessel occlusion, people who have an NIH stroke scale score of 10 or greater and are within the early time window. And I think this is going to be a positive study. Sorry for the long ranting, but it's something that I care a lot about.
It's funny because if you talk about this internally, if you just look at what we do, right? Those that come through the door downtown or those that come by transportation. So you know your delta, what you're gonna save in time right there. Because those that come from elsewhere where the image was down, your door to puncture is 10 minutes, 8 minutes, 7 minutes. For those that come through the ER, that number brings that up to 41 that Nima just showed. So I think that again, the time is going to be saved 30 minutes like they show in Spain, but it's going to be interesting how that translates in results. Marcelo.
Yeah, very nice presentation. The reason I want to make a comment is because I'm coming from another country and from Brazil. And this beginning of the year, we get a meeting with the emergency medical system to try to implant this in our city. Actually, it was another city. And the biggest challenge we had was not money, investment, ambulance, whatever, was personal. People believe in that and make fast transfer. So when you said that people go to the hospital to be taught and everything, I think that's the most important thing. I would like to ask you, how was in the beginning? Do you think it's a real challenge in getting people involved on that?
I'm sorry, the question again, please.
The question is, how was in the beginning when you started the strokes emergency system here? Do you think the biggest challenging was get people involved on that? Because that's our biggest challenge down there.
No, it was, you know, and if you look at our protocol, stroke is probably the most complicated protocol amongst all of them. More complicated than STEMI, more complicated than trauma. I think part of it came from, our leadership and really even the hospital collaboration, that we made it a priority and had subject matter experts come in and say, this is what's helping, this is saving people. This example of the video where you show somebody with a disability and after a procedure, that disability is gone. That firefighters, you can vouch for this, they're visual. And so if you could show them videos like that, and that this is based on your intervention, it goes a long way. We can talk all about, things and, PowerPoints and what have you, but a video seeing somebody who can't move, they're paralyzed, they can't, focus, but after a procedure, they're moving their extremities, they can go back home and function. That means a lot. And I think, we all went into this profession to help people. And what better, example of helping people. And so I think, there was some resistance initially, but it takes time, and some of the older guys, hey, we never do it like that, or, but it's repetition. And, the leadership has to be strong, that this is what we're going to do. So.
Thank you.
Hi, I just wanted to say to your question, sir, that I've worked in a couple of different states, and I will say that the transition for an EMS perspective, I've been doing this going on 20 years now in different areas. And I would say the buy-in here and why Jacksonville works so well is actually because our providers here were so forthcoming in saying, just call a stroke alert. I think that was some of the hesitation for us because we're very ego-driven in the EMS field, where we don't want to make a mistake. So we were hesitant to call them, and we would get there and say, oh, maybe we think it might be. But I'd say the big shift for me, at least, and for my agency, was having the stroke team say, just call it. If you're wrong, it's okay. We'd rather be activated, more so than not. So I think that was a big shift for us as well in the last less than 10 years, where they said, no, just don't be nervous. Just go ahead and call it. If you think there's even a suspicion, activate the team. We can always downgrade it if we need to. So that was a big change for us as well.
Yeah, that's interesting because that's the reason. I had experience with when they brought people supposed to be stroke to the hospital. It was not a real stroke, and we told them, no, it's not a real stroke. We're not going to intervene or do nothing. Don't they get very disappointed? And next week, nobody came into the hospital. That's the point. Yeah.
Excellent conversation, discussion. Thank you again, everyone, for being here. The food and there's beverage outside, so please enjoy.
And again, thanks for coming, and we appreciate your collaboration. Thanks again, everyone.
Hey, Omar, can you hear me? Omar, are you there?